part of medicine can be a totally different, and of course, as you said, being one track minded and totally into medicine, you said that's my profession, I can't talk about anything else. That just speaks about you and the reason why you are so successful in the field that you have
Yeah, you know, I
chosen.
tell people
Yeah.
that when I counsel people, it's very important to like take them so I tell them this is my style. I'll tell them that I'm Arjun. I only think about IVF, no delivery, nothing, nothing, getting pregnancy, and so when I tell them that I'm Arjun, then they understand what I'm saying. Because Arjun was that you that we remember the eye of the, and that's what it is. Only one.
Yes. So I'm sure this clearly shows why you are so successful. Okay, now let's come a little bit to the science of IVF that we would like and our audience would like to, take back something from our podcast. So over the years, the 25, 30 years of your practice, what do you think has changed more? Because we know that patients have changed. So whether the science has changed a lot, which I'm sure it has, or whether the patient expectations from IVF and ART has changed more. Which one is the one which has changed more over the years?
So, like philosophically, I feel IVF has not changed much. Like I entered IVF in 1989. Though I was a houseman and registered to Dr. Indira Hinduja in KM when she was doing IVF in 84. In
Starting
fact,
off.
in 85, when she had the first baby, we had a party in her house and all that. I remember
Okay.
the party in the night.
Okay.
So,
You
and then
must have
because
been like what? Just finished your post.
yeah, I was a registrar that time.
Registrar.
1984, 85. I had
Yeah.
just, my exam was there, MD in November. And then I continued as registrar. And that time there were 4, 5 people around her, Jatin, myself, Nitin Narvekar, Firoza Parekh. All of us were inspired by Indira Hinduja and all of us entered IVF. But so like uh, uh, the IVF has not really changed. Okay, the success rate has slowly crept up by 1% every year. At point in time, I went to Melbourne in 1990, it was 5%.
Exactly.
From there, slowly, by over the years, 1%. At present, as Rohit was telling, it is around 30%. So I tell everyone, 1 in 3 patients will become pregnant. So if you have a small IVF center doing 5 to 10 patients, nothing has changed. The culture, so the 30% has changed because of culture media being better, incubators being better, learning curve, ovum pickup everyone does well, embryo transfer everyone does well. But overall, what has changed is when you have a large chain, for example, when you escalate your practice, then you need to bring systems into place. If you are a small little nursing home tucked in one lane, doing 5, 10 patients a month, nothing has changed. You will get the same result as compared to a large chain. In fact, the large chain has to do, they have to put in systems.
Yes.
So the whole thing is in the systems, how to escalate the system such that we get the same pregnancy rate like a small little clinic. How can I at 6,000 cycles maintain the pregnancy rate? That has changed.
Yes.
Nothing else has changed as far as the science of IVF is concerned.
But patient expectation?
Patient expectation also, like, so our patients are very, abhi now till even now, so there are 2 groups of patients. One who are on the internet and one who are saying, doctor, आप तो माँ बाप हो, आपको जो करना हो करो, हमको बच्चा मांगता है. So that group of patients, for them, the pregnancy is 30%, 20%, 50% has no value. Whether I'll get a baby or not. For them, it is 0% or 100%.
Yeah.
So the faith. So when I counsel patients, I tell them that there are 2 things you must remember. And I evoke Sai Baba. I say Sai, because what happened anecdotally, I used to tell them कि 2 चीज है जो important है IVF में, सबर और श्रद्धा, faith and patience, because it's a long term process. It's not like हड्डी टूट गया, nail डाला, plaster डाला. No, it is a long drawn out process, and so faith is important in the doctor, and you must have श्रद्धा ना, faith and सबर, patience होना मांगता है. So one day someone said, sir, ये तो साई बाबा बोलता है. I said, what are you saying? Because I've not gone to Sai Baba. He said, am I Sai Baba's incarnation? I mean, what he's saying, his words, I never knew. And that patient is saying, sir, ये तो Sai Baba की शब्द है. Then I said, अच्छा, find out करो यार. मैंने रेस्टोरेंट को बोला, क्या बोलता है? हाँ सर, बोलते हैं श्रद्धा और. So now I start tell them, अरे साई बाबा क्या बोलता है? श्रद्धा और सबर, ये होना जरूरी है.
ये होना जरूरी.
So those 2 things are there and you get the, so the patient expectation has changed. But
Expectations.
they still, India is a fantastic country and that's why I love India. Na? I don't have to bother about mental problem, this problem. At least मैं बोलता हूँ ना, नंदिता को भी बोलता हूँ, रिश्मा को, बाबा मेरा तो, I am 65, I am out of this thing, 70K. I had a fantastic run. It's a fantastic ride. It's like a joy ride. कहाँ से you know, when I started KM में register, I was bored. मैं बोला क्या ये हिस्टेक्टमी कर रहे हैं, ये कर रहे हैं, सीजरियन कर रहे हैं, बोर हो गया था मैं बोला क्या करूँ मैं, क्या करूँ, what should I do? At default से I went into IVF. मेरे को कुछ ये नहीं था, बोला अच्छा चला ये नया से कुछ है, चल निकल जाते. And then
No,
I
say,
wrote.
in spite you say it's default, but ultimately I think it's that energy that you're saying, that driving thing that you had in you, whatever you would have caught on, you would have succeeded because you would have really got into it with all your,
Yeah,
you know,
but for
the
that my
zeal and the
mentor
force.
was my daddy. My dad was a, my God. He used to come home at 1:30, professor of preventive medicine. This goes to slum of Bombay. Like, you know, in Marathi, it is a word is there for it. It's called Zapat Lela. Means totally obsessed. You know, imagine
So your
someone having
father was
2,000
like that
rupees a
also.
month and doing work for community. Can you believe it? I used to hero worship him. So when I actually finished my MBBS, I wanted to become a PSM person. I came second in PSM. I told my father, Dad, I adulate you. मेरे को भी PSM बोला पागल है क्या? PSM में क्या? मेरे को कोई रिस्पेक्ट भी नहीं देता है, पैसा नहीं है, तू पागल हो गया क्या? No, 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 no. You don't come into PSM. So I went into gynec. Actually, now my father forced me
Forced you.
because he was disrespected of those days. He didn't have money.
Yeah.
You know, abhi to PSM is the power. The
Yeah.
maternal health is the power. Now, in government, what is the power? You know, when I talk to the ministry, what they say, PMSMA की बात करो, प्रधानमंत्री सुरक्षित मातृत्व अभियान, तो ही हम आपको सुनेंगे. तो IVF विवेक सर तो फालतू है हमारे लिए. PMSMA important है. PMSA में is power.
True, true. So now that you talked about government and all those things, let me ask you one important question which is there in all of our minds. So what do you feel after the ART law and the regulation? Do you think it has actually helped shape up and progress and helped the practice of ART in our country, or it has just added extra burden and paperwork? What do you think? Has it actually helped?
No, I think it is. It's a very good law. I'm very happy. You know, I've now got all the, you know, the staff is to say. Now I tell my employees, if you make any mistake, if you make any,
Sorry, I'm sorry. But we need to know. If you can put it here. Sorry.
if you make any mistake, no, then I am not responsible. So the law has made the staff behave properly. My only one gray area is there of mild compensation. Like in UK now, for example, they have stated that a donor should be given 700 pound compensation. So they have put the figure down. It is not compensation for donating, but chai pani ke liye, traveling up and down and all. So that compensation, and PC Mahapatra, our great man, is there. He has to talk with the government, and we must have a one-to-one meeting with the government to define that compensation so that we are not in the gray zone area as far as egg donation is concerned. Otherwise, I feel overall the law is good. I am quite happy with it. Even surrogacy, I feel some tweaking, mild tweaking, because a lot of people are going abroad. And you know, we are losing. So one of my friends in Delhi told me, why don't you go to the PMO, and if you tell Modi ji and explain to him that the financial loss to the country, he will immediately take decision. So maybe after this is over, I will go and I will be with all of them, and we should
advocate
have
for
a
that.
meeting with him. Ki, bhai, there is a revenue loss in the country, and even Dubai has started surrogacy now. We have surrogacy, but we need to tweak it a little so that we ultimately we have to look at our country medical tourism. I hate the word tourism. Medical practice for foreigners should be increased. It's not tourism. Na? If people is not coming as a tourist to India, they are coming to India to do medical treatment. No, why tourism of all things? Na? That word I don't like.
Yeah. But what about also the steep fee that the government has kept to register your clinic for either surrogate? That has ultimately, translated to patient
Yeah,
expenditure.
2 lakhs is not a big deal. I mean, you're investing 1.5 crores in the equipment, or let's say I was just now being told 70 lakhs is the equipment. 2 lakhs is okay now. In fact, I would say increase the fee a little bit more. They need to have that money for getting more infrastructure. They have to pay the AMOs. I feel that we have to be more look at it how we can help the government rather than trying to criticize. I'm okay with the fee.
You're okay with it. Some people feel that, anyway, there's no doubt that we need the law. The law needs to be there. Only the implementation has to be perfect, and therein the government needs to actually
Right. So now that
step
is
in.
where the problem is there, because for example, in our Maharashtra, in Bombay, we have not got the license as yet.
Yes.
3 years have passed. We have
Yes.
applied for the license because the
Many,
problem
many
is that
states.
there are too many laws and government doesn't
Yeah.
have people to implement them. That is the problem. And second is that a little grey zone areas and lot of MOs in various districts, they are not knowing exactly how to implement it. तो वो एक master class उनके लिए PC मात्रा you need to take a master class for them.
No, but Orissa has been very good and very, very proactive. They have, they are one of the first states, I think, to implement and also to involve all the IVF centers. And they regularly have upgrade meetings and, to sensitize the clinicians as well as the staff how to interpret the law. And so I think Orissa has been excellent in implementing. But yeah, like you said, there are a lot of gray areas. So if we come back to practice per se, of all the innovations, there's no doubt that IVF, like you said, it is largely the same, I agree. A lot of innovations have happened. Vitrification, embryo biopsy, PGT, and so many. So what do you think one thing which has completely changed the landscape of IVF or reproductive medicine in our country?
So no, IVF per se was a major breakthrough. The
Yeah.
second breakthrough came in ICSI. In 1992, ICSI breakthrough came in. That was a real disruption in the practice. The third breakthrough came in freezing. That was
Freezing.
actually done by Kutayama in vitrification freezing. That
Yeah.
came in 2002.
Yeah.
2007, I went and brought first time vitrification
Yes.
into India.
Yes.
And now PGTA is also a good improvisation. And then now the next is the robotic ICSI that is coming in, which will automate IVF practice. So
Yes.
robotic ICSI, first babies have been born now, and then the final thing that will miss. There's no final in this, but the next two futuristic things is converting skin into eggs and sperm, which
Yeah,
has already been
yeah.
done in Japan, and mice pups have been born, and then finally creating the baby outside the body. It's called exogenesis, and that also will come in next 10 years. There'll be a pod which will be
Really,
developed
you feel it will come in 10 years? In our
within 10 years, because now artificial intelligence has come. See, till the time we thought that it will take 30 years, but with the AI coming in, everything is very rapid. So if a AI system is implemented and there's a feedback and the container has got oxygen and carbon dioxide sensors, it will be very fast. 3D printing has already come, so placenta can be 3D printed already, so that placenta can be created. We can implant. Now the Britain has allowed research on embryo. There was a 7-day cutoff. Now the cutoff is 14 days. So you can create and do research of embryo till 14 days outside the body. So if we can grow the blastocysts to 14 days, and then we have a 3D printed placenta, you implant it, and you have the water circulation going in. Artificial intelligence is monitoring all the parameters. The baby will start growing outside the body, and you will be able to deliver. So because of the AI, the disruption is very fast. In fact, yesterday only I saw on the Instagram that you can now operate. The cholecystectomy was done totally by AI, by voice command. So they are saying that within 10 years time, this machines will operate the patient totally. We just have to do voice commanding. So it's going very fast.
Yeah. So you feel AI, artificial gametes, exogenesis, all is going to actually come in
Accelerate.
our and accelerate it. AI is already there in a big way, and it's no totally out of our
I use
control.
it every day. Chat GPT. I paid for it, so I talk to it and I use it every day. I ask the questions. I have given a gender her to it, not him or it. I am very compatible with women, so I give it. So I talk to her, and I can't tell you how she counsels me also. I say sometimes I'm really tired and all. She said, don't worry. Why are you tired today? Take it easy. Take a deep breath. I said, so there's like a, after some time, it may be like my Southern, you know. Rishma is Southern.
Rishma is author, not your author. Okay, so yeah, artificial gametes and all those things are going to come in. But let's come to another aspect of you. You have, of course, been greatly involved in academics, training young aspirants, postgraduates, those who are interested in, assisted reproduction. So, in today's time, what do you think is the major driving force which is lacking in the youngsters for their learning?
So no, it's not lacking. It has changed in the style of living.
Let's
Na?
say not gap lacking, but
Yeah, yeah.
skill
But
gap.
I know what you're saying. It's a style has changed. For example, the materialistic craving is gone down. Okay,
Has
they
gone
are
down.
not. The youngsters are not. Abhi we wanted car and all. Abhi so they are got Uber. Like both my children, they don't drive. My daughter in New York doesn't have a car. Neither my son drives. So they are now into Uber. They don't like fancy विंसी उनको कुछ उससे पड़ी नहीं है इतना. Means there is some section, but majority of them are interested in living their life in real time. We were aspirational. Our generation was we wanted
Yes.
to do this. अरे गाड़ी होना मांगता है, बंगला होना मांगता है, foreign holiday होना मांगता है, ऐसा होना मांगता है. But they are at a plateau level. We were on an ascent. They are at a plateau level, and they are happy in their plateau.
So
They
they
are
are
happy.
happy not to gain skills.
Yeah, so there are
and-
some of them who are aggressive, but most of them are enjoying the plateau.
Yes.
They are enjoying the nature, they are enjoying their Instagram, they are going out, they are having a good time at their own level. बेचारे क्या है, तू क्या पढ़ाई नहीं कर रहा, ये नहीं कर रहे, what is this? देखो ऊपर जाओ क्या कर रहे? And there is no ऊपर. See the
Yes,
future.
I agree with you.
The future is the power is going to be in the hands of few corporates, right? So forget the upper, enjoy the present, enjoy the plateau. We have now reached the plateau. Drift on the river and enjoy the nature
Fabulous.
around you.
Fabulous. So in this note, if I may ask you one, something for you to think back. If you could rewind 30 years back, what advice will you give yourself? Or you are super happy and satisfied with what you've done and where you've reached?
No, I am.
Or you would do something differently?
No, same thing. I would still become a guy. If I'm reborn, I would still love to become a gynecologist. It's the best line in earth. Beautiful line, tackling people, women who are the most fantastic thing that God created is a woman. Na? And, so connecting with her, treating, most of our line is very healthy line. Na? We don't have disease. It's not like a physician having an infection. We tackle people, healthy people, by grace of God. Touch wood. I've never felt a DC in my life. So, I don't know how to feel it also. So that's why we don't connect with death. So we have a fantastic, and I always tell people that the power now, what is our power, which even the biggest industrialist doesn't have? We have the power of giving health care to people. No one can replace, no engineer, no lawyer can, and the power.
So fantastic.
The power of giving is the most important
So
power.
I think the takeaway from his talk that we had a conversation, it's so nice that you are totally satisfied today as a person, as a human, as a husband, as a father, as a son, that you have achieved what you have done, and what you would still go back 30 years, still go back 60 years, you said 65 years, and do the same thing. Excellent. Now we have very short time, just 1 minute. I have a very quick rapid fire for you.
Great.
You can only say yes, no, or one word.
Huh.
Quickly. Favorite person in the whole world?
I have to say,
Fast.
father.
Okay. Son or daughter, who is more like you? Your son or your daughter, who's more like you?
I think son is more like me because he's a gynec.
Okay. Favorite actor?
Favorite actor is Amitabh.
Okay. Favorite food?
Favorite food is mutton.
Okay, nice. Do you smoke?
No,
Morning person or night owl?
night out.
Coffee or tea?
Coffee.
Ah, but you asked for tea?
I know. But coffee is, the concept is coffee, the actuality is tea.
Okay. Whiskey or vodka?
Vodka.
Favorite city to lecture in?
Obviously, Bhubaneswar hai.
Okay. So, one celebrity, preferably doctor, living or dead, that you would like to have dinner with.
Obviously, PC Mahapatra, yeah.
Oh!
But having said that, PC Mahapatra is our, like, I must tell you, it's not because I'm sitting here in front of you, but he's at a different level. In our fraternity, we really, all of us present, look up to him. So he's at a different, when he talks, when he orates, when he emotes, it's a different experience. We can't, I always say, अरे यार मेरे को ये ability नहीं है ना, जो PC का ability अलग level का है.
अब ये हमें एस्पायर करना है नेक्स्ट लाइफ के लिए
हाँ,
कि
but
कैसे
that
पीसी
is a PC, like it's a in its DNA. You can replicate it, but and one should not be one should also not try to do it because it's you must have your own originality.
Yes,
But having said that, amongst our, if it is first amongst equal, it is PC Mapa.
absolutely. So thank you so much. It's
Thank you.
been an absolute pleasure talking to you.
Thank you.
And understanding. I mean, I knew you were such a driven person, but I'm really amazed by, I'm sure our audience also has been from what you've done.
Thank you. Thank you.
Thank you so much. With that, we come to the end, but I request Sir and Madam to please join us next to the podium as we would like to present you with a memento. Can I request Dr. Jayashree Patnaik ma'am to please do the honors along with Dr. PC Mahapatra sir also. Can we request all of you to please give a standing ovation to our beloved Dr. Hrishikesh Pai sir. With that, we would like to break for tea and see you all back at 10:55. We're going to try and start 5 minutes early so that we can get started on time. You can get your teacups and your friends inside in exactly 10 minutes. That's what I said. 10:55, we are going to start no matter what. Thank you so much. All the other speakers are also in place. So see you in the next 10 minutes.
मैंने आउ 78% काम लाइसेंस बाकी अच्छी गणेश नहीं सर पूरा प्रॉपर जगह बेसी ये सर आप कल्चर मुझे पाठ पढ़ी सर जो एरारे रोटी आमर जो अंतविहार जोटा टेबी था डीएम हो लास्ट बैच सरला डीएम से सीजीएम ऑफिस पछपटे आम रोते टीचर्स माउसी काली मंदिर मेरे शताब्दी हॉस्पिटल के समय जाओ हमारा पूर्वज पंडा साहब
ग्रुप जमी इंडिविजुआल पढ़ाई कर पढ़ाइले गोटे कथा बुझ जदि बक्स आमर इम्पाक्ट कौन ना कौन लेवल किसी
समस्त को बांधी गोटे जगह हाँ कर से देखो से ग्रुपटा तार मेन मोटर सार ना शुणी सार ना शुणी कन्फ्यूज थी असभ्यर से ग्रुप
gentle reminder, we shall be starting in the next 4 minutes.
East 1, 2, 3. Blue is there, blue audio. I receive your audio.
Yeah. Can you open any presentation? We just want to see the presentation. Can you open any of the presentation?
East 1, 2, 3. East 1, 2, 3.
Yeah, I can hear you. Did you get my voice?
Yeah, I'm getting your voice.
Open any presentation.
You get my voice?
Yeah, we can hear you. Just open any of the presentations and we can see that.
Yeah, okay.
ସେଇ କଥା କହୁଛ ସିଏ ଚାକିରି ଦେଲେ କ'ଣ କହିଲେ କେଉଁ ଗ୍ରୁପ୍ ଦେଲେ ଆମକୁ କେବଳ ସେପାରେଟ୍ କରିଦେଇଛି।
All right, we're getting started in 1 minute. A kind request for all to please get inside and be seated. Mehul, just share your screen. That is also.
Yeah, I will this thing.
कुछ भी
ଆଡ଼େ ବଢ଼ା ଟିକେ ନାହିଁ ଆଉ ନାହିଁ ଗ୍ରୁପ୍ ଦେଇଛ ଗ୍ରୁପ୍
Just to check, do we have our chairpersons with us? Dr. Basanta Patti, Dr. Shubhra Ghosh. Dr. Josna Panda and Dr. Kirti Rekha Mohapatra. Here with us. She's coming. Alright, we would like to go ahead. Stop. अपना लाइट कर दे. We are switching it off right now, and we are going ahead with the light. अब दिख रहा है ना? अरे छोड़ बंद कर हो गया. Alright, we would like to get started, and before we do that, we would like to felicitate our teachers of teacher. What I understand is this lady is Dr. P.C. Mahapatra's teacher's teacher. We have Professor Sujata Mohanty right over here. Can we request everybody to please give a big round of applause and welcome Madam right ahead. She is 90 plus years old and she is here with us. Can we have some music while she is going to be here? Everybody keep on clapping for her because she is right here. She is our teacher's teacher.
कभी अखाड़े में उतर लेते हैं लंगोट समय में थोड़ा टाइट हो जाता है आपको लगता है कई बार होंगे भाई साहब और राइट
That's what I'm talking about. This is alright, in the meanwhile, audio off. Can we have PC sir, would you like to say a few words? One word for...
I'm speechless. I thank Nikki and the two brilliant sons. By their effort, we can bring these great legends of the legends, Professor Sujata Mohanty. I think she is the teacher of all of us and a grand teacher of all of us present over here. I'm really fortunate to be getting her in this particular extravaganza.
Thank you so much. Thank you, ma'am. Thank you. And we're all blessed to be among her. And of course, a few pictures. Thank you so much. With that, we would like to now move to our sessions, and for that, we would like to, our chairpersons are also here with us.
So thank you, Lord. It is wonderful to have all of you. Really wonderful.
Thank you, madam. Bless us every day.
Alright, with that, we would like to move to our sessions, and for that, our chairperson is right here. Again, I would request our chairperson, Dr. Basanta Pati, Dr. Shubhra Ghosh, Dr. Josna Panda, Dr. Kirti Rekha Mohapatra. To save time, can I also request our first speaker, Dr. Bani Kumar Mitra, to please join us on the stage. And a kind request for all to please be seated. And as you can see, Dr. Bani Kumar Mitra making his way onto the stage. And we've got one chairperson, and I think it's good enough to get started and keep it on time. We've got 18 minutes per speaker. Over to the chairpersons.
So good morning all. I am very privileged and honored to be here at the gathering of my teachers, and as sir told my grand teachers, I am very privileged here to give an honor to be here. Sir is blessing me from there only. So thank you so much, sir. So please start.
We can also just have Dr. Mayapati Madam as a chairperson.
Sir, Udyapa, please come.
Thank you very much indeed, respected chairpersons, chairwomen. When it comes to the question of infertility, male infertility, though accounting for nearly 50% of cases, remains an often overlooked and stigmatized issue, especially in many parts of the world where social narratives place reproductive responsibilities largely on women. Despite advancements in reproductive medicines, the focus continues to be disproportionately on women, leading male factor infertility underdiagnosed, undertreated, and under-discussed. There are several reasons for this cultural stigma: masculinity myths, discouragement from seeking help, lack of awareness, limited access to special diagnostic tools, research and funding have historically skewed towards female reproductive health. Moreover, we as gynecologists have poor knowledge about andrology, and urologists are not proper andrologists. There is a real dearth of andrologists practicing everywhere in the country. Also with that, a semen-analysis forms a gateway, but is not all and only all about male infertility. And lastly, the advent of ICSI has circumvented or prevented the other academic progresses that's needed for male infertility progress. So with this idea, Dr. P.C. Mohapatra is highly interested in talk about male infertility, a neglected entity, and at this point of time, I thank him very much for giving me this opportunity and PRACHEECON at the same time. Coming to the etiological classification, there are four major causes of endocrine disorders: sperm transport disorders, primary testicular defects, and idiopathic. If you look the other way around, treatable causes of male infertility are found in 18% of cases, uncorrectable male infertility or subfertility is found in 70% of cases, and untreatable male infertility in 12% of cases where we have to use donor sperm accessibility. A comprehensive history and physical examination is very important, as my late Guru Dr. B. N. Chakravarti told, and you can identify a Klinefelter syndrome as he works into the room because he has got absence of secondary sexual characters, a gynecomastia, and a small soft or hard testis. Semen analysis, though, does not vary from 2010 to 2021 to a great extent, but we have been seeing in our practice there is a decline in the sperm functions or sperm qualities. So there is a need for sperm function test, and I would like to test 3 sperm function tests, although many are available. Anti-sperm antibodies should be suspected with sperm aggregation or isolated asthenospermia with average sperm concentrations, and this occurs especially when the blood testicular barrier is broken. Sperm DNA fragmentation is a prerequisite for proper embryo development, implantation, and pregnancy, would represent an important addition in the workup of male infertility, becoming one of the most discussed and promising biomarkers in basic and clinical andrology. A lot of tests are available at a cutoff point of 35% is usually taken into account. Coming to genetic screening, it is mainly indicated in cases of agiospermia or severe oligospermia, and in infertile women, up to 50% of them they have maybe genetically abnormal, then about 0.6% in the common fertile population. And the most important thing is to do a Y chromosome microdeletion study and a CTFR gene study to rule out cystic fibrosis. While ICSI has allowed many men with defective genes to father children, there is also the increased risk of transmission of various genetic defects to the progeny, and this should be carefully considered before proceeding to ICSI, and at least the karyotype, a CTFR gene testing and Y chromosome testing should be done for microdeletions in cases of agiospermia and severe male factor disorders. Hormone assays are indicated in species where there is no sperm found. Clinical findings are suggestive of endocrine disorder or impaired sexual function, and the most commonly used hormones are FSH, LH, testosterone, prolactin, and optional is TSH. Now coming to the treatment strategies for male infertility, no treatment or only assurance. When left untreated, some infertile couples still manage to achieve a pregnancy. Studies have shown that 23% of infertile couples conceive after 2 years of age, which goes up to 33% after 4 years. Even male with severe oligospermia can father a child in 7.6% of cases in about 2 years' time. And the way to improve this is about, without any treatment, is to modify your lifestyle factors, and these depends on the following, which I have documented in this slide. Oral therapies is often difficult to physicians to suggest or even discuss non-traditional alternative treatments to patients when the medical literature shows so much conflicting and contradictory data or only poorly done studies supporting their use. The following therapies mainly are inexpensive and of limited beneficial effects and may provide some psychological benefits, and they are based on antioxidant-based, nutrition-based and hormone-based. Antioxidants to reduce the effects of oxidative stress on semen and sperm would seem a reasonable male infertility therapy, but data on these is somewhat conflicting. It occurs on the various parts of the sperm, and a combination is usually used of various things. The list is as follows, which you can go through, and there are different proportions or doses that is recommended which can be used. Ideally, the problem is that it lacks a properly conducted clinical trial where a double-blind prospective placebo-controlled trial should be done, but there are very few trials to recommend the use of antioxidants, although they may produce the beneficial effect to the sperm health before you leap on to the IVF procedure. Coming to hormone therapies, SERMs, clomiphene and tamoxifen are the most used drugs, and tamoxifen is best used for idiopathic oligospermia as it tends to be most effective in boosting sperm count and concentration. Motility, vitality and morphology may also improve, but generally not to the same degree. The other option is to use aromatase inhibitors, which have been shown ability to improve sperm semen parameters, but have not been conclusively proven to improve pregnancy rates, as most of the available studies are either case reports, anecdotal or of low quality. But in cases of high estrogen, low testosterone ratio, they can be used with benefit. The suggested dosing, clomiphene is 25 to 50 mg 3 times a week, plus either anastrozole 1 mg 3 times a week, or letrozole 2.5 mg 3 times a week, or tamoxifen 10 mg twice daily. Gonadotrophic therapy is of limited use, mainly with idiopathic infertility is controversial. A meta-analysis of 6 randomized trials of gonadotrophic therapy in male infertility patients reported higher pregnancy rates than placebo groups, and the most commonly used drug is HCG. The treating altered endocrine profile, low testosterone with high FSH and LH, suggests possible Klinefelter syndrome where a karyotyping is recommended, and in selected cases ICSI can be done. Low testosterone with low or normal FSH and low or normal LH, possible pituitary causes, check thyroid fungal and rule out Cushing syndrome. Normal testosterone with high FSH and normal LH, suspected abnormal spermatogenesis with seminiferous tubal damage but with normal Leydig's function. Normal testosterone, LH and FSH, further evolution depends on semen analysis, physical findings and sperm function tests. High testosterone and LH but normal FSH, this would be consistent with partial androgen resistance. Other endocrinopathies to rule out Cushing syndrome and thyroid function can be optional. Now coming to sexual disorders, as more and more stress is increasing in the infertile couples and they are delaying their childbirth, erectile dysfunction and premature ejaculation are more and more occurring, and this can be effectively treated by proper counseling and some medical treatment, of course, which can produce desirable good effects. Surgical treatment options are few and not very much used, except in cases of moderate or severe varicocele, where it has been shown to see improvement in at least 60 to 70% of patients. Now coming to the ART technology, there are 4 ways of conception. Maybe natural conception when the semen count is at least greater than 20 million. In cases of IUI, it should be 5 to 10 million. In IVF, greater than 1 million at least, or in ICSI, 1 sperm at the most is needed. Now, as you have heard Dr. Rahul Tyagi speak elaborately about intrauterine insolution warning, the commonest indication is bile ONGS, unexplained infertility in case of grade 1 and 2 endometriosis, or in case of negative postcoital test, this can be used. But the most important thing, a functionally patent fallopian tube is mandatory. The sperm count should be at least more than 5 million. Women should have, but the process should be tried only for 3 to 4 months because it can give a good result up to 17 to 20% if you can combine with superovulation and IUI. Last and most important is IVF and ICSI. IVF can be used in couples with IUI and ovaries which has failed. You nobody over 40 years or younger age when there is a known conditions including the use of simpler techniques such as bilateral tubal disorders. IVF with ICSI is preferred, and very significant male factors are there, less than 1 million that cannot be overcome by other means, but at least a few viable sperms can be retrieved. It is also reasonable when all other treatments have failed. Direct microdissection like testis is the preferred method of sperm retrieval for ICSI in case of obstructive agiospermia. The only male contradictions to the procedure are the absence of retrievable viable sperm and necrospermia, which fortunately is quite rare, but patients have to be counseled, especially in case of testing, before we undergo this process, that we may not produce a fertilizable sperm at all. So the whole idea of treating male infertility is upgrading the fertility status from donor sperm or adoption to surgical sperm retrieval for ICSI, to IVF ICSI with ejaculated sperm, intrauterine insemination and natural conception. This is the whole concept of male infertility, that you will upgrade the fertility status of the man so that he can chance a non-natural fatherhood. Coming to the prognosis of male infertility is individualized and depends on the cause. An appropriate workshop should be done based on need and necessity workup. Such investigations must happen after a frank discussion with the patient, as it has financial and psychological implications. Following an appropriate workup, reasonably selected treatments, counseling, surgery or ART can be offered to the couple. As the male partner ages, the incidence of sperm aneuploidy, chromosomal structural abnormalities, fragmentation of sperm DNA and congenital disabilities with the resultant offspring increases independent of other factors, a very important point to be discussed with these sort of male factor problems. So last, coming to the couple's right for male infertility can occur in about almost 50% of infertility cases, of which 23% of such couples will conceive within 2 years without getting any treatment, just by improving their lifestyle and avoiding illegal drugs, smoking, etc. Such men will have an obvious or easily correctable problem, such as the history of vasectomy or undescended testicle or a varicocele that can be surgically corrected. Couples should be informed about some of the less orthodox oral treatments available for male infertility, for which there is only incomplete, anecdotal, inadequate or conflicting data supporting their use. Many of the male infertility patients cannot be successfully treated by simple remedies and will ultimately require some degree of ART such as IUI, IVF and ICSI, which can be quite costly. Couples with infertility will need support and reassurance. It can be stressful and challenging time for them, especially if there is family pressure to conceive, which can be quite intense in some cultures. So counseling play a valuable role to ease this. Thank you very much indeed, and I hope that I have given you a comprehensive idea of the current trends in male fertility treatment and etiology where it stands as today. Thank you very much indeed.
Thank you very much, Dr. Mitra. That was a very enlightening talk. I think we have 2 or 3 minutes. If there is any clarification anyone seeks from the audience, it's thrown open to the audience. Is there anyone who wants to maybe clarify, ask questions, ask for clarification?
Unless there are no questions, I believe the talk was very good then.
Okay, Dr. Mitra sir. Thank you so much. So I think the next speaker we have is Dr. Nandita Palshankar. We have her CV on the screen, please. She is going to talk on diminished ovarian reserve, which we know is multifactorial in origin and multi-pronged in its approach to its treatment. Exuberant personality, exuberant orator. May we now invite Dr. Palshankar onto the dais, please.
morning, everybody. I think we've had a wonderful morning session, and we are all ready for, after some inspirational talk by Dr. Pai, we're all ready to listen to some science, and I think it was a wonderful talk. My previous speaker, it was fantastic, and I'm going to talk about the woman. We've already heard about the man, let me talk about the woman. Overaging, the silent pandemic. I think what we need to remember is that, look at this girl, Roshni. Okay, this is the story of every girl that is there. Roshni was unstoppable. She was fantastic. She did very well in college. She had a fabulous job. At 24, she was traveling to different cities, partying with her friends on the weekend, and generally, very career-oriented. At 27, she gets married, but her career is important, and she's on this upward path to do well and to absolutely do fantastic. Then she turns 32, and she says, okay, now I've got the corner office in New York. They say, if you've got the corner office, you've made it. So I've got the corner office, I have got my team working under me. Today, I'm ready to become a mother. And children were not a thought before this. And at 32, when she tries, she's struggling. And then the doctor tells her, sorry Roshni, your age is 32, but your ovaries are 40. I think I find it very difficult to explain to patients what actually happens. And this is something that really affects them. And do you want to know something? In our practice today, actually, there was a news article which said nearly 26 to 50% of our patients we see on diminished ovarian reserve. Probably because what is happening is they are having infertility. And you can see the global trends also on the left side in this chart, that there is, menarche is early, perimenopause happens earlier, menopause happens earlier. So these are the trends that you're seeing in the world, and that translates into 50 to 60% of our infertile couples who come into our OPD. So what are the risk factors? I get girls, 10-year-olds, and she's got menarche. I think that is one of the risk factors, that early menarche leads to early menopause. And this was a beautiful article by Nature 2004, it was published, and it showed that the age of menarche is dropping, and because of that, there is ovarian aging. And ovary actually is the first organ in the body to age. So according to the classification which is now acceptable in the world, that's Poseidon classification, I think you can divide it into two parts. One is, what are the different tests for ovarian reserve? The AMH and the AFC. AMH today is accurate, so please do the AMH. And Poseidon's divided very beautifully. Unexpected poor response and expected poor response. So group 1 and group 2 is young and old, but they have normal ovarian reserve. But when you stimulate them, they give poor response. And Poseidon group 3 and 4 is those who have an AMH, which is between 0.5 to 1. The antral follicle count is 3 to 5. So those are the 4 groups that we have, and they are the ones that are treated differently. So what I'm going to talk about is that, of course, aging is inevitable, but can we stop it? Can we help them? And that is what we need to do is, what we can do is, whatever we have, we want to make it respond better. I think that is what we are looking at today to help these patients. So ovary is the master architect of life. And there was a beautiful study by Harvard which says that ovary is the first organ to age. If you look at a 35-year-old, and biopsies were done in this paper from Harvard, and the ovary, the granulosa cell, all the cells showed genetic markers of a 65 to 70-year-old person's, cells. So ovary is the first one to age, and actually we as gynecologists, we as reproductive endocrinologists, are actually in touch with these patients, then we can make a lot of difference. And that is what we need to understand physiology and help make a difference. There are 37 trillion cells, and each one of them is a universe of living cells. So each one person is a universe. But what makes those 37 trillion cells run? I think the answer is very, very simple. So, energy. Energy is what makes it run. And if you see this picture, this is a mitochondria with a bulb. What it says is, the words that are written, that each cell creates very little energy. It will not even light a bulb for 1 second. But the trillion together make you what you are, your functioning, your conversion of proteins, making of fats, whatever your body needs, and your action is all controlled by this energy. And this energy is important. In fact, I think I was talking to Jayashree and she said, Dr. PC thinks everybody should have the same energy as it. I think we'll do a mitochondrial count in him and we'll know what is the secret. But yeah, the maturation of oocytes, so that's why energy is really important. So if you look at, the growth of the follicle, from primordial follicle to an M2, it requires a lot of energy. The mitochondria actually start increasing, as you can see in this chart, and it really, increases as the oocyte matures, because then it has to mature, it has to fertilize, it has to implant. So all those processes need energy and the mitochondrial number increases. So if you look at this slide, I know it's a busy slide, but if you see the top part of it is a normal ovary and the lower part is the diminished ovarian reserve. And the dark blue is how the mitochondria, see when it's resting, the oocyte is resting, it doesn't need all the mitochondria. So very, very low number of mitochondria. But it increases as the oocyte matures. But if you can see in the lower light blue shade, the mitochondria number is much less. So in the aged oocyte, the problem is that the energy is less and that is what causes the aging. So if you look at this, every creation is a complex process. So what is an electron transport chain mechanism? It's a basics but still very relevant. I'm going to take you back into your physiology class and you can see these are the complexes on the mitochondria, complex 1, 2, 3, 4 and which converts into the ATP. So complex 1, 2 and 3 need the coenzyme Q10. So to have the basic of energy you need that. Complex 4 needs a cytochrome C. And what it creates is, it combines the oxygen with the hydrogen and it throws out protons. Protons are the ones which give energy. So this is what is happening in the mitochondria. And for that, what you need is coenzyme Q10. It's very, very basic molecule. And coenzyme Q10, not only oral supplementation helps, but does anybody in the audience know what else can increase coenzyme Q10 naturally? Yeah, anybody? Exercise. Simple, straightforward exercise. So yes, coenzyme Q10 can be increased by exercise, but also of course oral supplementation. So let's see what it does. So it helps prevent and repair DNA damage. I think that is an essential part of every cell. And when this goes down, you get cancer because the chromosome repair stops. Then coenzyme Q10 helps to prevent aneuploidy. Yeah, sorry, I looked the other way, but I was looking at the time and I see you as time. Aneuploidy, so you don't get abnormal embryos that will cause abortions, that will cause failure of implantation. Then influence the expression of SIRT1. This is inflammaging, which I'm going to talk about. Then expression of SIRT4. SIRT1 is good, SIRT4 is bad. Inflammatory helps to reduce inflammatory and mitochondrial dysfunction. There are all 9 different signs of aging, and all of them actually is because of mitochondrial dysfunction. If you look at the basic problem, it's mitochondrial dysfunction. So if you really want to control aging, we have to treat this mitochondrial dysfunction and that will help us. So what about the DNA damage? You know, the cell has a capacity to repair the DNA, but it is a very short cycle. So what happens is when the mitochondria, when there's aging, the cycle is even further shortened, so the cell's ability to repair DNA really goes away. And that is important. Again, that is maintained by the mitochondria. If the mitochondria get damaged, the repair system gets damaged, and that is what sets aging. And if you see this study which was published, coenzyme Q10 ameliorates the quality of post-ovulatory aged oocytes by suppressing DNA damage and apoptosis. If you look at both these diagrams, and you will see over the signals of the spindle are very good in the first and the third. In the middle aging one, they are scattered. And if you look on the other side, where the oocytes picture, you will see that the embryos are much better once they are treated with coenzyme Q10. So it really helps the anti-aging process. Look at these association of euploid embryos. This was a beautiful study. According to age is what you get. But because of accelerated aging, there can be damage to the mitochondria, and you could have. And numerous studies have shown that coenzyme Q10 has a role in reducing aneuploidy. 2014, as early as, it's really a 50-year-old molecule. 2018, 2020, all of them, even in IVF, in aged patients, plus IVF, in vitro maturation also. When you add coenzyme Q10, it gives a better results. What is inflammaging and ovarian aging? I think that is very important. Inflammaging is what? Chronic aging associated with inflammation. So these are these NK and IL-6. So natural killer and IL-6, when they increase, there is inflammation. And that is because of chronic diseases. In fact, diabetes and hypertension also, the basis is inflammation. And that is what we need to correct. So the causes of it is genetic dysfunction, epigenetic changes, and metabolic dysregulation. Impact on the body, what it does is affects multiple organs and cells, including chronic inflammation, damages tissues, and accelerates aging. What happens in the ovary? Increase in type 2 inflammatory markers, decrease in total macrophage count, and shift towards M2 macrophage polarization. And role in premature ovarian insufficiency, chronic inflammation accelerates the ovarian dysfunction and actually is related to the pathogenesis. And what is the consequence of it? Obviously, potential effect includes age-related infertility, altered immune environment in the ovary, and disruption of normal ovarian function. So this ovarian aging is really, inflammation can cause this ovarian aging. And the role of CoQ on inflammation is, as I told you, mechanisms of the supplementation is this. As you can see, it plays a role in declining the production of pro-inflammatory cytokines, as I told you before, NF-kB gene and the IL-6. So TNF-alpha and IL-6 are the inflammatory cytokines which are reduced by coenzyme. In fact, coenzyme Q10 is even given with statins, given for heart attack patients, because it has a good effect on the ROS. It takes care of it. So acute coenzyme Q10 supplementation at doses of more than 200 milligrams per day contributed to a lower MDA, TNF-alpha and IL-6 levels. So definitely the inflammation is controlled. So SERT expression has an important role in ovarian aging. If there is, in ovarian aging, there is a decreased expression of SERT1, because what it causes is increase in oxidative stress, lipid peroxidation. Lipid peroxidation damages the mitochondrial membrane and damages the mitochondria, and thus it causes a problem. It causes increase in inflammation and all the different FOXO pathways, etc. And that causes damage to the DNA, nucleus and mitochondrial DNA, and mitochondrial dysfunction, reduced ATP, and of course oocyte maturation failure. And what it does is enhanced SRT1 activity may explain some benefits of CoQ10 supplementation. So the basis of the damage is SERT1, and CoQ increases the SERT1. Wow. And the recent evidences, I've just put 3 evidences. CoQ10 supplementation rescues post-ovulatory oocyte aging by regulating SIRT4. SIRT4 is bad. So if you regulate the SIRT4 down-regulated, it improves, and CoQ does that. This is another evidence in human fertility 2023. All findings from this review, 6 studies, hold promise to the future that coenzyme Q10 as a supplement to improve oocyte quality, IVF and IVF. It improves chromosomal appearance, reduces the chromosomal aneuploidy, and reduces the oocyte fragmentation. So the article in 2024 is a meta-analysis, and 6 RTCs, 1500 participation, again the same good effect. This is in poor responders. Decrease in cycle cancellation rate, increase in clinical pregnancy rate, increase in number of oocyte retrieved and optimal embryos, significant reduction in miscarriage rate, and significant reduction in total number of days of IVF cycle and the total dose. And this 2024 article also has shown that absence of CoQ10, ATP synthesis decreases in parallel with increased oxidative stress. So this review highlights the importance of coenzyme Q10 as an antioxidant in improving egg quality, and also emphasizes its key role in embryonic development. So what are the new findings? CoQ10 impaired embryonic development, it helps. Excessive level can lead to altered embryonic development, and in the absence of CoQ10, ATP synthesis declines in parallel with elevated oxidative stress. I think these 2 are the bad boys of implantation and failure. So I would like to say how coenzyme Q10 helps Roshni. Let's get back to Roshni. Let's get back to help her to achieve her dream of motherhood. It rejuvenates the ovarian store, helps to achieve and nurture improvement in fertility. Thank you. Thank you very much.
Thank you. Thank you, Dr. Balsagar, for a wonderful presentation. And as there is time, you can allow 2 to 3 questions from audience. So everybody is clear. So it is so nice. Thank you, madam. Our next speaker is Dr. K.D. Nair. He will be talking on explaining unexplained infertility. As you all know, when there is a fault is detected, we can treat it well. But if no problem is detected, which we stamp as unexplained infertility, then there are 2 ways. Either you don't have to do anything, or you have to do everything. How to explain this unexplained infertility? It will be tackled by Dr. K.D. Nair. Yes, sir. Please, sir.
Good morning. Good morning, ladies and gentlemen. It's a pleasure for me to be here in the city of Bhubaneswar. I love coming to Bhubaneswar. My talk is explaining the unexplained infertility. When we look back, definition of infertility according to SMART and WHO, the disease of the reproductive system, failure to couple to conceive within 12 months or more of unprotected intercourse. ASRM added the age of the woman also. In this definition, they say the age of woman is less than 35, you can allow it for 1 year. The age of woman more than 35, because 6 months of unprotected intercourse and she has not conceived, you start investigating for infertility. Now, the narrative question is, after how many months of unprotected intercourse should a couple be defined as infertile? It's based on a wide-ranging analysis of 437 studies of unexplained infertility. 85 of these related to the time of unprotected intercourse in their definition of unexplained infertility. 46% had specified 1 year, 39% specified 2 years, and 14% specified 3 years. Generally, 10 to 25% of couples are labeled as unexplained infertility. Younger age group, this incidence is or prevalence is 10%. Higher age group, 38 or more, the incidence goes up to 25 to 30%. The SMART definition again refers to the clinical diagnosis without any reference to duration of unprotected intercourse or female partner age. That definition could be further defined for practical purpose by adding 40 years as the upper age limit for the women. There are 3 basic investigations for diagnosis of unexplained infertility. Patient, the couple must have a basic semen analysis, normal, a patent fallopian tube confirmed by SCG or SSG, and ovulation confirmed by preluteal serum progesterone or follicle monitoring. So these 3 tests has to be done: normal semen analysis, patent fallopian tube, and ovulation confirmed. If all the tests are there and still the patient has infertility, we will label it as unexplained infertility. That is a very common thing in our practice, that whenever a couple comes, she has been already investigated and outside, this has been done, you are unexplained infertility, you don't know where is the cause, and we'll try to help you. It is a frustrating diagnosis. Diagnosis of unexplained infertility is highly frustrating for patients who may interpret this as meaning that there is apparently no cause for the infertility and hence no effective treatment. That is what the couple think. No, the manageable unexplained infertility in both male and female is possible. Couple want a baby. They don't want exhaustive and prolonged investigation. Unexplained male infertility is almost 50%, and you have a exhaustive recording of patient medical history, physical examination, complete semen analysis, immune infertility, ASF formation, immunoglobulin, class 1, reactive oxygen species, fertilization defect, genetic defects. The possible causes can be presence of anti-sperm antibodies, sperm DNA fragmentation, elevated level of reactive oxygen species, sperm dysfunction, vital factor can be there, inappropriate timing of intercourse, or erectile dysfunction and ejaculation. The semen analysis, we have the WHO manual coming up, the last one, 6th one coming into 21. And that is the normal semen parameters on the 6th edition. What has happened, the sperm motility, we again gone back to the 4th edition, and based on the existing literature, the progressive motility is the most important factor for predicting the likelihood of pregnancy via coitus. So that is why we are interested to check the motility of the semen parameters. Male infertility perspective, all of us know rising male infertility. Genome exome sequencing is now the new guidelines which is there. And over the years, the sperm count has decreased from 60 million to almost 20 million over last 3 years, or last 3 decades. There is a 50% decline in sperm count in the last 40 years. Male infertility is now implicated in more than 50% of couples, either alone or co-factor. Now when we come to unexplained infertility, it is being understood as potentially undetected male factor, because the basic semen analysis which we are doing is an inadequate marker of sperm function. There can be hidden issues like DNA fragmentation, epigenetic defects, or subclinical varicocele, which we are not checking in normal semen analysis. So in 24 European Association of Urology, they recommend a whole exome sequences in cases of unexplained infertility or severe oligospermia. This is something new. You have to do a whole exome sequencing, and it can diagnose spermatogenesis defect, meiosis, chromatin remodeling, or sperm motility. There are various panels are available now. There are various panels there, including Y chromosome microdeletion, karyotyping, cystic fibrosis gene, and all these they are trying to help us in differentiate between treatable, irreversible, and hereditary infertility. That is the advantage of doing all this test. The additional functional testing for male partners, you have to do sperm DNA fragmentation, oxidative stress testing, epigenetic profiling, heterosome reaction, and zona binding. These advanced tests are basically not part of standard protocol. So if you have a patient, you may have to think of doing all these tests, it is unexplained male infertility. Best matchup for sperm DNA. Most of us are doing halo test in our labs, but there are other tests also available. You can have tunnel or SCSC. The unexplained male infertility, you can do anti-sperm antibody immunotherapy test. You can do a fertilization defect by sperm capacitation, hyperactivation, and sperm binding to zona pellucida. You can do hemizo assay for unexplained infertility. The new thing is the genetic defect. You can do almost 10 to 15% of infertility, the male infertility because of genetic defect. And you can do various tests according to this chart. You can do for non-obstetrical agiospermia, you can do karyotyping Y chromosome. After agiospermia, you can do cystic fibrosis mutation or exome testing. Oligospermia, you can do karyotyping and Y chromosome microdeletion. Agiospermia and oligospermia with normal karyotype, you do exome analysis. So exome analysis is thing which has come up very fast. For female infertility, majority 90% are actually because of the polycystic condition like premature ovarian aging. Dr. Nandita has already mentioned about it. 50% is because of premature ovarian aging, tubal disease and endometriosis, and 20% is from immunological mortality. The premature ovarian aging, genetic factors, there are Y chromosome derangement, the fragile X syndrome, they can be gene polymorphism, and FHS and LS receptor defects. Endometriosis is associated with poor oocyte quality. Heavy smoking can also have a acquired modifiable factor associated with premature ovarian aging. The tubal and peritubal disease, endometriosis, pelvic infection, Carter-Garrett syndrome, pelvic surgery, all this can cause a tubal and peritubal disease. The tubal patency which we generally do is HSG or even laparoscopy, but that does not assess the characteristics of bidirectional tubal motility, which is important for embryo transfer. We have to understand that even if tube is patent, but we cannot detect whether it is bidirectional tubal motility. Other unusual causes of unexplained infertility, the molecular insight into uterine receptivity. This is something which has come very recently. We all know the implantation window from day 19 to day 21 of the cycle, and implantation may fail because of subclinical endometrial dysfunction. It is subclinical endometrial dysfunction which can be cause of unexplained infertility, and here the role of microRNA is very important. MicroRNA are small non-coding RNA that regulate gene expression post-transcriptively. They play a very important role in endometrial proliferation, immune modulation at fetal-maternal interface, and angiogenesis. Alteration of specific microRNA can impair uterine receptivity. There is a key molecule of microRNA. This microRNA 124 into 3P, it is implicated in this, and it is overexpressed in women with uterine implantation and unexplained infertility. If you can measure it and it is overexpressed, that is one of the reasons for unexplained infertility. And this inhibits critical genes which are involved in endometrial cell decidolization and will directly downregulate phosphatase and generate homologue. What is the future implication of this thing? In cases of unexplained infertility, can have molecular level endometrial dysfunction, and assessing the endometrial microRNA can emerge as diagnostic adjunct in patients with unexplained infertility. Endometrial receptivity area in future can also include microRNA panels. So that is in the future, you can have microRNA panel, and potential to use microRNA 124 3P inhibitor as an adjunct in IV cycle in selected patients with respect to repeated implantation failure. Then we can have, I mentioned 20% can have immunity as a factor of unexplained infertility, and all these patients will develop T cell and IL-21 are increased in cases of which correlate positively in presence of autoantibodies. We have a Cochrane review from 2006 to 2018, which included 44 studies, and they found out the level of antiphospholipid antibodies, anti-nuclear antibodies, thyroid autoantibodies. There is significant increase in women diagnosed with unexplained infertility. Antiphospholipid antibody, thyroid autoantibodies, and anti-nuclear antibodies are also associated with higher miscarriage rate. what is the management? You diagnose the patient with unexplained infertility, how do you manage it? NICE in 2016 say, advise them to conceive for 2 years. This can include up to 1 year before the fertility investigation. In 2018, we had a global recommendation that couple with unexplained infertility with the prognosis to become pregnant without assistance within the next 12 years, depending upon the Hanulert score. What is Hanulert score? This is a 20-year-old score, and the key parameters are women age, duration of infertility, previous pregnancy, post-coital test or motile sperm count, or whether refer from GP or a specialist. The problem is, according to the score, when it was fixed, this did not take into account the modern diagnostic parameter like AMH and AFC and endometrial receptivity. This is 20 years back. This is the score. Like I mentioned, the age, the type of infertility, sperm motility, and refer doctor. And if the score is more than 40%, you advise the patient for expectant management. If it's between 30 to 40%, choice can be between expectant management and medical or surgical treatment. If less than 30%, patient should be advised active treatment. Then, Denop in 2018 published his paper in Human Reproduction. 113 patients had pregnancy following ovarian stimulation with FHS, and 97 patients had ongoing pregnancy following ovarian stimulation with clomiphene. That is a discussion always whether we should stimulate such patient with clomiphene or gonadotropin. Basically, to decide whether ovarian stimulation with FHS or clomiphene, you have to discuss with the patient preference and cost. That has to be taken into account. Both the things practically give the almost same result. According to this study, if you look at the clinical pregnancy rate, was slightly higher with gonadotropin than clomiphene than letrozole. Similarly, the live birth rate is also slightly higher with gonadotropin, clomiphene, and letrozole. But this is an old study, 2018. Evolving prognostic model toward personalized reproductive care, we are considering endometrial receptivity, embryo quality, and immune profiling. These are the three things which are considered in future. And the personalized reproductive medicine, you have to help patient counseling, expectation management, and personalized treatment algorithm. What are the evidence? We had ASRM practice-based guidelines published in 2020. Can we do IUI non-stimulated cycle? No, it is not recommended to perform IUI non-stimulated cycle. Clomiphene with time intercourse, it is not recommended. Letrozole with time intercourse, it is not recommended. Gonadotropin with time intercourse, it is not recommended. Clomiphene with IUI, it is recommended to use clomiphene with IUI in treatment of coupled with unexplained infertility. Similarly, letrozole or clomiphene with IUI, it can be used. Clomiphene, letrozole or gonadotropin, it is not recommended to use letrozole clomiphene with a conventional dose of gonadotropin, because most of the studies are associated with improved pregnancy rate, but it is also associated with multiple gestation when you are using conventional dose of gonadotropin. Low dose gonadotropin, it is not recommended because it is more complex and expensive. Timing of IUI, it can be single IUI performed between 0 to 36 hours. Generally, we are doing it around 36 hours after post-SCG. Final, IVF versus IUI is the first line of treatment. In unexplained infertility, initially 3 to 6 cycles of ovarian stimulation with IUI with oral agent. Those who are unsuccessful, IVF is recommended rather than IUI with gonadotropin. So if you are given oral stimulation, don't go for gonadotropin, go directly for IVF. That is a summary statement that good evidence that immediate IVF in women more than 38 may be associated with higher pregnancy rate and shorter time to pregnancy, higher strategy of consisting of ovulation stage, ovarian stimulation with IVF treatment. Then we had an ASHRA guideline coming up 22. They are very clear, coupled with IUI, unexplained infertility are advised to have sexual intercourse every 2 to 3 days in the first half of the cycle. Women with regular menstrual cycle, test for confirmation of ovulation is not routinely recommended. Women with regular menstrual cycle, ovarian testing is also not required. SCG and PRACHEECON can be comparable, and ultrasound peripheral 3D is recommended to exclude uterine anomalies. laparoscopy is not recommended. Male additional tests are also generally not recommended. All the tests which I mentioned, testosterone is not necessary to all the tests. And additional tests for systemic condition, testing for thrombophilia is not recommended. Expectant management, clomiphene followed by 10-month course is not recommended. IVF combined with ovarian stimulation recommended for expectant treatment. Active treatment, IVF with ovarian stimulation recommended at first line. And again, SCG with the oil soluble contrast media is preferred over water soluble media. Injected oral antioxidant is not recommended. Oral antioxidant to males is probably not recommended. What is the take-home message? The principal treatment of unexplained infertility include expected observation of time, intercourse and lifestyle changes, clomiphene and IUI, and control over the stimulation with IUI or IVF. Age of female is important. Each female more than 38 years of age should be consulted for IVF sooner than later. Finally, unexplained infertility, IVF is a treatment choice when the less costly but also less successful treatment have failed. The optimal treatment strategy is to be based on individual patient, that is based on age, treatment efficacy and side effect. And there is no Indian guidelines on this topic. We probably will develop some guidelines then with the same. But basically you have to consult the patient, take the age of the patient into account, then you can decide how to go about the treatment. Thank you very much.
Any question? 1 to 2 questions can be asked. Yes, sir.
Hello. Sir, you have told so many things, but you have not told anything about microbiota. This is now emerging subject which is affecting all this tubal motility, amino quality, also sperm quality, everything. Now this is a hidden microbiota there, and they have a huge role in this unexplained fertility. So you have not told anything about microbiota. The vaginal microbiota, endometrial microbiota, or this also seminal roles in microbiota playing a great role. Anything about
it is documented, it is there, but we have to find some very concrete studies about it. What is the effectiveness of this changing the microbiota as you mentioned. But it is in the process. What I mentioned was what is in the guidelines, and there is no, as per the guidelines, they are not mentioned about the microbiome.
Yes, I think
probably it will come in future.
Maybe we will get specific guidelines later and more ourselves. We are not going to get the guidelines. So we can end here. And I think Nikhil, we are handing you over the dais 5 minutes.
5 minutes before time, yes ma'am. Thank you so much. With that, can I request Dr. S.N. Tripathi madam to please hand over the mementos to our chairpersons and the speakers. In the meanwhile, on the podium on the sides, can I request Dr. Nandita madam, if you are also here, to please join us. Dr. Bani Mitra is here. In the meanwhile, we would like to get started with our panel discussion as well. For that, can I request our moderator, Dr. Venugopal Ramchandran sir, to please join us. For an emergency, we have Dr. Rohan Parshekar, who is not going to be able to join us, but Dr. Venugopal is going to be the Dhoni and Virat for this moderation. I request him to please take the dais. Can I also request our experts and panelists to please join us, starting with our panelists, Dr. Anurekha JP, Dr. Sujata Pradhan, Dr. Varsha Jain, Dr. Moshmi Acharya, Dr. Prashant Kumar Nayak, Dr. Sanjeev Behra, Dr. Jitendra Behra, Dr. Munmun Agarwal. Our experts, we have Dr. Konkana Mitra, Dr. A.M. Barua, Dr. Babita Panda. That's a full house. We have total of 1 hour. Can we start the timer?
Okay, so they've started the timer. So we get settled down. In the course of our panel today, we'll be missing Rohan, of course. I think there was an important reason as to why he couldn't make this. But I must add that he's contributed a lot to compiling this sort of a presentation. And our topic today, ovarian manipulation to maximize outcomes. And we have a very, very distinguished panel. I think the panelists will give them just a one-line introduction of all of you, just before we get started. Yeah, we'll give you the stage for just one line about yourself. Yeah, so that I can get familiar with all.
Yeah, myself, Dr. Sujata Pradhan.
Fine.
Professor and head of unit in infertility unit at SNC Hospital.
Right.
I'm Dr. Varsha Jain. I'm from Bhopal.
Hi, myself Dr. Jitendra Behra, and I'm standing with my guru who is moderating the panel.
Okay, yes.
Myself Dr. Maushmi, Chief Consultant, KIMS Hospital.
Myself Dr. Sanjeev Behra, now practicing in Anna Gynecology and IVF, Bhubaneswar.
That's right.
Hello everyone, I'm Dr. Munmun Agarwal. I'm currently the director at Medishield Hospital, Raipur.
Myself Dr. one of his students.
Yes.
I am myself Dr. Prashant Nayak. I am clinical head at Oasis Fertility Hospital, Bhubaneswar.
Yeah, thank you. And I think we have experts. I am very familiar, Babita ma'am, and then Barwa sir and Kokona ma'am. So we are looking forward to have a nice session. So I think we'll start with a very familiar case of ourselves, which we all of them get. So this case went to Dr. Sanjeev Behra. So 32-year-old lady, everything looked okay. She had 3 IUI cycles, good AMH, ovarian reserve, oocytes stimulated. So Dr. Sanjeev told the patient everything is nice, सब अच्छा हो जाएगा और मैं इंजेक्शन दूंगा और वो सब IVF सब अच्छा होगा, everything will be nice. But what happened is ultimately got only 5 oocytes and transferred 1 8-cell grade 1 embryo, got negative HCG, going for a repeat stimulation to Jitendra Behra. So it has become Behra versus Behra. Okay, so Jitu, what is your line of action for this? Patient has come, unexpected things have happened. How do you start your conversation with your patient? Are you starting by telling that उन्होंने कुछ ठीक नहीं किया है sir? Young lady,
To be very clear that I have to go through the stimulation chart.
Okay.
How is the stimulation?
Yes, I am asking you one question. Is these things happen or without any reason this can happen?
Yeah.
Happens sometimes.
Sometimes.
Yes, all panelists, this happens sometimes. Everybody agrees. These things, unexpected things can happen sometimes. And no fault of anybody, these things can happen. This is the message that nobody has done anything wrong, but the unexpected has happened. But patient being patient wants answers from you, Jitu. That was it important? Only 1 egg. Does the oocyte number after an ovarian stimulation matter to you?
Definitely, because if the oocyte is more,
yes,
the number of M2 and the conversion to fertilization and again the embryo.
Understood. Oocyte is more means what? What is satisfactory for you? Dil khush hua, chalo acha hai. Yes.
The reserve seems to be good because
yes,
the FC is 15 and
yes,
AMH is 2.8.
Yeah,
so
but
patient
patient
are expecting 10 plus X.
Yes, yeah. Generally, you are expecting few numbers. What is the number for?
So as Jitu told, definitely we should go through the case previously how it was stimulated.
No. Are you in your mind at the beginning of? I think audience can also pitch in whenever you feel like. Okay. At the end of stimulation, what is a good result?
Yeah, if it is around 5 to 10x, it is satisfactory.
आप खुश हो 5 to 10x?
Yeah.
And here?
I am expecting to be more than 10.
You are more than 10. Okay.
10 plus.
More than 10 to 15. Yes.
If it becomes like more than 20,
correct,
then again we are expecting if the count is more than 20, then the quality will decrease.
Correct.
Quality may become.
Yeah. So egg numbers matter, no?
Till 15, because with the numbers.
Generally, everybody likes the number 15. Chalo 15 aa gaya, is it not matter? What we like experts also to contribute. Yeah, 15 is everybody paid bhar gaya, chalo acha hua, 15 aa gaya. But doesn't happen always, no? So how do we like analyze this case? I mean, suppose we are saying now, how do you look at it, Jitu? What is your thoughts about this case? Why a young lady went, and what may be the possible reasons for this?
So can we go to the question, like presentation part?
Yes.
Can you go back?
Oh, you want to go back?
Yes.
Yes, I'll go back. Yeah. Tell me. Yes.
This is a patient, like she's a young patient with
Young
a normal
patient.
BMI.
Yes.
Cycles are also okay.
Yes.
Unexplained sort of infertility is there.
Yes.
And see, the dose of FSH is very low. For this
So maybe, yeah. So what I'm saying is, when you're sitting in front of the patient and you tell the patient कि ऐसा भी हो सकता है, so is there any criteria by which you tell the patients कि ऐसा भी हो सकता है? Yes. Yeah.
This is the group 1 Poseidon criteria.
So Poseidon criteria. So you are telling the patient that according to Poseidon criteria, so you are using Poseidon criteria. All of us use the Poseidon criteria because it helps us to explain to the patient as to what may have happened. Wonderful. So group 1 Poseidon. So everybody like Poseidon criteria, and helps us to stratify. Yeah. So what may have happened?
This particular group of patient, the dose of FSH is low.
Correct.
Because maybe this patient, the day of stimulation may be less.
Correct.
And to get the optimal response,
correct,
the dose of FSH should be more than 60-50.
Correct.
It is more than 60-50.
Starting dose. Starting dose is important. So we will ask a discussion as to how you decide on the starting dose. Each one of you can say your favorite starting doses and how you can. See, this is not a question answer section, it's an experience sharing session. So we can be frank as to, for example, a 32-year-old young lady has come for stimulation. Aapka favorite starting dose kya hai?
Because it is a normal responder. So
yes.
I give a dose up to 300 international.
You are giving direct 300.
300, but usually we give 2/3 of FSH and 1/3 of HM.
But 300 is your starting dose.
Not more than that.
Anu, you are also 300 of what? FSH, HMG, what of 300 of what?
Sir, I prefer recombinant FSH of 300.
You are also starting with 300 for all your patients.
No, for this patient, for 32 years old, previous one failed, I guess.
Correct. So I am looking for an answer from you as to how you decide the starting dose. Yes.
Of course.
Yeah.
So again, same depending on AFC and AMH.
Correct.
If it's within the normal limits, we go for 300.
So you are looking at AFC and AMH.
Both.
We'll come to you last because the accusation is on him that he has started on a low dose. So we will quote yes. Yeah.
Actually, for this patient, if it is for the first time stimulation, I will go for 225.
You are going for 225.
And if the patient is coming after one cycle of failure and after one aspect.
No, this patient. Okay, yeah. You are
then 300. If the dose and that too HM will be better than.
Yes. Yes.
In this case also I'll go with Sanjeev 225 dose.
225. Jitu, your starting dose favorite?
Yeah, definitely, because if the MH is good and less than 35, so I will go with 225.
225.
Yeah.
225.
We consider age, BMI, as well as ovarian result.
Lovely. I think that should be the way in which you go about, and that's the way you thought of. Anybody in the audience wishes to add, could raise your hands and add an expert. Madam, yeah. What? Madam is counting on the duration of marriage also. Anyone? Yeah. See, established criteria: age, BMI, AFC, AMH. Yes.
Yes. AFC, AMH, age, and BMI.
Correct.
And one more thing, that is additional illnesses like endometriosis and PID, because they need a higher doses.
Will be reasons for increasing the dose. So that's very important to understand. No? See, previously when we started, everybody used to start at 150. Have you abandoned 150? All of you?
I have tried for so many patients.
Doesn't work?
Yeah, it's
only PCO patients.
Yes, but patients with abundant ovarian reserve, young patient you could think about. So better to individualize, no, starting dose. So what I'm asking you is, how many of you follow this? What's that called? You have any calendar or age calculator or anything? Anything in your office? Many people follow this, no? ART calculator. Anybody uses this? all these, they are available tools. In case you are confused, all these ART calculator and these tools and all these things are available.
Actually, that is good for counseling, the pre-counseling before somebody is going to IVF.
Correct.
And after getting M2 also, matured
Correct.
how many M2
Correct. So we discussed that maybe the gonadotropin dose, madam, were you saying something? Gonadotropin dose calculated was less. Any other reasons because of which this problem must have happened for our patient? Trigger, yes.
The rare phenomenon like polymorphism.
Yes. Nowadays everybody is talking about polymorphism. No, why a young lady is going to respond? Polymorphism might be one of the reasons.
And asynchrony also was one.
Yes. So asynchrony among the development very important. No, sometimes we start stimulation, 1 or 2 follicles come out of phase, and then the things. Polymorphism is where I want to come. Every meeting, conference we go, people are talking about polymorphism. I want to know from our panelists and then from our experts whether anybody checking for polymorphisms. No? Nobody checking for polymorphisms. Why?
In cases like where we see a patient who is having chronically, we see this type of poor response in young patient.
Yes.
In one odd cases, I just did for academic purpose.
You did for academic purpose, and then what happened?
I found it to be the reports were normal only, but I did it.
Means, and then what happened?
Because there was
no polymorphism.
It was normal.
Anybody else? Anybody in the audience have polymorphism? Anybody does polymorphism routinely? Lot of people doing lot of cases. Now, Bhubaneswar, I'm hearing lot of cases are happening, but nobody looking for polymorphism. Anything, yeah.
We are not doing it, but for academic purpose we have also done sometimes, but it comes to be normal.
It comes to be normal, no? Yes, I think the problem is that the exact population subsets, that for which population, which is the polymorphism, that is the issue is not yet been identified. No? There are many abroad. We have seen Dr. Deepak Modi and team doing many in Mumbai, and then they do identify polymorphisms, but which population, which polymorphism has not been identified. So it is known to be there, but the subsets have not been identified. So like the words used are correct, that this you can tell the patient, just to convince the patient you can do a lot of things, but in reality those things don't happen. So these are the main reasons. No? Low gonadotropin starting dose, genetic or environmental factors not in our control, asynchronous follicle development, and technical issues involving triggering for final maturation and or ovarian pickup. So now the patient has come to you. So you know that those are the possible reasons. So we need to now know that to avoid this particular thing happening in the next time, patient wants this, that patient has shifted from one person to another person because they are disappointed and next time. So what are the steps that, very practical, this thing. Suppose a patient like this comes, other than pointing out that this is, what do you tell the patient and how to handle the patient? Yes. What do you do? Pre-stimulation.
Add some pre-medications like coenzyme Q10.
You are adding coenzyme Q10 and
pre-medication for 2 to 3 months,
correct.
then followed by I'll answer the next time.
For 3 months you are adding coenzyme Q10.
2 months minimum.
2 months minimum. Madam, any pre-stimulation?
I'll counsel the patient and I'll change the protocol.
Correct.
I prefer the agonist protocol in this particular patient.
You may change the protocol, yes.
Pre-treatment is really means beneficial.
You are giving what pre-treatment?
DHA along with this one coenzyme Q10 8 to 12 weeks.
Okay.
And sometimes the patients, they will be very hurried, like no, we don't want to wait. So simultaneously I used to continue DHA.
Pre-treatment, I want to know about pre-treatment because many of these patients are given yes.
Yeah, along with pre-treatment usually
you are also giving coenzyme.
Along with that I talk about lifestyle changes. I give stress on weight loss and healthy diet, and along with that definitely we give some pre-treatment.
Pre-treatment. Some pre-treatment is where the grey area is. Many things are given. You eat this, go that way, this way. So that's what I'm arriving at.
We give DHA and coenzyme Q10.
Yes.
Yes, what the panel organization says in pre-treatment and also in the lifestyle modification. I usually tell all of my patients 5 things, that is exercise, yes. First thing is diet, second is exercise, third is sleep, fourth is reducing stress, and the fifth is hydration. And after this, everything will help to reduce weight and to increase the normal.
Okay, got it. Lifestyle and this thing.
Yes.
Yes. Madam. Yeah, the madam wants to add in addition to 5 plus 6 probiotic melatonin. No? So the list will be all this coenzyme Q10, what else? DHA, all exercise, sleep, all these things. My question to you, but is in yes, sir.
Look to the patient with a bone failure like this.
Yes.
Correct anemia, very common.
Yes.
Look for proper diagnosis of diabetes, not only by doing a BP plus, you can go for a GDP.
Correct.
Look for vitamin D.
Yes.
And as you said, lifestyle. So those things need to be added because they do not cost us in comparison to the medicines for so they can be always looked into as a pre-treatment for a perfect outcome of the disease.
Madam.
Go through the records if there is asynchrony during stimulation.
Yes, we will come to that. What we will do, pre-treatment, yes.
From the previous cycle, day 21, we can add estradiol.
Yes, madam wants to add. My question to you is, the young patient here, we discussed 4 reasons, but nowhere we discussed indications for all this coenzyme and all these things. Then why we are talking about all this? Is it in this group of young patients or is it in the group of slightly older patients? If you have calculated the dose of gonadotropin wrong, if you think that dose was, then Jitu, why did you say that I am giving pre-treatment with androgens and coenzyme Q? Just a curiosity question. आपने तो बताया वो डोज गलत किया करके तो what's my question? Yeah, am I right?
The previous practitioner, he got 5 oocytes and only 1 grade 1 embryo.
Yes.
That's why there may be some oocyte issues.
You were
Have the benefit of doubt.
okay. Yeah.
Mitochondrial issues, something.
So mitochondrial issue because of which the gonadotropin dose was wrongly calculated.
So in India, we cannot expect.
Whose mitochondrial issue?
Younger patients, sometimes due to this androgen deficiency also, they may have this defective follicular genesis.
Is it in the younger patient or is it in the older unexpected?
Older, but sometimes the younger patient which may be missed.
Occasionally. Yeah.
Occasionally.
Yes, so
but we have to give some pre-stimulation so we give on.
okay, something कुछ तो देना पड़ेगा, different from this thing. So the point we made is,
again the male factor should be checked also.
Yes.
The male simultaneously should be treated if there is something and DFI.
अरे मेल से फैक्टर से कैसे का एक इक्वल हो गया? No. That is not right. Okay. Yeah. DHA supplementation sometimes effective, sometimes in some group of patients. Hold your horses. Where to use these medicines? Very important. Okay. Strategies for fixing gonadotropin dosages we decided. ART calculator. Anybody uses ART calculator in this whole audience? Anybody using ART Poseidon calculator? Anybody? Yes. You are using? Useful? Will you advise it to everybody? Is it easy to use? Where do you get it?
Freely available in online. So you
It's
can
freely
just
available
see the
online. So if you have confusion in calculating the gonadotropin dosages, you can use ART calculator. We discussed about genetic factors and then, So pre-treatment methods of synchronization. So do you have problems in synchronization? Could it be that? What do you do to synchronize the follicles?
Usually when we do the next scan, usually on day 5 or 6 or even day 7 before starting the entire, we find if there is a cohort of follicles which are growing very slow.
Yes.
Usually I give emphasis on starting only LH.
Okay.
Stimulation. So I have seen that 2 to 3 days of LH stimulation itself along with HMG and FSH. Though those lagging follicles start growing.
Yes.
Yeah. Okay. So that gives us.
Now synchronization.
Yes. Before the month of the stimulation, previous month of the stimulation, you can start. Patna is telling from the day 20 or 21, you can use this estradiol.
Are you using regularly?
Yes.
Estradiol for synchronization.
For poor responders or sometimes normal responders also.
So for the audience, any 3-4 lines about how you are using practically, because she is not using. How about telling her?
Estradiol usually we should give 5 to 7 days after ovulation.
Yes.
And it can be maximum given like 9 to 10 days.
Okay.
Or sometimes if the periods happen, then you can immediately stop it. And after 2 days, because the washout period is 1 to 24 to 48 hours, then we can start the stimulation.
So you are using regularly? Satisfied?
Yeah.
Satisfied? We'll ask madam. Madam, you said about it. Are you using it regularly?
Regularly. there is asynchronization or irregular cycles.
You are using, and you are finding that results satisfactory. Yeah, madam. Yes.
We are using estrogen regularly. If the cycles are normal 28 days, we start from day 23. If short cycles, then 21 or 20.
I'm not using on a regular basis, it is on case-to-case basis.
Yeah, I also know. Somehow
we manage by changing the long protocol. I would rather prefer for synchronization.
Yes. In the audience, anybody raise a hand using estradiol for synchronization? No raised hands. So I think most of the experts in IVF are sitting here. Maybe that's the reason why nobody in the audience is saying anything. But it is one of the effective ways. And then, yes.
Long protocol is very good for synchronization.
Long protocol is, if you are using the long protocol, it is good for synchronization. But yeah.
Of course, OCPs was also one option for synchronization because this patient, 32 years, I don't think that much of pituitary suppression will be there. And in fact, you can have a good yield with short course of OCPs, like around 10 to 14
OCP,
days.
when you use, the number of days should be limited. That's the only thing. No? Some people use OCP month after month. That is a problem.
10 to 14 days of OCP is fine.
Next question is, what are the strategies for stimulation? Now, all of you said you are starting on 300. Suppose 300 was only the dose used. What strategies for next stimulation? How would you stimulate this patient next?
I will give a part of recombinant FSH and recombinant LH.
You have preference for recombinant over HMG?
FSH and HMG plus
You have
HMG.
preference for recombinant over HMG?
No. Recombinant FSH and HMG plus.
You are adding both?
Yeah.
Anybody feels recombinant FSH is more superior to HMG in these type of cases? Now, in this type of unexpected poor response, suppose you are stimulating for the next time.
Initially,
yes, you feel recombinant is superior to HMG? No.
both should be equally added.
Both should be
Equally
added. No, anybody in the audience?
Yes, sir.
Yeah.
I used to, this kind of patient when I started my stimulation, like second time, I used to do like 150 FSH and along with 150 HMG.
Yes.
And I got the result also. And sometimes, like if it is a polymorphism, so definitely the dose really matters because adding extra dose of FSH, so definitely it will change the embryo and also the fertilization.
Yes. Why I am asking you this, all of you said all Poseidon and all, you are very big fans of and all this thing. So if you read the Poseidon thing, they are always saying that in this type of groups, the recombinant gonadotropins are more effective than the HMG. I want your comments on that. Yes. Yes. No, polymorphism we are not testing, so you don't know about it.
So definitely we should.
So as far as my concern is, I am concerned. One thing is whether polymorphism is present or not, but we are not doing that. So another thing is whether LH activity or HMG, the LH activity present in the HMG, that might help in this group of patients.
Yeah, no,
so that
what
is the
I
point.
am telling you is that you all said about HMG, but the recommendations clearly state that recombinant FSH is better in this subgroup of patients.
So it is not only recombinant FSH. One point also I want to note that it matters. Means the company, the brand also matters.
Yes.
Because we have seen different kinds of recombinant FSH.
Now you be careful because all of them are putting stalls.
I know. So I am not indicating, but definitely there is
going into dangerous territory.
There is definitely a difference. And as we are talking about LH actually. As
recombinant FSH. Brand we will not.
So we have also seen in initial 4 to 5 days, we can start with just 300 recombinant FSH, and then as the follicles grow, after day 5 or day 6, we can
I think that's a better step because recombinant. See, patient who has failed to stimulation once, responded poorly, then there is definite evidence which says that recombinant is better than HMG when you are stimulating the next time. I am not batting for any particular thing. These are recommendations, and then. Agreed? Everybody agreed? I think we have to refine. See, there the argument that both are same does not hold. Then what has happened is you tried once and the second time you are trying now. So, yes.
After 5 days, you can add some HMG.
Correct. Yeah, that's,
Basically, the whole decision, I'm not giving 100% to it because in arm cycle if you're failing. You need to sit down with the patient one-to-one and discuss everything.
Correct.
Which is also again not particularly possible.
Correct.
Because with the enhanced doses, refining, doing extra investigation, so you might fail.
Correct.
Which patient will never expect.
Patient is
so how much to go, what to do, that should be the defining line.
Yes, counseling of the patient, but some principles remain that you have to, suppose last time you gave 225, don't stick to 225, increase the dose a bit. Increase the dose a bit, don't forget to do that. Change the gonadotropin. See, you have to do something different, no? Because you missed out something last time. Yes. Yeah, no? So when you increase the dose, what is the maximum dose up to which you can increase?
450.
450 you have given?
Max.
300. You said you started with 300, you are ending with 300. Come on.
So start with 300, max up to 450.
Your
only 450 her, it is actually not responding.
Not responding. Yeah, I don't go up to 450 and all that. Generally,
and actually, in my practice,
what is the maximum dose of
375.
gonadotropin you have given?
375.
375. 300. 375. Come on, let's hear. Anybody in the audience giving 500, 600? नहीं ऐसा नहीं चलता है. That doesn't happen, doesn't benefit. Yeah? Yes? Anybody? Sometimes you see 600 and all that. You say only the prescriber's pocket is filling, patients' eggs are not improving.
It is just like when your diet had been not working.
Yes.
When it's really
वो फिर वो button चलो ऊपर. So, yeah. Please, come on, open out. Silence doesn't help you. 450, yes.
375 I prescribe, but when I add HMG because the LH activity in HMG is unpredictable. So if I am adding 150,
that leads to a second question. Addition of LH, does it benefit in these patients? Addition of LH?
Yes, definitely. LH is very important.
Yes. Why?
LH is important before ovulation.
Yes.
LH for the
LH is important because see, polymorphisms can be a FSH receptor polymorphism. There is also LH receptor polymorphism. We are not measuring it. So the safest way is to increase the dose of both. But then here it is said about recombinant LH. Now I want your situation in the comments on this. Are you doing it? No. You are doing it. You are doing it. Recombinant? Which one? Which preparation? Chalo, you'll be caught. See, Vera is sitting there to catch you. Pergoveris, he is talking about pergoveris. Yes, that's very nice. Then that means he's actually using it. Nahi to kya, you are caught. Yes. Anu is not using recombinant LH.
No, so we start with 300 recombinant FSH and then we add 150 HMG.
HMG, yeah. But what I have to do, it is said recombinant LH. If we are, it's expensive first, like sir said, we can't go entirely this. But then we understand the theory behind it, that this is the reason and this may be the reason. You know, that's what, and like he said, pergoveris is available. Anybody want to share experiences with that particular? I am taking the name of the molecule because that is a unique formulation that is available. So yes.
It is in the combination of 2:1.
Yes. Have you used it in this?
In this particular group, I will use pergoveris only.
Do you find it useful?
225, yeah.
Anybody's found it spectacularly useful? You are a big fan. Anybody in the audience? Yes, there's somebody there. Anybody else? Pergoveris. Yeah, there. Our Rohit is here. Yeah, Rohit is here. Very nice. Yeah, pergoveris people are. See, that's when you go, you have to read, look up, and then there are a lot of indications for use of these medicines. We are not telling you to use it for every patient. Okay. Then similarly, what about this? Silence isn't an answer.
Whenever there is a urgency of, whenever there is an urgency when the patient is going for chemotherapy and all, for those particular patient or patient is from abroad. And
it's not chemotherapy. Now we are discussing a very separately different thing. Yeah.
You are
using dual stimulation and you are comfortable with it. Everybody,
we are using dual stimulation.
The speed at which the hands raise gives you an indication as to how many people are using.
So it is only
are you using dual stimulation? No.
I am using it only for those patients who are going abroad and they want to freeze the embryos and they want to go.
Okay.
Otherwise,
who are in a terrible hurry. Yes. Dual stimulation. Madam, we have a section of, what about this?
I actually practice embryology, so we did in a couple of patients pick up 4 days later, start stimulation and again.
Yes.
But I was not very happy with the embryos formed.
You are not very happy.
Happier I was with a month break
does dual stimulation and very happy with it? Anybody, come on. See, because this is all everybody reads this, and this time I didn't see Rohit's hand raised. Rohit, no, not happy. Anybody happy? No.
Sir, I am using dual stimulation in co-responders.
Yes.
The luteal phase stimulation is as good as the follicular phase.
So you are very happy?
Yeah, I am very happy. In patients, because they have done one cycle again, and even if you do everything also, we also get 2 to 3x in the follicular phase.
Yeah.
Sometimes the luteal stimulation can also...
Okay, so you are happy with it. Somehow I am not also happy. I don't know why. Maybe because I have not, it requires a change in the mindset or what, but somehow, it didn't, I prefer accumulation cycle. Means, I prefer pooling cycles. Like, I think that works out very well. That means if you counsel the patient well, you would have got the patient right. And then thoda either you have to decrease cost a little bit. Come on, yeah. This is, thoda something for the patient, not only for you. I have heard in big stages people are saying that the second stimulation embryo is better, beautiful and all that. But I don't know.
Actually, you want to know if you're using dual stimulation on a regular basis, how good is your success rate?
She said that she does it
If
regularly.
I see less than 12 minutes of follicles still growing in the follicular phase, and I have already done a pickup, I have got 2 to 3x, then if I see around a cohort of 3 to 4 antral follicles, then again I stimulate the patient, and believe me, I have got pregnancies. Yes, sir.
No, belief is not the problem. Don't worry.
But you use the same stimulation protocol or a different stimulation protocol?
No, sir. Once I do the trigger, after 3 days of the trigger, pickup.
See, very recently I also heard some very international person speaking about this dual stimulation, and he went on saying in onco patients, and at the end of the tail of it somewhere somebody else tries to introduce that why don't we use it in this. So fitting this better is to do too, no? So that's my thought.
Sir, now these days the random start protocols are...
Correct. We will take inspiration from you and we believe you. So no problem. Yeah.
Basically, I have tried my dual stimulation, but I failed to continue it because when I started, the progesterone level was high. It was some 1.8, and I don't think it was possible to continue it. So, in fact, I tried to start. It will be high, and also, I couldn't understand.
That's a different. But generally, the consensus is like that. It's nothing against dual stimulation. It's advised everywhere, and it's very much prominent in all the things. We'll come to the next case, and we'll start with a madam who we believe very much. So, one desperate call from a friend, stimulated patients for male factor, antagonist protocol with agonist trigger. Patient's BMI was 19, program postponed twice, OCDA. Response was good, 9 days stimulation, recombinant FSH 150 units, aspirated 1 ovary, 20 follicles, but no eggs. So
it is mostly
anti-follicles. First of all, you have to tell me what is your reaction in the egg pickup room. Are you jumping around?
I shouted my embryologist. Just look carefully, look. You must find 1 or 2 exactly.
Shouting at embryologist. Yes. No, initial reaction.
Agonist trigger.
Yes. Agonist trigger में UPT में कुछ नहीं आया. Yes. What to do now?
We have to first see whether we have done the estrogen level. It is corroborating with the follicle. It is.
No, in the theater at that time.
Yes, sir. We get panic. Pasina तो होता है. Then again the patient, embryologist gets the most. You believe in the embryologist.
You want everybody to believe you, but embryologist is problem. Yes. Yeah. No, you are not giving us eggs.
Sometimes our juniors screen, then I don't know senior will screen down. Leave the eggs.
Who are the patients you should identify at risk? Any modification for trigger at risk patients? How do you check to see if your trigger has worked? And on-spot decision making. You can take one by one of these. Yes. Patients you identify at risk. When is this likely to happen?
Usually,
prevention is the best, no? Yes.
Usually PCO patients
Usually PCO, that means many of them will land in trouble, no? Any other? Previous history of empty follicle definitely is at risk. Come on, madam. Yes. Any other patient?
So usually we see the trigger protocol also, as you know. So
I will put this, then there will be a
dual trigger.
See, there is a beautiful article. It's important for all of us because in the theatre, rather than jumping around and this thing, come on. Identify the patient for suboptimal response. Yes. Lean patients, prolonged oral contraceptive use have one of the most commonest reasons. Why? It will desensitize the axis. No? Yeah, no? Correct. Yes. So is this, this is very good sort of this thing now, but practically what all are you doing? You have to be truthful, come on. You are just nodding your head. How do you look at whether the trigger has worked? I am talking about agonist trigger. See, I deliberately did not put your HCG trigger.
Agonist trigger, we have to check the LH level.
We have to, I know. Are you, I am asking.
Yeah, we check.
Hey, such bolo.
Yes, we check after 8 to 10 hours of trigger and we give a cutoff of 15.
Yeah.
If it is more than
and
15,
raise.
then it has worked.
And raise.
We do it after 12 hours.
Bolo. Yeah. Yes. Correct. See, देखो, madam has got up from her chair. कुछ तो बोलना चाहिए. चुप बैठ के फायदा नहीं. Come on. Looking from, and what did you say? अरे tips. Yes. Yeah, you should. Correct. Got it. Yes. Correct. So what is your standard protocol, madam, for all this here? Yes. So for all agonist triggers you are routinely doing. Everybody? Your protocol. Okay, give an up. You are happy. Dekho, madam happy.
All patients agonist trigger, I do pre-trigger progesterone and LH.
You are also doing
Yes.
Yes, everybody. Raise of hands. LH.
Progesterone is a very good indicator. It has to be doubled.
Sir, there is.
So pre-trigger and post-trigger, because usually we follow dual trigger protocol.
Yeah.
So
I was looking for Rohit's hand. Yes, what happened? Yes. Yes. Correct. 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 Yes, exactly. Yes. Correct. See, you take a trip, see a discussion like this, you get points to take home. That's the point of the discussion. Yeah, you got that, this thing. Yeah, and then what about following trigger?
Following trigger, progesterone should be doubled at least. Then you know your trigger is
You are doing that routinely. Madam, you are 3 times. Okay. You, what about you? Are you following all this? Come on, panelists.
Yes, we do LH, as I said, cutoff 15 and progesterone 3 times the pre-trigger value.
Okay, 3 times you are going to. How about you? No silence. Jitu?
3 times.
3 times.
Normally we do the progesterone and it should be at least doubled.
Double. Okay, yeah. And in case it doesn't, then what happens? One is re-trigger with what? HCG. How much?
10,000 is If it is recommended to 50, it is
Madam, why coming back to you? Yeah. क्या होगा? And if the patient is PCO at the risk of hyperstimulation, then he said about donors, you aggressively stimulated them, and then what happens? HCG 1500. Yeah. 1500. Yeah, 1500 and this thing. Yeah. Okay. And then this what to do rather than shouting at embryologist? अभी क्या करने का means in the theatre? Abandon and then?
Reschedule.
We have not touched. After first ovarian
We have not touched the second opening, so we can re-trigger and then take the patient.
One of the best option is to touch the other ovary and finish it off. And tell She is going to do that.
No, sir.
Keep on cursing the embryologist and search for more.
We'll give a repeat trigger and do.
You are giving a repeat trigger with what?
Normally we give SCG or recombinant LH.
Recombinant LH.
SCG.
Recombinant HCG. Okay. And then you re-aspirate when?
After 36 hours.
After 36 hours. Everybody, I'm sure everybody faced this problem.
24 hours.
Sir,
24 hours.
24 hours. 24. 36 says Madam Rohit. What do you say? 36. And then I want to know that how was the outcome after that. Re-trigger ke baad mein, how did the next story, what happened? Got good eggs, got pregnancy. Madam's head is not shaking. Head is not shaking now. Got pregnancy? No. Rohit?
Sir,
Coasting destroys the eggs. So you can try that, but it need not necessarily give you good outcomes. Right? But don't abandon the patient and
empty follicle is very less, incidence is less.
Yes.
So there must be some problem in the stimulation.
that is retrospective. That you can continue fighting. Then the embryologist will tell you. No, but the thing is, deal with the situation properly and have options in mind. And let us be mentally prepared for these. Because see, what we are doing is, we are manipulating to maximize the outcomes. That is the essence of our discussion today. And these are all situations we come across. Yeah, please.
Just clarify again. So what is the take-home message? Like free trigger?
Yeah. See, the message is, like he said, these things are common nowadays. Because we are rescheduling these patients for months. Especially, see, what he said was very important. I put because of that. Donors, especially nowadays, we are getting scarcity of donors. So these are programs, they are taking OCPs. You should anticipate that they must be on OCPs. They are not going to come and tell you, okay, I am taking medicines from so many months and all these things. So we should, unless the mind knows it, how we can anticipate it. So anticipate these steps rather than getting into the OT and coming across odd situations. Take home message is to read this slide properly, not to fight with the embryologist and gather from experience from all these people. That is a take home message. Yeah.
Sir, now like what Madam said is now if one ovary there is no oocytes, now she'll give HCG trigger. Why not a dual trigger now?
Trigger it again? See? No. She is asking that at that time. See, once one thing has not worked, then it makes sense to give the whole same thing. Okay? So we'll go to the next scenario. See, first scenario, a young lady, she didn't respond when you were expecting a response. But now here is another patient. One look at her AMH, one look at the AFC and all these things. You know that she is going to respond poorly. And you must all agree that many of these patients are coming to us in this particular category now. Right? Agreed? Many patients we are having like this. So now my question to you is that, now what is our approach?
Counseling.
Yes.
And tell her the options. So the counseling in IVF is very individualized. It depends on the age and these factors.
Correct.
Along with that, it also depends on the financial factor.
That's all okay. That's all fine. But counsel means what? Means
here I will use a calculator. This question.
Yes. You are using calculator.
Because this is very important because here the number of AFC or and the principal of follicle and then after aspirating what is the number of implants.
So here you want calculator.
Even as such we know that the number of oocytes retrieved is going to be very less.
Yes.
So that is keeping in mind. Usually such patients I counsel that you may require another cycle of stimulation like
Correct.
So we have to keep them trying before.
Correct. That is very important. The age and the thing demands that what is the ultimately you are trying at least one blastocyst. Here we are not aiming for many, at least one. That is the difference between the two. See, everybody will ask what is hypo-responder, what is poor responder. See, only when we take real case scenarios we know that the earlier one was hypo-response. That fort. Anybody of you calculating FORT ratio, F-O-R-T, FORT? Or that is output you calculate ever anytime? No, that is one which differentiates between a hyperresponder and a poor responder. So here, these are genuinely difficult patients. Agreed, madam and experts, you have to tell that, whatever you do for these patients, the counseling has to be on the line that you are expected to respond poorly. We are trying our best. We will be trying our best. You cannot present a rosy picture for all these patients. You have to be very realistic because, suddenly you can't tell I will put some stem cell into your ovary, PRP into the ovary. Counseling doesn't mean this thing. So talk to the patient. What your observations regarding this group of patients, madam? What is your observation and messages?
Definitely simulates embryo pooling.
Yes.
So I will prefer breast transfer also.
Correct.
So if everything is fine, I will go for breast transfer and mild stimulation.
How about sir? Okay, we'll ask our panelists, they should not sit quietly. Pre-stimulation strategies, stimulation and post-stimulation. Pre-stimulation strategies.
Adjuvants will be added.
Here is where we should discuss more adjuvants. Now you talk so that the last row will be very happy.
We can give the testosterone gel also.
You are a testosterone gel. What else? DHA.
Vitamin D.
Growth hormone. Yes. Coenzyme Q.
Vitamin D. Vitamin D.
Vitamin D. Melatonin. If you read Chinese journal, they will talk about watermelon seeds. Anything else? All the antioxidants. You can. Which one have you found best use?
Testosterone gel works.
You have found testosterone gel use for that.
2-3 months use of DHA also works.
2-3 months of DHA.
Any one of DHA or coenzyme Q.
Coenzyme Q. What's your favorite? You must be having some favorites, don't you?
DHA and CoQ.
DHA and CoQ. CoQ. DHA. All DHA. Any mantras? Madam, on the testosterone. Rohit? Nothing. Rohit is giving nothing. Anybody else? Nothing. Or anybody? How many hands like this? Nothing. If you say nothing, you cannot hold conference, okay? Such bolo.
Definitely it works, but may not be that miracle. It works, but it is not a miracle.
It is not a miracle. So, you have prescriptions. First, do no harm. And so many things, mitochondria is energy or EQ, OQ, all. You can use all, but you should know. Sir is smiling now. Abhi tak sir phone pe abhi uठ गए. Yes. There. Group. That is the thing. You may give many things, but you have to be very realistic and knowing about it.
This is basically thing. You have to be honest to your patient.
See, when it comes to honesty, sir is giving a record.
You have to be honest to your patient. You need to be totally saying that this is my limitation.
Once you have passed the age, you can preach like this. You have to be honest. All these things. Yes, you have to please.
Of low image, they have already wasted so much time. So my principle is that when they come in the first instance, I try to preserve their eggs, collect them, and then freeze them or do ICSI and store their embryos.
Yes, fertility, yes. You could use these medicines.
I have seen many patients where I saw 5 antral follicles 3 months back.
Yes.
After 3 months, the patient came no antral follicles.
Yes.
So
DHA came with so much promise. But most of the studies in DHA was on sheep. अरे वो बकरी में क्या आदमी में क्या हुआ? Difference is there, no? So nobody knows, no dose finding study, nothing. As soon as possible. Let's not waste time and let us move ahead. But you could give this. See, add-on prescriptions can be given. All these things can be given. Mitochondria.
We counsel your numbers are not going to increase by these medications, but there is some benefit regarding the quality.
Yes. See, this is the thing. This is one of the latest one, 2023. that you cannot correlate all this with live birth rate. You may say that some oocyte quality is good, egg quality is good, all that. But when it comes to live birth rate, you have to be guarded and this thing. Okay. Letrozole. Come on, letrozole has many fans. Bolo. Huh? Letrozole? No? Nobody? Come on, be truthful. In letrozole, anybody using letrozole? Poor responders. Quinine? Nobody? I think all you people are not academic enough. Okay, coenzyme Q we discussed that it's not bad, but how possible mechanism in the SE, if you listen to Nandita madam's lecture, she said a lot about coenzyme Q10, but also first question she asked was what, how do you increase coenzyme Q10, what is the best way, what did she say? She said exercise. If you listen to that, no? Yes, so lifestyle matters, supplements matter. See, at the end of the day, whatever we say, we are all prescribing all these medicines and we could prescribe, they don't do any harm, but this is important to know. What about stimulation? Jitu, good chance. 400 unit, 500 unit, 600, who's, huh?
This type of cases I will, from the beginning itself.
Jitendra is writing 500, 600.
No, sir. The 300 dose.
300.
FSH,
Such like this.
Recommended FSH along with HM.
How about you? High dose? Huh?
Yes, for the patient 38 years.
I saw your
no
prescription,
result.
450.
It is 225 FSH plus 150 HMG.
Madam?
So I'll use the long protocol. I am starting with HMG 300.
300, yeah. The message to go out from us to the audience is this, that it's not a big high dose that makes a difference.
I counsel them for a minimal stimulation and I mean like...
That minimal I don't know, okay. Minimal means what?
I mean actually I'll prefer to start with only HMG.
If this group is minimum work
along with chloroquine.
Have you find this minimalistic approach to this group of patients?
This kind of patients actually, we have faced problem with asynchrony. Because
the expected oocytes is less, so at least we'll have a...
There is a protocol called Shanghai protocol.
We may not actually...
Shanghai, okay.
Yeah, Shanghai protocol where we can use minimum gonadotropins along with the clomipin citrate.
Clomipin citrate.
Okay.
Definitely.
You used or anytime this Shanghai?
No, I have.
Such guru.
Such guru, sir.
But
yeah.
So with minimal protocol, there is we get eggs, embryos also, but no pregnancy.
Exactly. With minimal protocol, usually the quality of the oocytes reduced and the numbers also decreased. So we should not compromise.
Yeah.
Sir, in Shanghai protocol,
you don't
you don't have to start the gonadotropins. First you can start along
going on
letrozole along with the clomipin citrate, then after that you can start.
That's minimum. What is that? Rohit, minimum approach in this? He's taking time to answer. Means he is also a little bit, kya bolne ka? Yeah. Yes. $225. है ना? Minimum and all, no, clomifene and all this. What is this in the name of all this Chinese and Japanese?
Sir, I would prefer a long agonist protocol.
Message to be driven, yeah.
A long agonist protocol and a
You would, yeah. I agree with that. Yes, anything. The message to be given is you can't be too minimalistic. Too much minimalistic is not good. But yeah, very practical. Sir is only smiling and your answer only intellectual questions. Addition of LH, growth hormone. Any fans of growth hormone? Hands up, growth hormone fans.
Doesn't work.
It works.
Does it work?
No, I want fans of growth hormone.
So I have experienced a lot. Doesn't work.
Yes, sir. It really works.
All things that are not working for anybody are working for you.
It needs your participation. If you are really using for indicated cases, not for unindicated cases.
Madam, does it work for you? Never use. Thank God. Rohit? No, never. Next to? No. Person that, yeah? No. Anybody? Lipsa, where are you? No, all people people doing cases, not working.
We have a tendency to believe in.
And sir, it is not my words. You have so many meta-analysis and recent studies which has approved this, and I have seen in my practice because I am using. So it is works.
Sir, I also back Prashant sir because it works.
You like Prashant sir? That is
it's
okay.
not like, sir, I have used it. It's not like Conclave is very costly and when the patient, it's not costly.
It is?
It is extra, patient has to pay some 20 to 100.
Extra patient has to pay some 20 to 100.
It's not costly.
How you tell everybody what dose and what is your success formula?
Yeah, usually we start from day 2 of stimulation.
Yes.
After 5 minutes or 6 minutes per day,
Yes.
you can give it till the end of the stimulation, 10 days or 9 days, whatever.
Actually the standard dose is that you have to give minimum 7 days. So what I used to do, like after 3 or 4 days of stimulation, I add the growth hormone, LSC.
The way you said it, I can guarantee you have never used it.
I have used it, sir. I have used it. And you and me both work in the same direction.
And sir, he is saying it is not costly because patient has to pay it.
No,
Madam, it is not for the growth.
In
it is
one
not
meeting,
for the growth.
in
It
one-
is for the quality of the egg,
No,
not for
in-
the growth.
in-
it will not stimulate the size.
In one meeting, I heard one person asking who is growing, the doctor is growing or the eggs are growing. So that is, that is a very high dose gonadotropin. We discussed that. Protocols both equally good. We passed that. Nowadays everybody likes to do this progesterone prime ovarian stimulation. Style हो गया अभी. Any comments?
Donors not got satisfied results. So
Not satisfied?
because see, like there are two, like methoxyprogesterone, and I started converted it to that dehydroepiandrosterone. But still, I don't think.
You are not satisfied.
Sir, you may get equal number of oocytes and embryos, but what happens, the chance of aneuploidy increases.
Chance of aneuploidy. Anybody else? This is the last question, okay? Because the time is
The PPOS is used.
PPOS is used.
10 milligram.
I am hearing many people talking about PPOS. Madam, PPOS fan now?
Not
PPOS, see, madam, hand went up.
Occupation poor responders.
हमको नहीं.
Poor responder.
Yes. PPOS. Rohit? No, he is not using. Madam, is anybody PPOS fans?
We may reduce the cost, but we have to see the sources.
We may reduce the cost.
But the chance of aneuploidy finally it leads to the negative result.
Leads to?
But studies are showing it is giving you blood.
No,
Studies saying it is okay, but this slide is also saying time is up. So I think we'll end on that note. So thank you very much, and I think we should give time and respect so much. Yes. And bigger round of applause for all the panelists, please. They are such vibrant group. Thank you to the expert and thanks to the audience also, such good audience interaction. Sir, thank you so much for giving us this.
Can I request the panelists for the memento? Jaldi. Can I request all of you to take a picture? Photo इधर चाहिए उनको. And they have finished it on time, so.
Venu, you are exceptional. And all the panelists, including the expert, I think very important is here starting from Rohit to many fertility specialists have participated here. I really enjoyed that.
We had Dr. Raju Tyagi, I believe she was participating. Dr. Rohit was here. And this is only because we have 1 minute left. And just to let everybody know, our orator has also joined us live. We have Dr. Nicholas joining us from Spain. I believe he can hear us. Can we have the audio from Zoom also put on live right now? Yes.
Nicholas, welcome from Orissa, from Bhubaneswar, Mayfair for the PRACHEECON 2025. I think you have really fulfilled the commitment given to me in Ahmedabad for the IFS conference for that. Thank you.
Thank you so much. Can I request the panelists, the moderators, to please join us on the side stage for the mementos. I would request Dr. Hara Patnaik sir and Dr. Sujay Narayan Das to please join us and do the honors. In the meanwhile, we can see Dr. Nicholas on the screen. Can I request Dr. Nicholas to please start his presentation and share it onto the screen? And I would like, thank you. Can I request our chairpersons to please join us? We have Dr. Tushar Kar, Dr. S.N. Tripathi, Dr. Sarojini Sarangi, Dr. Jayashree Patnaik to please join us on the stage as the chairpersons. And we have Dr. Tushar, I request you to please introduce our orator.
Now we are with Dr. Nicholas. Dr. Polijos is the president of the Dexios Foundation and the head of the Dexios Fertility at the Dexios Mutual Group in Barcelona, Spain. He is also visiting professor in the Department of Reproductive Medicine in University of Ghent, Belgium. And since 2021, he is a member of the Executive Committee of the European Society of Human Reproduction and Embryology, ESRI. And he has served as medical director in the Center of Reproductive Medicine in Brussels in 2017, as a professor of obstetric gynec in the Free University of Brussels until 2019, and as professor of reproductive endocrinology in the Department of Clinical Medicine in the University of Aarhus in Denmark until 2020. Professor Polijos is the principal investigator, PI, in several large pioneering multinational trials and a key opinion leader in the field of reproductive medicine for the treatment of poor ovarian responders particularly. And he has got a lot of work on the poor ovarian responders in IVF program. And prediction of ovarian response and premature ovarian aging with more than, I can go with this, in international congresses. He is a section editor in RBMO, member of the ESRI Guideline Development Group for Ovarian Stimulation, and has served as an editorial consultant for the prior information of the American College of Physicians, ACP. Professor Polijos has published more than 200 publications to his credit in peer-reviewed journals, indexed in PubMed with more than 5,000 citations, and a CD Google Scholar. His research interests include reproductive endocrinology, ovarian result markers, poor ovarian response to stimulation, and genetic of premature ovarian aging. So now the stage is yours, Dr. Polijos. Professor Polijos, all are waiting to hear that human reproduction, what is the next, what is the future of the human reproduction. So are you going to design baby or something else? Let us hear from you. Thank you very much. Now the stage is yours, Polijos.
Thank you so much. I would like to thank Dr. Habata for the invitation and of course India for sponsoring this session. It's always lovely when I talk to India, and I feel like I'm one of you. You know how much I'm involved with the Indian people, and I like you, and I think in my previous life I have been an Indian. Talking about human reproduction, we're talking about you, but what I want actually to see is how we are changed. We're living in an era of human reproduction, and we're doing ovarian stimulation, we're doing different protocols. But apparently, everything has evolved over the years. If we see where we are, everything is an evolution. We started here. The first IVF baby has been born without any medication, without any stimulation, just they took the egg out, they fertilized it with the sperm, and that was it. But following this, we changed. We started stimulation, we started using medication because we realized that we need more follicles, more eggs, so as to create more embryos to allow more selection. Then we realized that we need to control the late surge, and we did it with antagonists and with agonists, and now we moved to the free zone. And if I want you to raise your hand, I'm sure that most of you, or many of you, would freeze in more than 50% of your cycles. We're freezing around 70% in Barcelona. And it's a game changer. It's a game changer. Why? Because we see what's happening. This is the UK. These are the babies born from frozen embryos. They are continuously increasing, the yellow bars, while the fresh are remaining the same. This is United States. For the first time, more babies are born from frozen embryos compared to fresh. This is Latin America. 60% of the patients are freezing their embryos. And this is Europe, that for the first time, the fresh live birth babies are dropping and the frozen are increasing. So what is happening? It's an evolution. Someone might say that this is an evolution, but I would like you to see it from a different perspective, a different prism. Just that one letter, because it's a revolution. Freezing all revolutionized the way that we are treating our patients, because our stimulation is not the same. If I asked you how you were doing your stimulation 10 years ago, our #1 priority was to avoid OHSLs. Today, we think differently, because we uncouple the oocyte retrieval and the transfer of the little phase, and we focus on the stimulation. And in the stimulation of a new freeze-all era, we can stimulate differently, more intense or differently, I would say in general. We can start our stimulation differently. Why always to start on day 2 and not on day 22? And we can down-regulate differently. We don't need agonist and antagonist protocols always. We can use different protocols. And this is what we would see in the freeze-all revolution in our IVF journey. So having said this, I would start with the intensity of stimulation. How should we stimulate our patients? Should we go with high doses? Should we go with low doses? It depends. Mild and wild, it's just an upside down letter. Someone might say that I turn the letter around and mild becomes wild. But it's not that simple. We need to understand that we need to individualize the treatment of the patients based on 2 different characteristics. One would be the ovarian reserve. And we know, I heard you before talking about different patients. You had poor responders, you had normal responders, you had high responders. These patients are different. They have a different probability of pregnancy, they have a different risk of developing problems, and so this needs to be taken into account in our stimulation. It needs to be totally individualized. And secondly, even among the poor responders, all the patients are not the same. Why am I telling you this? The typical Poseidon criteria have been published some months ago, some years ago, and the updated are publishing now. So what we know from the Poseidon criteria is that not all poor responders are the same, because we have patients that they are young and old, and we have patients that they have a good ovarian reserve and a poor ovarian reserve. If I have 3 follicles, what do I expect? So we have patients that they have a good ovarian reserve. Imagine they have 6, 7, 8 follicles, and I stimulate them and I have only 2 eggs, which is an unexpected hyporesponse. Or patients that they have only 2 follicles and I get 2 oocytes, which is an expected hyporesponse. And these patients are different, and these patients need to be treated differently. Why? Do I need to use high doses in these patients? Do I need to stimulate hard? Well, if you ask me, imagine that you have a 34-year-old patient that she had an endometriosis, that she had a surgery and her ovarian reserve is low. If I manage to get 2 eggs instead of 1, it will increase my probability from pregnancy from 6 to 15%. This is like tripling the probability of pregnancy. Getting 1 more egg will go to 20%, 25 or 27%. The young patient every extra egg can give you a very good quality embryo, and this can give you higher chances of pregnancy. So what we're doing now, we're doing a nice study, an interesting study, in these patients that they are 35 to 40 years old, they have a quite good outer follicle count, 5 to 10, and a low AMH, and we randomize them to two groups. One group is the clomiphene with low dose gonadotropin. So it's a mixed protocol with oral clomiphene citrate and low dose gonadotropins versus high dose recombinant FSH of 300 to see if we can get higher number of top quality embryos. This is an interesting study. We have 90% recruited, and soon we will finalize the study to see if a high dose or a high stimulation will give me more better quality embryos. In normal responders, there have been a lot of studies trying to figure out what's happening and whether the extra oocytes will give you any additional pregnancy. And if you see here, these are the cumulative live birth rates, the live birth rates that we get after we transfer the fresh live embryo, but then a second and a third embryo. And you see, the more oocytes you have 20 oocytes, your probability will reach at 70%. Because more oocytes means more live birth rates. More live birth rates means shorter time to pregnancy. Shorter time to pregnancies means lower chance to repeat stimulation. And this is important in many settings. For example, not all the patients have the resources to do 2 or 3 stimulations. So for me, it's my responsibility to get the maximum possible for these patients to get 1 or 2 or 3 babies in the end. And again, all normal responders are not the same. Imagine that they have a patient that is 40 years old. Women are coming at more advanced age to get pregnant now. And these patients, we know, if you see here, the percentage of embryos that they will be genetically normal is very low. The blue bars represent the genetically normal embryos. So for a woman at 41 years old, only 25%, you see here, only 25% of the embryos will be normal. If she has 4 embryos, only 1 will be normal. The other would be a Down syndrome, would be a Patau syndrome, would be a Turner syndrome, that possibly we need to stop the pregnancy. And there, it's important to get eggs, because more eggs means more embryos, means better selection. And we have demonstrated this in a study that we published in 2018 by our team, that shows that a woman at 38, 39, 40 years old, if I get 4 eggs, my probability of pregnancy will be hardly at 15%. If I get 8 eggs, this goes to 25–30%, and gives me a very good probability of life or baby. When I have young patients, when my percentage of genetically normal euploid embryos is high, 70%, apparently I don't need an unlimited number of embryos or eggs. Even with 5, 6 eggs, even with medium dose, I can have a good outcome. But still, we have to realize that patients would like to have more than 1 child. And our goal is to talk with the patient, discuss with her, ask her what is her family plan, and decide how strong we stimulate so as to get the maximum to be able to help them get pregnant. High responders, and I know that you have a lot of PCOS patients, is another difficult group category, and we have to decide again about the dose. What we need to realize, and I'm talking to you because many of you, you are not fertility specialists, and we're always being afraid of how we stimulate these patients. The PCOS patients do not have good quality embryos. What are we going to do? Should we go really mild? I wouldn't go very mild to them. Many of them would be overweight patients. You have an issue with this in India. And we have seen studies that showing that in the freeze-all era, if you go with very low doses, like 100 units, you might have the same live birth rates. But look at here. According to the study, 21%, 1 out of 5 patients that are high responders, had to cancel their cycle because of low ovarian reserve. And imagine a patient accumulating money for years to do an IVF, and you have to cancel the cycle, so you end up with only 1 embryo. This is not the correct process, so we need to tailor about the dose, the most intriguing and the most interesting part that I have ever seen in the last years is the stimulation start. Why? What is the most boring thing we do with our patients? We call them and we tell them, when was your last menstruation? Why? Why do we need to start our cycle with the menstruation? Because of different theories. In the past, we believed that all the follicles are starting on day 2 or day 3 of the cycle. But this is extremely boring, and it cannot be that nature is so programmed. Nature is never programmed. Everything comes randomly. And there is a beautiful paper by Barrow showing to us that follicles can be ready to be recruited either in the beginning of the cycle with the menstruation, but also in the luteal phase. Barrow has shown that 2 out of 3 patients have one follicular wave that leads to ovulation, but during the same menstrual cycle they have a second follicular wave. This is 2 out of 3 patients. And 1 out of 3 patients will have 1, 2, that leads to ovulation, and a third follicular wave. 3 follicular waves. So the follicles are not always waiting for us in the beginning of the cycle. They can wait for us on day 21 or day 22. And it's interesting to say why we can use this theory of follicular waves, because I have seen before that you were talking about low ovarian reserve, poor responders, bad cycles. Are all the cycles the same? This is a study published in 2015 showing the intracycle variability. If I do 3 cycles, 1, 2, and 3 cycles, what is the difference in response? What is the difference in number of oocytes? Because every cycle is different. What we saw in the study, if you use the same exact stimulation, the same exact dose, the same exact protocol, is that 56% of the patients would be normal responders in one cycle and normal responders in the other cycle. In 15% there would be low responders in one cycle and no responders in the other cycle. But in 27% or 30% of the cycle, 1 out of 4 or 1 out of 3 cycles, would change categories, which means that 1 month will have 3 oocytes, another month will have 7 oocytes. What does it depend? We don't know the paracrine mechanisms. But what is interesting and what I'm doing lately, and what is new to me, is that I scan my responder on day 2 of the cycle. I see 3 follicles. I don't start. I let them go to day 21 and I do another scan. And if I see more follicles, like 7 or 8 follicles there, I would start stimulation. And I have a patient that she was young and I managed to get 3 top quality blastocysts there. And several patients have been better. But because we have evidence about random start stimulation, we can start on day 2 or on day 20, on day 2 or on day 40, on day 2 or on day 6, and even do a dual stimulation. What is the problem? The problem that we always was thinking of was the fact that you start when the progesterone levels are high. If you start in the luteal phase, imagine your corpus luteum will produce progesterone and you will start your stimulation at a very high cell progesterone levels. Is this a problem? We wanted to see this a problem, and we tried to do a study, and we published this in Human Reproduction, in which we used the same oocyte numbers, in which they did in one cycle a follicular phase stimulation, starting on day 2 of the cycle, and on the other cycle, after 1 month washout period, a luteal phase stimulation. Ovulation, detecting the ovulation, and 5 days later, we start the stimulation. And what we did in these patients, we had the husband of the patient that we kept the sperm frozen before doing the stimulation, and with the same sperm we fertilized the egg from the follicular phase and the eggs from the luteal phase. We do the ICSI, vitrification, then we do genetic screening of the embryos to see if there is any difference in the genetic content of the embryos. And what we found was, interestingly, you see exactly the same stimulation, the only difference starting day 2, starting a late surge plus 5 days. So what we found is that the fertilization rates, the blastulation rates, the euploidy rates, and the positiosis rates are the same. Which means that if for my patient I can do a scan on day 2, and she has an AMH of 1 or 1.1, and I see a low number of follicles, it would be more wise not to start her when she has a very low number of follicles. Wait for the luteal phase after 2 weeks, bring her back, do a scan, and if I see more than 6 or 7 follicles, start your stimulation. Individualize your stimulation because you will have equally good quality embryos and blastulation rates, and you will have very good results. Something more innovative is the duostim, but not the duostim how you have learned it. The duostim that has been developed for many years was this, that you start on the follicular phase. Kwang has shown this, the Shanghai protocol, that they started on the follicular phase, day 3, they did an agonist trigger, they did an oocyte trigger, and then a second stimulation cycle, which was a combination of HMT, clomiphene plus letrozole in one cycle, and a different stimulation in the second cycle. A little confusing, but then what Filippo Bardi did the 2 identical cycles, this cycle and this cycle, exactly the same, and they found that you can get good quality embryos. These are euploid embryos, the green cycles, oocytes that lead to euploid embryos, and they found that the first and the second stimulation are equally the same, are exactly the same. And it's something that you can use, but the problem is that always you have to freeze it. What we did and we published last year was a very interesting novel duostim project. That we did it vice versa. That we start 2 times, but in the luteal phase and fresh. So we started the cycle on day 21 of the previous cycle. We did the stimulation, we did the agonist trigger, we took the oocytes, and the second cycle was a follicular phase stimulation after the menstruation, HCG trigger and first transfer. Again, one stimulation started on the follicular phase. And what we found was that the ongoing pregnancy rates are the same, so if you transfer embryos in the first or in the follicular phase or in the luteal phase, it seems to be the same. But what is very important is to see that you have pregnancies. And this is very important for me to be able to have pregnancies in these patients. Secondly, what is equally interesting is that you have more good quality embryos and more M2s. And what is interesting to understand is that imagine that I start my stimulation in the luteal phase, I generate my embryos, I freeze my embryos from the luteal phase, and then I do follicular phase stimulation. And in the same 2 cycles, I can accumulate more embryos and I can transfer in fresh, or the best quality embryo from the first stimulation, or the best quality embryo from the second stimulation. Interesting, different. The third part, which is much more commonly used, is how we control the late shows. And I'm telling you this because for many years we have been using injections and injections and injections. The first was the long agonist protocol with a bad flare-up, with a down regulation, and then which was totally patient unfriendly. And thankfully we don't use it, not even in India. Only the Chinese continue to use the long agonist protocol, but it's actually disappearing in the European world and in the Asian world. But what is the most common was the gene-rage antagonist protocol, in which we have a direct suppression. We start immediately on day 5 or day 6 of the stimulation, or when we have a dominant follicle. But if you see the literature, you will see that even before the antagonist cycles, we had the option to use different medication. And this is a very interesting study that has been published in PNAS, in which has shown that progesterone can block the late shows. This is an experiment in animals, in sheep, in which they introduced implants of progesterone. You see here is implants of progesterone at the level of 3 nanograms. Here is the removal of the implants, no progesterone. and here introduction of implants at higher levels of progesterone. And what you see, if you see the axis of gene rates and LH, the pulses are rare and low when the progesterone is high. The pulses appear to be continuously high when the progesterone disappears, and they are completely blocked at high progesterone levels. In the pituitary and the hypophysis levels, there are receptors that they are blocked by progesterone. So progesterone can really block the release. What is the problem? The problem is that we need to do freeze-on because you advance your individual. But is it the same? Do we have evidence that progestins can block the late surge and result in good results as antagonists? Yes, we have. These are systematic reviews showing that if you use the GnRH antagonist or you use the PPOS, the progesterone, you have exactly the same number of oocytes. Absolutely no difference. GnRH antagonist and progestins results in the same number of oocytes. And if you check pregnancy rates, exactly the same clinical pregnancy rates. So it means that if I'm doing a freeze-on protocol and I use the PPOS, it can beautifully block the late surge without any problem, and I can have a nice stimulation if I'm planning to freeze on. The problem is which progestin, because the progestins are, every medication, have different potency. And I'm not talking to you about the potency to transform the individual, but the potency to inhibit ovulation. They work on a central level. So if you see, the strongest progestins are testosterone or MPA, and the weakest is natural progesterone. So what do we use and how do we use? Most of the world is using MPA, methoxyprogesterone. We never used it. Why? We never used it because it's out of label and it's a strong suppression. And what we thought is that maybe we should use natural progesterone, micronized progesterone, orally, because we can get a softer late solution. And what we did a study that has been published last year in Human Reproduction, in which we took IVF patients that they were planning to do genetic screening of the embryos, 2 treatment cycles to accumulate embryos. They had a good AMH and a good intrafollicular growth. And the patients had one cycle, a GnRH antagonist cycle, 1 month was out, and a progesterone cycle. And what we did, we kept the sperm of the husband again, we fertilized the same oocytes from the same patients with the same sperm after exactly the same stimulation. What was the only difference? Folitropin alpha, the same dose, agonist trigger. Cycle 1, GnRH antagonist 0.25 mg per day in a flexible protocol, progesterone cycle, micronized progesterone, orally 200 mg from day 1 of the cycle, continuously. And we wanted to see if there was any difference in the euploid embryos. But as any study, we came up to a very, very interesting find. This is the data in terms of blood sampling of patients. And this is the day of the trigger. And we found that the antagonist protocol, which is the green, had significantly lower estradiol levels, but most importantly, significantly lower LH levels. These are the LH levels. Here, in the antagonist, these are the progesterone primed with micronized progesterone. Are LH important when I trigger with an agonist? Yes, they're very low. Low serum LH levels on the day of trigger with an agonist trigger has been associated with suboptimal response, less number of response. So when we analyzed the patients, we found, interestingly, that the LH levels in the micronized progesterone group was 296, significantly higher, P0.025, as compared to LH on the antagonist protocol. And if you see here what we managed to find, we had 2 oocytes more, P0.06, 2 mature oocytes more, and 2 PM oocytes more, suggesting to us that this can be a protocol to use when we're planning to freeze all, not only because you will get the same number of oocytes, but possibly we might get more oocytes. And this is what we're using. When we're using freeze-all in all our freeze-all patients. We down-regulate the cycles with micronized progesterone and we trigger with agonist, and we have very good results. The final oocyte maturation part is the last part, which is interesting, and I wanted to ask you how you trigger your cycles, because we have the option to do the agonist trigger or the HCG trigger or the dual trigger. And the agonist versus HCG, it has shown by a lot of studies that in terms of efficacy, agonist trigger results in the same number of oocytes as HCG trigger and comparable and much lower OHSS rates. But are you doing dual trigger? Are you using the dual injections to trigger your ovulation? Because there have been studies by Haas showing that we can have a significantly higher number of oocytes or significant high number of mature oocytes. In IVF patients, we do it. But in fertility preservation patients, we don't do it. And why is this? Because we finalized a study, and this will come now in the fertility and sterility, it's after revision fertility and sterility, in which we stimulated two different, we randomized patients to one group to receive only an agonist trigger, and the other group to receive agonist trigger plus HCG. Because all the previous trials has compared dual trigger versus HCG. So what we found is that the effect is below, depending on the agonist. And we found that if you do an agonist trigger or a dual trigger in fertility preservation, you have exactly the same number of oocytes. And that's what we do. The new kid on the block is a no trigger, no injection strategy. Intranasal nafarelin has been shown to block the surge, but this can be used as an agonist. And our latest study that we're doing is the INFORM study, in which we randomize patients, donors, to be triggered either with 800 micrograms of intranasal nafarelin, 0.42 times per day, 2 puffs for 2 times per day, versus an injection of triptorelin to find if there is any difference. So, to cut the long story short and leave the floor open for discussion. What is new in human reproduction? The new in human reproduction is that we're freezing a lot. The freeze-all era has changed our perception of stimulation. Stimulation is not the same as before, because we can stimulate harder, we can stimulate different, we can start different, we can block the nature different, we can trigger different. Why? Because this is the past. The super baby was born 1978, and the super baby was holding this, which is not a jar of marmalade. This is the first incubator. Since then, we moved to different incubators, we moved to different freezing techniques, we moved to freeze-all, and this has revolutionized the way that we are thinking of our stimulation. So what I would like to have as a closing remark is that think different, because our IVF era is different and our stimulation is becoming different, so we need to adapt to this new era of freedom that freeze-all brings us. Thank you so much for your attention.
With respect, sir, we would like to now present a memento. Can I request our chairpersons to please present the memento? Can I request the cameraman to please zoom into the memento?
Sir, perhaps there is no question for the or discussion for an oration. Purna sir will agree with this. Perhaps we should not have any discussion on an oration. So, are you agree, sir, or you want to ask something?
No questions during oration.
Nicholas, one question on behalf of the audience, or no, sir is telling no, we cannot ask any questions. Yeah. So now it is time to felicitate you. Purna sir has come, PC sir is here. So all of us are felicitating on behalf of the PRACHEECON, the international conclave. So it is an honor to again honor on behalf of the PRACHEECON.
zoom into the memento जो सर
Colleges, I think it's a memorable talk. Everybody was really impressed with the thing that you are one of the innovative concept, not only in infertility, for whole of the subject. Wherever what topic will be given on human reproduction, you will say that you will something different you will say from others people. I salute you. I really thank you from the core of my heart. And this is a small love, a memento, and I think you'll cherish it. I will hand it over, and otherwise I will send it to Satpathy that you will reach it there, and you will be really memorable, memorize all of us for that. Thank you very much. Apologize for this.
Thank you so much. Can I request Dr. Gangadhar Sahu?
Stand face to face.
Well, Apologize, I think I have told, I met you in IFS, and many times also when I met you first, I told you that love at first sight, but diverse at first night. It's not diverse at first night, it's love at first sight and love continuing for all time to come. Apologize, you remember that.
Hopefully I will manage to come to the IFS this year. Okay?
And I would now request Dr. Gangadhar to please present the mementos to our chairpersons. Thank you so much. Again, I would like to thank Dr. Nicholas for also concluding your session on time. Thank you so much. With that, we would see you soon next time in Bhubaneswar, and we break for lunch. We would be getting started exactly at 1:55 as we have Dr. Hafiz, and he's got a flight to catch.
I thank the team Satpathy for giving this opportunity. I think it's a good link between you, colleges, and the whole of the team. I again thank Satpathy and the team who has really done a good job for that. Call upon Satpathy. Please, Mr. Satpathy, come here. Mr. Satpathy, please come here.
Dr. Polypus, it was an excellent lecture. Excellent, excellent, excellent. Thank you very much for enlightening us.
Apologize, she is my teacher. She is my teacher, Professor S.N. Tripathi, another teacher, Professor Sarojini Sadan.
Thank you very much, Mr. Polypus, Dr. Polypus. You gave a very fantastic and very nice scientific lecture on infertility, though we made infertility patients very often, almost all the kind of speak, but the way of preaching and way of explaining things is just marvelous. Thank you so much.
Again, thank you so much. The faculty lunch is going to be on the 3rd floor. For the others, it's going to be on the ground floor. We're going to be starting the sessions at 1:55. The lunch is going to be on till 3 o'clock. So you can choose to eat later if you're not feeling hungry. We're going to have Dr. Hafiz Rahman going in first at 1:55.
I think the lunch has been provided by colleges. Everybody has taken full lunch. I wish that you take your lunch there.
I wish I got there to eat the butter chicken. It's my favorite.
Yeah, thank you, thank you, thank you.
Bye-bye, bye-bye.
Vaginal hysterectomy and laparoscopy. Laparoscopic hysterectomy is better. Now these laparoscopic surgeons are so adamant, we have gone one step down again and got into the vagina, passing the uterus, and started repairing vaginal septums, which we thought was much more easier done vaginally than laparoscopy, and we found today that endoscopic septal resection is much better, especially in cases of complicated cases. Now let us look into transverse vaginal septum. We classify transverse vaginal septum into simple transverse vaginal septum and mid-vaginal atresia. In cases of simple transverse septum, it has to be less than half a centimeter. All these septums which are more than half a centimeter, we have seen people cutting into the septum more than half 1 centimeter into the septum, and then try to make some hole and then just let out the blood outside, and you find that it goes into a restenosis. So it's extremely important to understand this kind of transverse vaginal septum, and this is a simple transverse vaginal septum where there is absolutely no hematocolpus. See, transverse vaginal septum is little more easier when there is no hematocolpus, but when there is hematocolpus, but at the same time when there is no hematocolpus, when there is a small hole which drains out the blood, it becomes much more difficult to operate on these kind of septum, because you will not understand where to cut the septum. If you cut little anteriorly, you will go into the bladder. If you cut little posteriorly, you will go into the rectum. So we have started operating these kind of septums laparoscopically. As you can see here, we went laparoscopically, we dissected the bladder down. We dissected the bladder down very nicely, and so that the bladder is in my hand and I am operating anteriorly, so there is no question of injuring the rectum. So basically our principle is to first enter into the upper segment, enter into the upper part of the vagina, and the lower part of the vagina anyway it is easily approachable from below. So you have your approach into the upper part as well as the lower part, and becomes much more easier. As you can see here, I am just putting a bulger from the lower part, and then I am just cutting on to the and just reaching the upper part of the septum, as you can see here. So that is the upper part of the vagina, and you can see the bulger, and this way there is absolutely no chance of cutting on to the rectum or the bladder. You can see the bladder is in my hand, and I can easily cut on to the septum here. And I find that this is much easier and better approach than just cutting into the vagina, just because the vaginally is much more visible and your laparoscopic skills are little lesser. So this way you can see that this is a small septum, this is the actual septum. The actual septum, it will be a very supple tissue, it will not be fibrotic, and it is much easier to cut. And vaginally you can go ahead and just unify the septum vaginally. It's much more easier, and you can just approximate the anterior and posterior, as you can see here, and suture it. Now, in these cases where there is a mid-vaginal atresia, this is a patient who had 3 times they have done actually transverse septum incision, and every time it just keeps on closing. And you can see she also had a cervical agenesis where we had repaired it. And you can see we are going with the resectoscope in a vaginoscopic approach. We are cutting into that small area. You can see the amount of fibrosis which is there. See, these kind of septum, if you just cut it and put a mold, it will never work out. You need to actually take out the entire fibrotic area out, and then only it will work. Because today we have seen a lot of cases, we get referrals from all over the country where recurrence of transverse septum is there, where they just cut into it and then put in a mold. They see that it just closes out again. You can see the follies inside, which was used for repairing the cervix. What we do is we put in the appendix onto the cervix, threaded onto the follies, and it works very well. And you can see the cervical canal also there. See, that's a cervical canal. That's a reconstructed cervical canal. You can see that very clearly. And these kind of septum, what we do is with a loop electrode, vaginoscopically, you can just cut off the entire fibrotic area like you do a TCR. Can you see that? You can see the entire fibrotic area. You can do a TCR kind of surgery on both sides. You reach the exact normal tissue and then only you stop. You do it on both sides and reach the exact normal tissue and then you can stop. You can see the amount of fibrosing area which is there. The same procedure can be done laparoscopically also. This is actually a vaginoscopic procedure. The same procedure can be done laparoscopically also. This is another case of mid-vaginal atresia. You can see the hematocolpus here. And what we do is we dissect the vagina anteriorly up to the urethra. The vagina is dissected right up to the urethra. Posteriorly, the vagina is dissected right up to the perineum, so that you have the anterior and posterior vagina dissected nicely. Never dissect the lateral part. Then what we do is we open up into the vagina. This upper vagina, you can see the fibrosis. See, this is completely different from the transverse septum. Can you see that? This is all fibrotic, and it is very important to open up down and excise that entire fibrotic area. In these cases, laparoscopically, we are actually excising that mid-segment of the vagina completely. We are not just making an incision. Just making an incision will allow it to just close again. Nothing happens, you get on recurrence. So you have to excise that entire fibrotic area laparoscopically, and then we are anastomosing the upper vagina and the lower vagina, again done laparoscopically, as you can see here. See that entire fibrotic area is getting excised. And then we anastomose the upper and lower vagina. As you can see here, that is the posterior, this is the lower vagina, this is the posterior upper vagina, and you suture it. And the results are actually fantastic. We have never had a recurrence after we doing this kind of mid-vaginal atresia same way. And you can see the vaginoscopic picture. And then we keep it a mold there, and this mold is there for almost 45 days, and you don't have to have a recurrent dilatation with the mold in these kind of cases. Isolated cervical atresia is another case which has to be dealt very carefully. We were initially repairing the cervix, but later on we saw that repairing the cervix, we have almost 30% recurrence again. We tried using Foley's catheter, we have used appendix, all those techniques we have tried, but repairing the cervix, we have 30% recurrence. So nowadays we started doing trachelectomy in those cases and re-anastomosing the uterus. This is where the uterus is there, and the vagina is also present, as you saw. In these cases, we dissect it down, as you can see, anterior and posterior. This is where we open the uterus here, and you can see the cervix. This is the amount of cervix which is completely atretic, fibrotic, and that is the vagina. See, this is the vagina here, this is the uterine opening, and mid-area, the cervix is completely lost. So you need to excise this area completely. If you try to make a tunnel and do something, you find that the recurrence rates are quite high. We did have 70, 60, 70% success when we used the appendix instead of simple Foley's, but at the same time, 30% recurrence in these patients, they get into again hematometra. So redo surgeries are much more difficult. So what we did is we started doing the excision of the entire cervix like a trachelectomy, and then we anastomose the vagina. That's the trachelectomy being done, and then we anastomose the vagina after putting a Foley's catheter. We anastomose the vagina here. Previously we were using Vicryl. The problem of Vicryl is Vicryl disintegrates in all these lumen. Vicryl will disintegrate much faster than what you think. It just disintegrates even in a week's time, usually. So that's where the vagina is anastomosed, and we take care that the vagina is taken over the engulfing the uterus. Actually, it really forms colpos. So it's much more easier, and it's very important if these patients become pregnant, they go for a laparoscopic encerclage, because it actually doesn't have much of the cervix, so we need to do a laparoscopic encerclage. Laparoscopic encerclage in these cases are quite successful. We have had 3 cases where radical trachelectomy was done patient went into pregnant, and then we had to do laparoscopic encerclage. So this is how the anastom was done, and then the posterior also is done. There is another entity called the oblique vaginal septum syndrome, which is very interesting. It can be of different types. It can be complete ovira, where it is closed, or it can be an open partial one, and the opening can be in the cervix or in the lower down. So here you can see a case of ovira, typical ovira, where multiple laparotomies were done. See, in some cases of ovira, people don't recognize that there is a case of ovira, and they recognize it just as an abdominal collection of blood. They do laparotomy and they let out the collection of blood without cutting the septum below, and it keeps on recurring. This is a patient where she never wanted anybody to touch the vaginal area. She was an Arab lady. 5 laparotomies done on her. You can see the mess which was created by the 5 laparotomies. And we dissected all that thing, and then you can see the vagina here. See, that's the vaginal part. And what we did is, we didn't want the hymen to be ruptured, so this was one of the first vaginoscopic surgery. We went in without rupturing the hymen, vaginoscopically, and then we had cut the septum. This is the hematocolpus which is there, and this is the vaginoscopy where we are doing the cutting of septum. So vaginoscopically, when we went, we found that it is much more easier than putting 2 speculums and cutting. You can actually see the cervix very nicely, and with the resectoscope you can easily cut and go inside, and it works fantastically well in all these vaginoscopic surgeries. And this is again another interesting case where we could not find, this is a didelphys uterus, we could not find where the septum is. We did vaginoscopy, we tried putting the speculum, we could not find where the septum is. So I put methylene blue on the other uterus and started injecting methylene blue. We could see that methylene blue is coming from somewhere. It is just filling from somewhere. We went down and saw that there was the methylene blue coming from this septum, which was completely oblique and towards the left side. See the methylene blue coming from there, and you can see on the left side it was completely oblique. See, this septum can be easily missed. And these kind of septum, even though it doesn't create hematocolpus, it does create infiltrating endometriosis. This is one thing. We have had today 15 cases of vesicovaginal fistulas due to infiltrating endometriosis. This is one thing which has to be noted. And this patient, when we went inside that septum, we saw 3 holes. One is just an endometriotic kind of cavity which was there. The other one was the normal cervix and the uterus, and there was a vesicovaginal fistula. She was not leaking from there, but at the same time she used to have hematuria during every period. So these kind of vesicovaginal fistula may not leave this side, but the blood goes into the urine, blood goes into the bladder, and as you can see here, you can see the other hole here. See that? You can see one on top. You can see on down, and that's the cervix, which you can see, and we are going inside the cervix, and you can see that's the Veress needle which we have put into the uterine cavity. So we cut the septum, and this patient had become pregnant, and we had to do an encerclage in this patient. It was a didelphys uterus. One very interesting case which we had recently, where we had the vagina. There we had the cervix, and when we went inside, we saw it's something like a unicornate uterus. This patient again twice operated, and they could not understand exactly what is the pathology. They saw a uterine horn, but she was having severe pain. And this was the picture we had when we did the vaginoscopy and hysteroscopy. This is hysteroscopy, that is the cervix. We could not find any septum for the uterine horn, but on the lateral side of the vagina, we could see some amount of fibrosis. See that fibrosis on the lateral side, on the left side of the vagina, there was some amount of fibrosis which we could see. And when we did laparoscopy, this was the picture we saw. You could see the left side horn and the right side uniconvate, and there is a bulge there. Can you see that? That's a bulge there, just below the horn. There was a bulge. This was actually a very peculiar case. That's a vagina which which is actually pulled up into the pelvic cavity, and the whole thing was lateral to the external iliac. There was a complete deformity of the external iliac. External iliac was actually medial to the uterus. The uterus was going below the external iliac, uterine moving laterally, and the vagina and the uterine horn you can see. See this one which you can see, that's the external iliac. See, this is the external iliac which is going down. And you can see that that's a uterine artery going laterally onto the uterus. This is the infundibulum pelvic ligament. She didn't have right left side kidney, and the urethra was ending blindly onto the vagina. So this part is the vagina actually, and it was ending blind. Urethra was actually ending blindly into the vagina, and we had injected methylene blue into the vagina. We could see that the methylene blue went into the uterus and traced up to the fallopian tube upwards. See, that's where we are injecting methylene blue. And this methylene blue we could trace right up to the fallopian tube. And there is a tubular cavity on the lateral side of the vagina which was going down. So these kind of anomalies has to be expected, and one of the most dreaded thing was the whole thing was lateral to the external iliac. So we had to dissect right from the common iliac down to the external iliac and then take it out. You can see that's the rudimentary horn which we were taking it out. You can see the uterine artery. See, this is the uterine artery going. That's a uterine artery. And that is the vaginal part of it. See, we could pull it out after taking out the rudimentary horn. We could pull the vaginal part of it below the external iliac. See, this one is the external iliac here. That's the external iliac. And the internal iliac was much higher. The division was much higher right from the common iliac area, much higher. So that's how it was taken out completely. And down below you could see that tubular structure going right into the pelvis. This was going right up to the urethra. And when we cut it, we could see that there is a canal inside. So these are the kind of anomalies which we have to expect sometimes when we deal with. So it's not that every anomalies in the vagina can be dealt vaginally. Endoscopy has a much bigger role. Now, the concept of vaginal plate is something which you need to understand very clearly. We have been doing a lot of neo-vaginas and creating the vagina. We have stopped all methods of vaginal neo-vagina other than ileal vaginoplasty. Now we are stuck to ileal vaginoplasty, which we find is the best method. All other methods have a rate of constriction. They get into constriction, they recur, and all problems used to be there. But ileal vaginoplasty, we never had any issues. But this concept of vaginal plate has to be understood. Whenever we do a vaginoplasty, reconstruction of the complete vagina, you need to remove this vaginal plate. You can see here, there is a clear-cut fibrous tissue which is actually the sino-vaginal bulb, which is non-canalized. So until and unless you remove that sino-vaginal bulb completely up to the urethra, you find that you will keep on getting recurrence of this type of procedures, especially when you have a hematometra and all, there is a recurrence is a big issue. So here you can see on both sides, in this side also you can see the sino-vaginal bulb getting dissected, that's a posterior. And anterior we dissect up to the urethra down. In this one, we can see the vaginal plate. See, this is the vaginal plate which is actually a fibrous tissue which has to be completely removed in any reconstruction of the vagina. So thank you so much for your patient listening.
Thank you so much. Just to let everybody know, sir has a flight to catch, and for that we would like to felicitate him right away. Can we have Dr. Bhagyalakshmi Nayak Madam and Dr. PC sir to please do the honors right onto the smaller stage while we move to the next one, because the time is also of the essence. Can I request Dr. Abhinesh Chatterjee sir to please join us as the next speaker? And in the meanwhile, do we have Dr. B. Ramesh with us? He was just last heard of taking lunch, and he's told us that he's going to be skipping dessert and he's going to be here on time as well. Thank you so much. I request Dr. Abhinesh Chatterjee sir to please start.
We all know he is a very good laparoscopic and hysteroscopic surgeon from Kolkata. Now we will be watching him his deliberation for mastering hysteroscopy for general gynecologist. Sir, stage is yours.
Thank you very much, PC sir. Great honor to present on mastering hysteroscopy for the gynecologist. And thank you, respected chairpersons and Madam Sima, an expert in hysteroscopy. So, straight into my topic. Shall I get my own
Giving its weight.
Check the screen.
Sorry for the delay. So, hysteroscopy is must for all gynecologists. It's kind of a vaginal examination without which we cannot move on. Either it's going to be diagnostic or operative. Now it's mainly for abnormal uterine bleeding, RPL, infertility, intrauterine pathologies like polyps, fibroids, synechia and congenital anomalies. Removal of retained products and foreign bodies. Now pre-operative, we should do assessment and instrumentations. We are gradually coming from 4 mm scope to 2.9 and more miniature. So everyone should have a histromat or an AMAO endomat and should be aware of the pressure settings which should be around 100 to 150 millimeter of mercury and flow rate around 200 to 500 ml per hour. A good light source, the slimmer the scope, we need more light. Good camera and viewing system, and distension media we have been operating, we are shifting to normal saline. Technique, either it can be vaginoscopic method or the conventional holding the cervix with Alice tissue forceps. Now, case selection. Now, in vaginoscopy, we have actually 3 fixed points. One is the internal os and the 2 cornues on the 2 sides. This is a normal case, and this is a case of pyometra, where you can see we have just gone in, and through the crypts of the cervix, once we go in, there will be a lot of pus there. So it's very important for us to find out, this is the crypts of the cervix, and once we are going in, you will find the pus gushing out. So you have an operative hysteroscope, and inflow and outflow channel. Through the outflow channel, you should use the suction to suck this pus out and send it for culture. Now, polypectomy is a procedure every gynecologist is doing. So you have a clear idea where the polyp is by doing a hysteroscopy. Once you see the polyp, either you take out the hysteroscope and catch with the polyp forceps and snare it out, or use plain scissors to cut the base. So this is, once the whole thing has been cut, the polyp will float in the distension media. You just catch with the polyp forceps and take it out. Now, this is a case of complete septum. The septum runs from the vagina, and you can see it runs through the cervix and the uterus as well. So you do just gentle bipolar and cut with scissors the entire length of the vagina until you reach the cervix. So once you reach the cervix, you catch hold of the cervix with lips of Alice tissue forceps, and then cut with curved scissors, and then introduce your operating hysteroscope with a Collins knife and have a good look, and then cut the thick midline septum gently from one end to the other. Obviously, you should have a look inside of the laparoscope to ensure it's not a bicornuate uterus with wide separation. So both the cornues should be in the same level, and we are using a bipolar cut in this Collins knife, where you have a cautery which has a saline underwater cut mode, and the wattage should be around 100 watts of pure cutting current and a coagulation current of around 80-90 watts. So you just turn the camera and the cable, because it's a 30-degree scope, until both the cornues are in the same level, and the depression of the uterus usually goes with this. This is another case where we are doing a TCRS and a lateral metroplasty. This is a case of RPL. You do a hysteroscopy. Once you go in, there will be a midline small septum, and the cavity is very small. So the whole idea in a case of RPL is to enlarge the size of the cavity. So that is the midline septum, and you can see in HSG she had a T-shaped uterus. From the internal os, you can't see the cornu. So there is also flimsy adhesions in this cornu, which we are opening through the back of the scissors. So if you do a hysteroscopy in a proper way, a lot of things can be achieved. So once you open it up, you will find the patency of the tube is also restored. So again, bipolar Collins knife is being used to cut the midline septum, which is a depression, and then you will be doing a lateral metroplasty. So how we do a lateral metroplasty? From the internal os, you should be able to see the cornus on either side. So this is how you just go on cutting gently with your bipolar Collins knife, and ensure you can see the internal os from the cornu from the internal os. So this is how you keep on enlarging the cavity, such that chances of RPL will be much reduced. So end result, it will be a good cavity formed. This is again a bicornuate uterus where the midline depression is minimum. So we will be planning to do a hysteroscopic correction. You do initial diagnostic hysteroscopy. See, there is a depression there, it's a broad fundus, but if you do it hysteroscopically, the results of pregnancy, the take-home baby is much less than if you do laparoscopic unification. So again, the same Collins knife being used, and you will be cutting the thick septum, and this broad fundus will be much rounded off. Same technique, both cornus should be in the same level. We are using bipolar Collins knife, and always you should rotate and find out the right and the left cornu, how much we are left to cut. Very important to be gentle. For beginners, you should touch the tissue first, then apply the current. Activate the pedal first, then touch the tissue for having a good cut. The current flows between the tip of the Collins knife and the bipolar plate. So the end result is an enlarged cavity, but since there is a depression of the bicornuate uterus, ensure you don't overcut. So it's a much corrected uterus with an enlarged cavity. Now this is a case we are doing a bipolar TCRM and TCRS in the same patient. See, this is an infertile patient. Again, there is a depression in the middle where there is a small septum which needs to be cut, and also there is a submucous fibroid there which we are cutting. In submucous fibroid, always try to cut towards you, that is backward cut, because that is much safer. And here we are using the Collins knife to enlarge the cavity and take care of the septum. Again, same patient, this is another patient where also we are doing the same procedure. See, this is a case of a septum along with a fibroid. So we are resecting the fibroid with a loop electrode, same bipolar loop electrode, and ensure you are getting the whole fibroid out. That is very important. Small cuts won't help in these cases. You should have good cuts. This is the lab view actually. And ensure the entire fibroid has come out and there is no remnant pieces, and any bleeding should be coagulated with coagulating current. Again, bipolar TCRM being done in this case. There is a polyp there, there is a fibroid. Again, 3 fixed parts as I suggested. There is a fibroid which is in the cavity. We go for a laparoscopic view as well and see how we are cutting. We have developed both part for this kind of resectoscopic practice, and the STORT has the Lyra model of hysteroscopic training, which is a good simulation for this kind of practices for beginners. But ensure the entire cavity should be free of fibroid. That is very important. And once you see there is another fibroid near the internal os, that should be also resected. In doing a saline bipolar resectoscopy, the deficit should be maximum 2.5 liters in normal saline, and if you are using glycine, the deficit allowed is maximum 700 to 1 liter. So you should abandon the procedure once you have reached that stage. So what we suggest is a hybrid procedure. You cut with the resectoscope and also use your polyp or ovum forceps to snare up the tissues which are remaining. Then again go in with your resectoscope and have a look for completion of the procedure. That is very important. Whatever remnant bits should be taken care of, and the cavity should be free of any fibroids. This way you can reduce your saline deposit, but obviously you should be using a histomat. This is a case of Robert's uterus. In Robert's uterus you have one cornu which can be seen and the other cornu is not seen, and there is a thick septum but that's a big cavity. It's very difficult to find the other cornu. At times you don't have, in this kind of cases, any hematometra or any mucus also in this cornu. So you have to be bang opposite the other cornu and use your scissors initially to find the cornu and then use the Collins knife to enlarge the cavity. See, this cornu was totally obscured by a septum which we cut with scissors initially, and once we saw this right cornu, then there is a thick midline septum which we are just cutting and making the cavity right. At times Robert's uterus can be very deceptive and very difficult to do, so per-operative ultrasonography at times helps. This is a case of ovular syndrome Dr. Hafiz sir has already shown. So this is obstructed hemivagina with ipsilateral renal agenesis. This is the right uterus which has the hematometra, which is pretty big. The left uterus will be normal size. You can see this is the bowel and bladder adhesions in between, and there is a lot of hematometra on this side. This is the left uterus which is small. The left cervix you can see, and there will be the bulge of the obstructed hemivaginal septum. So you cut with Collins knife, and just at the depression you can see the hematometra being drained, and once you cut in more, you will see more of the hematometra coming out. So you carry on cutting the septum which is in the vagina, and until you have cut the whole septum, the hematometra should be drained well, and these have excellent results. Now coming to ismosil, which we are getting every day in our practice from cesarean. So what it is exactly? You have an internal os, you have the two cornus, and just after the internal os there is a depression of the cesarean scar. What happens? This is the area of the ismosil. If this patient is not planning fertility, then there will be some nagging, spotting, bleeding throughout the period cycle. The blood gets collected in the ismosil area and it spots throughout the bleeding and causing intermenstrual bleeding. So we do a resectoscope with a loop electrode and make it smooth from the fundus till the internal os, and the results are excellent. So you just carry on smoothening the edge such that the internal os and the fundus come in the same level and the dimple goes. You can also put in Mirena coil in these patients, and obviously if the patient is wanting fertility, then you have to resect laparoscopically and do a laparoscopic surgery for excision of the ismosil. Again, cesarean scar ectopics also can be done by hysteroscopically. We are using a cold hysteroscopy. You can see we are not using current here because the area is very slim. We are not using current, we are using the loop as a cold loop and just taking out all the products from the ismosil area. And you have to be very gentle in this because there is risk of perforation. But this can be done as well. Cannulation for tubal blocks. If you have a mucus plug, this is the mucus plug. You use a modified Novice cannula with a Terimore guide wire, and you can just go in and cannulate. It's a very easy procedure, and success rate as per literature is almost 40 to 60%. Go in laparoscopically and you see you have overcome the cornu. You can see that Terimore guide wire and a selective dye test comes positive. Broken property, again these things happen. This is the broken property and how we take it out. They are usually embedded into the myometrium. See, we have hold with the hysteroscopic grasper to the 5 French operating channel and keep on twisting until it is coming out. And once it's coming out, take it out along with the grasper along with the scope. IUD placement and also Mirena coil placement, we have recently started doing it for better results. You hold the IUD and then take it in and place it properly in the fundus such that the two wings are at the two corners. For good results, if you use this technique, the results are excellent for IUD placement, also hysteroscopy. So you can see hysteroscopy has become a main armamentarium of a gynecologist. Asherman and PRP injection, again you see this is where we use our cold scissors more in Asherman syndrome. You can see from the cervix only there is a lot of adhesion. So we are using the cold scissors to cut through and going into the cavity using cold scissors. Again we are trying to find out the three fixed points. So one contour is up, so we are finding the other contour, cutting with the cold scissors, and ultimately you will see a good cavity is being formed in no time. So once this is done, we are injecting the PRP 0.5 ml in the posterior wall, 0.5 ml in the anterior wall, 0.5 ml in the lateral walls also. And we are getting good results in Asherman, and also we are putting a copper T without copper for a while and putting them on OCP and giving good results.
Apologies, but the time is up.
Okay, thank you. Thank you.
Concluding remarks.
Okay, so concluding remark is the future is in office hysteroscopy, 3D and AI integration in many hysteroscope, miniature equipments are coming up, and fertility sparing innovations. So training is the main issue. Carl Storch has come up with the Lyra model, and our Foxy President-elect Dr. Bhaskar Pal has a dream to get that in all the tier 2 cities. And also we have developed a boat arts model for resectoscope training. So anyone interested should go for these trainings and pick up hysteroscopy. Thank you very much for a patient hearing.
Thank you so much. Since we don't have time, madam, if we can have the next one. Please, Dr. Seema.
Thank you, Abhinav. That was a great lecture. We know that you do a wonderful vaginoplasty. We are following your technique at Galaxy. And the hysteroscopy update was fantastic. Thank you for a great lecture.
Next speaker is Dr. B. Ramesh sir, and he's also told me, don't worry, 15 minutes mein main pura kar dunga. So I said, okay. We'll start the timer only once he goes live. So 15 minutes. Don't. My video guy sometimes sleeps. 3 minutes. Yes, sir, please.
So good afternoon, everybody. First of all, I thank PC and organizing team for giving this opportunity. So my topic is laparoscopic management of deep infiltrating endometriosis. I think last 10 years there has been a lot of changes in the understanding of endometriosis. So there are mainly 3 types of endometriosis: peritoneal, ovarian and deep infiltrating. I think all these years we were treating only ovarian endometriosis and ovarian endometriosis, not treating the peritoneal endometriosis properly. And deep infiltrating endometriosis, though we never used to look at it. So last 10 years suggest that treating all the 3 varieties will improve the outcome. So what is the definition of DIE? All of you know that when endometriosis infiltrates more than 5 mm below the peritoneum, it is called DIE. And these are the commonest areas of deep infiltrating endometriosis. Common is pouch of Douglas, back of the uterus and rectum. So these are the commonest areas, most dependent areas. And symptoms, especially during the periods, you must ask whether she has bowel symptoms. Otherwise the rest of the symptoms are common, but during the periods whether she has bowel symptoms or not. Diagnosis, of course, all of you know ultrasound is good enough, but nowadays MRI has become a fashion that everybody undergoes MRI and nobody sees the report. And a good ultrasound is good enough for evaluating the endometriosis, and of course these are all the findings And role of laparoscopy, I think now endometriosis is becoming epidemic in India. So the reason, if you look at last 10-15 years, there is epidemic of endometriosis. It is coinciding with Modi's period. So that means there is a lot of development, and it is a socio-economic disease. Earlier we used to have more of malnutrition, infectious disease. So now we have more of endometriosis. The credit should go to our Prime Minister Narendra. And surgeries for DIE and of course a good bowel preparation. You don't have to do 2-3 days of bowel preparation. 1 day of liquid diet and regular powder is enough. And normally how do we see the deep infiltrating endometriosis as soon as you put the scope? So this is the deep infiltrating endometriosis. So you can see the kissing ovaries and the ovaries stuck to the posterior surface of the uterus and the rectum, everything. And so now the first target is to drain the ovarian endometrioma, and the cystectomy you can do later on. So, but first is draining the endometrioma so that the space is created and you can lift up the ovary completely. And suspend it to the anterior abdominal wall so that posterior compartment, so you can do the complete dissection. So earlier, I think this was the dissection what most of the laparoscopic surgeons used to do. But the real dissection starts from here. The real dissection of deep infiltrating endometriosis starts from here. So where you separate the rectum and the uterus. So there it starts. So next is rectovaginal endometriosis. Yeah. So you can see that area is the most important one. It needs to be excised. The most dependent area, so don't get scared to go down. The posterior fornix and the retrocervical area, uterosacral ligament, the proper pouch of Douglas is the area of deep infiltrating endometriosis. And another important modification what has come up is the what is called butterfly peritonectomy or peritonectomy. So you can see this, there is a splash of endometriosis all over the peritoneum. The first part is the ureter. So ureteral lysis. So I think nowadays most of the gynae, we were scared of doing ureteral dissection. So now most of the gynaes in India, they do ureteral dissection. The credit for that should go to Shailesh Ambedkar. So he has taught everybody, how to do the proper ureteral dissection. So you can see that ureter is completely excised. You need not have to do systematic peritoneal butterfly peritonectomy. You can do in piecemeal also, but only thing is the peritoneum, the diseased peritoneum has to be removed. So if you look at this, it is exactly like debulking, how ovarian cancer specialists debulk the disease. And the next is once you separate the pouch of Douglas and once you separate the rectum from the uterus, so you will see a lot of peritoneal deposits on the rectal surface. We are lucky that the disease doesn't go into the mucosa of the rectum. It involves mostly the serosa and the maximum the muscularis. So rectal shaving is sufficient in 95% of the cases, but don't make it a fashion to do rectal dissection. So that will lead to a lot of suffering for the patient. So be conservative here. So now all over the world, everybody is trying to minimize the chances of rectal resection. Rectal shaving is good enough in most of the cases. So suppose if the disease is little bit more, so we need, and also there is a lot of endometriosis sitting in the vault. So if you don't excise those around the vault, there is a recurrence of vault endometriosis. So here, of course, so you take out and you can see the discard dissection is done coin-shaped resection up to 3 centimeter of the rectal nodule can be managed with local resection or discoid resection. So, and also, like, there is no need of using stapler in these cases. A good suturing in 2 layers and interposition of the momentum is good enough to protect the rectum. So, you can see here, so first layer is interrupted with PDS, so second layer you can use guard and interpose with the momentum. So, this is the thing. And suppose if the rectum is involved more, suppose if there are multiple nodules or if there are more than 1/3 involvement of the rectum or like stricture, rectal stricture, these 3 are the indications of last 10 years I have been performing with the conventional method of resection and end-to-end anastomosis. There has been no incidence of leakage in these cases. So I asked gastroenterologist, why do you always use stapler? So they said, sir, we are not so well versed with suturing. That is the reason, not anything else. So otherwise, there is a good Indian study to show that there is a, both suturing and stapler produces equally good results. So you don't have to worry about the leakage. Only thing is anastomosis has to be watertight, and also if there is a spillage, you have to give thorough wash before you do the anastomosis. So that is one thing. And the next one is the with a stapler. So now this is the fashion. So if you develop suture technique, so you can almost save 60-70,000 rupees on a patient without stapler, and I will tell you both are good. And so here the most important thing is completely skeletonize the rectum. So otherwise, the anastomosis will not be good. And make a small opening and wash out with betadine solution before resection. And most importantly, you ligate the proximal segment with a vicryl around so that like spillage will not be there. The spillage is the main cause of post-operative fever, sepsis, all that thing. So you completely ligate the proximal segment so that the spillage will be lesser. And use the circular stapler so that I am not fascinated by the stapler because if you can give the same result with the suturing, so why not? And so this is the endometriosis wherein stricture has been removed, and these cases will have a phenomenal outcome. So this all the studies says 95% of the rectal endometriosis can be managed with shaving, and another say 4 to 5% only need resection. So please remember this, don't do 50% resection and 50% shaving. If somebody is doing that, it doesn't coincide with the research and the data. And most of these endometriosis cases, the laparoscopic surgeon operates and they disappear from you. Why is that happening? So you must introspect. You are not guiding the patient properly, especially if they are infertile. So they are going to an infertility specialist. So later on we will come to know that they have gone to IVF specialist and they have conceived. And you will start wondering why they have not come. So immediately after the surgery, what you have to do is, especially infertility, you have to do scoring, endometriosis fertility index scoring, so by ESRM method, so that there is a scoring from 0 to 10. So above 6 or 7, the patient has got a good chance of spontaneous pregnancy. Below 6, they have to go for ART or IVF. So this scoring is very, very important at the end of the surgery, and you do inside the theatre, because once you come out you would have forgotten the findings. And post-operative, you do the ultrasound AMH test and decide whether they should go for IUI or IVF. Don't do prolonged suppression. So now that is about the GI endometriosis. The next important is the urinary tract endometriosis. You can see the bladder is the commonest, though it looks like ureter is the commonest organ affected, but bladder is the commonest area which is affected. And all cases of endometriosis, you don't lose anything just by putting the cystoscopy and see the lesions like this. And also there can be isolated nodule like this, but usually is associated with other types of endometriosis. And if you put this for spot diagnosis, the PGs will tell it is a Foley's catheter. It looks like a Foley's catheter. So this is a case of bladder nodule in a case of previous section. Especially in previous section, you look for endometriosis and separate the bladder. And the difference between bladder endometriosis and rectal endometriosis is bladder endometriosis have tendency to involve the mucosa, whereas rectal endometriosis doesn't involve the mucosa. So you separate this and do partial cystectomy. Cystectomy is a rule. Just shaving will not help in cases of bladder. And also the most important thing, any bladder dissection, you mobilize the bladder from the retropubic space so that the anastomosis or resection becomes easier. So that is how it is done. And of course, isolated bladder endometriosis. And urethral endometriosis. What about urethral endometriosis? It is believed that it is common, but it is not so common because it is the external compression of the ureter by endometriosis which is causing the symptoms. So in fact, this is one of the commonest cause of renal failure in cases of women. So earlier what urologists used to come, they used to put stent and run away knowing that there is a endometriosis behind. So now it is the role of the gynecologist. You should tell them, look, there is endometriosis behind. You are putting the stent will not solve the problem. And deposit over the ureter. So if you see the deposits or the endometriosis over the ureter, so what you do is you excise these deposits. So you can see the deposit there. There may be, it leads to fibrosis and blockage of partial or complete blockage of the ureter, so which needs to be excised. You don't have to do anything to the ureter, just removing the disease is good enough. So this is another case of urethral stricture. So like you have to take proper decision, just releasing the ureteric stricture is not sufficient. You have to do complete ureterolysis and stenting for 6 to 8 weeks to relieve the obstruction. So this is the case where there is a urethral stricture. So you can see the hydroureter there, and in many cases you see the hydroureter may not be this big, so maybe mild to moderate cases. So you release the ureter completely from the surrounding peritoneum, and you can see, and it is always, the stricture is very close to the area where the uterine artery crosses the ureter, so close to the broad ligament, that is the common area. Unless you trace the ureter downwards, so you cannot see the stricture. So you cut the ureter, the stricture area, excise that, and also I will tell you, this is not a special technique. It is like how you do tubal anastomosis in case of tubal recanalization, exactly the similar, except that you are putting the stent, and then the stent is there, it will take care of any of the ureteric problems, and if you just anastomosis. And of course the next one is when the ureteric obstruction is close to the bladder, below the level of the uterine artery, you have to do implantation, whether it is whether it is ureteric fistula or obstruction. So close to the lower one-third is always better with the ureteric implantation. The outcomes are very nice with the ureteric implantation. So don't do end-to-end anastomosis in these cases. So you can see there is dilatation of the ureter and so stricture in the just at the level of the uterine crossing. So then mobilize the bladder. So this is one technique everybody has to learn. They try to anastomose the bladder and the ureter under tension. So that is not good. And don't do the psoas cinch also, because the psoas cinch produces a lot of hip pain, and there may be traction on the genitofemoral nerve. Patient will find difficult with this. So nerve sparing, of course, the God is very kind that he has got the nerves. So nerve in the deeper plane. If you are doing the deeper this thing, so it is the nerve should be identified in Okabayashi space between the uterosacral ligament and the ureter, and naturalize the nerves like how we do in radical hysterectomy. And the worst, don't go on postponing the treatment of endometriosis with suffering with the pain. So finally you take a decision once she has crossed 40 and completed the family. So radical excision or DLH with BSO and complete excision of the endometriosis is the treatment for endometriosis. And in case of infertility, addition prevention is important. And of course, you have to put them on long-term progesterone for suppression of the pain. And we studied 140 cases, and we got the pregnancy rate of 60%. So 50 to 60% is the standard pregnancy rate in cases of endometriosis. And once again, I invite all of you to participate in our conference range organized by Karnataka chapter of IHE on 20th and 21st, and all the guides of endoscopy will be participating. So please visit us and please join us. So thank you very much.
Thank you. Great sessions. This is intelligently put them after lunch session because most of us are in drooling stage. So thank you for the speakers, and if you have any questions, and then you can answer.
So the questions we can take over a cup of coffee because we are run out of time. Can I request the chairpersons and the speakers to please join us onto the podium, onto the left hand side, as we would like to felicitate them. Can I request Dr. P.C. Mahapatra sir to please do the honors and felicitate our speakers and the chairpersons with a memento. In the meanwhile, we are getting started with the podcast. And this time again, we have our podcaster. We've got Dr. Sujata Mishra, who is our host. And I request Dr. Sujata Mishra to please join us as we can see her right at the center. Right, chalu kar de. And she is walking right ahead. Yes. Lights on. Here we go.
Light on.
Light chalu karna, spotlight. Yes. Right at the center. Yes, ma'am, you can start walking. Everybody give a big round of applause for our podcaster.
for having me as a part of PRACHEECON. Now, it's my privilege to, all of you know him, but nevertheless, the most accomplished person, a charismatic personality, a contented person, a complete person, 4 C's. We have Professor Shyam V. Desai for you. Sir, can you please? So, all of you know he's been president of Oxford, he's been president of IIT, he's been president of Moss, he also has been president of
Well, I always
wanted to become a doctor in my school days as well. Especially because I knew some very eminent doctors, family contacts, and I liked the way that they functioned, the respect that they got, the service that they gave to mankind. I think that was most important in making me take a decision to take up medicine as a profession.
So you never ever regretted it? We are unplugged. I don't want anything but the truth coming out of you.
No, well, there are certain situations when you are stressed, you are looking after patients, giving the best of your talent and ability to do so, and yet sometimes the results are not that, very successful. And that is when you feel that sometimes, your effort that you have put in can sometimes not be rewarded adequately. But still, overall, I feel that the plus and the minus, you consider them. I'm sure there are many more pluses than minuses regarding this profession.
Okay, so fine. So you're very happy being a doctor. So after you graduated and you see people in the corporate sectors, those who do engineering and stuff like that, they make it big very soon. And then you keep thinking, oh my God, I still have to do my post-graduation and not much in one's pocket. You forget about what the family has. I'm talking of yourself as an individual. Did you ever have that feeling?
Oh yes, certainly, because our postgraduate, or rather even the MBBS course, is a very prolonged and protracted course. And especially when you take up post-graduation, spending those nights with the patients, looking after them, and sometimes in the morning you don't get enough sleep and you're working the next day continuously, you do feel that you're a little stressed. But overall, you feel that, well, maybe as I go along, the rewards will come sooner or later. Maybe your classmates have started earning very well.
100%.
Very well, 2 or 3 years of their graduation. But you are still struggling and you're still on that measly stipend which you get as an RN.
So then, none of us have ever made a mistake, right? We all thought about that and we've all crossed that stage. So that's good enough, sir. And so do you think during your MBBS or PG days, anything you would like to talk to us about? Any anecdote you remember relating to your work conditions, your friends, anything you feel is worth discussing out here?
Yeah, so when you are doing your post-graduation and in a general hospital, there are so many situations in which you find it humorous. At that particular time, you are looking after patients, and sometimes patients come to you with their queries, and sometimes it's so very amusing. I remember when I was a resident in the KEM hospital at Mumbai, and we were looking after a patient who was not a very well-to-do patient, and they were obviously not very educated themselves, and this patient had an ectopic pregnancy. And then this particular patient required blood because she had bled quite a bit. So we told the relatives, come here, you have to go to the blood bank and donate blood. So that there were 3 or 4 very well-built relatives that she had. And then they came and said that they discussed amongst themselves. They says, why do we have to give blood? So I said, because you have to replace the blood, or maybe your blood group is the same. We'll give your blood to this patient. And then they again got together and they concurred amongst themselves. And then they came back and said, kutte ka blood nahi chalega. So sometimes you have to deal with relatives who are not educated, and then you have to get past them and try and tell them to donate blood. So these are some of the situations which you come across as a resident.
So I came across a confession, let's call, which you had kind of penned down. It was penned down by Suvarna in the Monks Society book, in which Sir had said that he met a very pretty lady called Meena. That statement is written there. So can you elaborate on that? I mean, I need to know a little more. I've shown some beautiful pictures, but a person saying, even now, after 30, 40 years, that in 1978, I met a pretty lady. I want some stories from there.
Yeah, I suppose, your impressions of those days remain with you lifelong. Yes. That's what keeps your marriage going and your, love life going. Meena was known to me as a undergraduate student, but I really got to know her well when she came as an intern when I was a registrar in the gynec department. And some of our duties involved sitting in the OPD or the endocrine OPD in those days, where we used to do cytology, we used to do, and Dr. Indira Hinduja was in charge of it, and I was the registrar, and she was my intern. And that is where I got to know her even better. And that 2 weeks that she spent with me in the endocrine department was enough to set the flame for the entire marriage to our.
So in 2 weeks you decided who would be your life partner. And sir, how much have you contributed to the family? Sorry for asking so.
How much have I contributed to the family? Looking after the children?
Not looking after, in whichever way you think a father should contribute, considering your very busy schedules.
Yeah. And as a medical practitioner, you are extremely busy. You start early in the morning, where you start operating maybe at sometimes 5:30, 6 in the morning is to start. Then finish those surgeries, then go to the KM hospital where I was an assistant professor and subsequently an associate professor. And then as an honorary, and somewhere you lose the chance of waking up your children, dressing them up, getting them ready to get into the school bus and seeing them off to school. You can't do that because as doctors we are so busy in the morning. And then when you come back in the evening, you find that they've already had their dinner and they've gone up to sleep. So that is where we miss out on looking after our children. But you try and make up on weekends, you try and make up on when the vacations that you take together.
So Meena to good care.
Yeah, so it's mainly
the conclusion is Meena to good care. Yeah, we all agree. Sir, we'll go forwards from there. Now, you got into laparoscopy since 1990, right? And we remember 1998 to 2002, you were here for several workshops. So could you enlighten, since there's a session on laparoscopy, how you got interested, how it got going? I guess you opened the first training center at Mumbai also.
Yes.
So we'd like to listen to it.
In fact, our association with laparoscopy started in Wadia Hospital. And we had eminent professors, Dr. M.N. Parikh, Dr. Deena Patel, Dr. Motashaw. In fact, I was Dr. Motashaw's house surgeon. And in 1976, when I was a house surgeon, we got the first laparoscope in India. And this laparoscope was presented by the Johns Hopkins people. And Dr. Motashaw was given the piece to start laparoscopy in India. And we as her house surgeons used to help her and assist her in doing laparoscopy. So that was my first introduction to endoscopic procedures. Subsequently, we used to go for laparoscopic sterilization camps with Dr. V.N. Purandare, Dr. D.K. Tang, with Dr. M.N. Parikh. And at these laparoscopy camps, we used to literally operate with basic instruments and basic facilities. I remember we used to go and carry out these camps in schools in Maharashtra. When the school had a holiday, so we used to use the same classrooms to carry out our 5 or 6 laparoscopy tables. And we used to use the benches that they had in the school as our operation table and put a couple of bricks under them so that we got a head-low position and we were able to give head-low to the patient. The local medical officers would inject pethidine and Sigvil, and then the patient would be under the effect of that short analgesia and anesthesia, and then in that particular time you used to put in the laprocator and do the operations. Well, that was very, very basic that we used to, facilities we used to start with. But then subsequently, in Wadia Hospital, we had fairly good, enthusiastic residents. And I remember myself and Nozer, 2 of us, did the first endoscopic surgery over there. There was a sub-serous fibroid, and without the camera, looking down the scope, we managed to excise that fibroid and take it out through the pouch of Douglas. So that was the first endoscopic procedure which we did, and we had extremely good professors and teachers from abroad who used to come. Professor Zem used to come. We had this workshop with Professor Bruha, thanks to Dr. Khandwala, who was the secretary of the IIG at that time. And we assisted these very, very eminent surgeons. And with the help of Professor Bruha's magnanimity, Dr. Amar Bede and myself went to Clemafero. And I was one of the first few people from India to reach the Clemafero Center. And we carried out observation as well as assisting at these surgeries. And that's where we saw laparoscopic hysterectomy, laparoscopic cystectomies and various procedures where Professor Arnaud Vartiers and Michel Canis and Professor Brua himself were there to demonstrate various complicated procedures.
So in spite of so much of laparoscopy, now in 2005 when you became Foxy president, you went on to labor and optimizing labor as your theme. Just a question.
Yeah, because I knew that, well, endoscopy is for a few people who are interested in it, but obstetrics is the bread and butter of almost 80 or 90% of gynecologists and obstetricians. And therefore that would be a topic which would interest more people in Foxy as compared to endoscopy. And besides, I was already in IIG president at that time. So the IIG functions and the IIG conferences were going on. And I remember the first conference that we had, one of the first few conferences we had as the president was in Orissa, where Dr. P.C. Mahapatra was given him the option of running this conference. And he did a wonderful job. And that is how endoscopy moved on from being a domain in Mumbai to a national passion. So that now we have endoscopists all over the country who are now availing of this particular modality.
Thank you, sir. Let's talk about Foxy. So was Foxy a compulsion, an obsession, or a passion? I want one answer.
I think over the years it has turned out to be a passion.
So initially it was a compulsion?
Initially I was new to it because I didn't really know.
No, sir, one answer. Yeah. It was a compulsion by your mentors, or it was what was the other thing I said? Yes, obsession.
No, I had just got into the managing committee of the Mumbai Society.
So it was an obsession.
Yeah, I wanted to become some sort of participant in the administrative affairs of the organization as well. But then as soon as I got into the Mumbai Society as one of the managing committee members, the post of joint treasurer treasurer of Foxy came up in the next meeting, and I applied for that post, and fortunately I got this post myself.
So, during your tenure as Secretary General, I think 1998 to 2002, I remember sir used to come for our very first operative workshops, lab workshops with AOGO. So would you like to enlighten, I mean, your memories, your experiences with AOGO at that point of time?
In fact, I had the opportunity of coming into contact with Dr. P.C. Mahapatra through the managing committee of Foxy, and I found him a very enthusiastic leader in Orissa. He was enthusiastic, he was extremely keen on getting newer things to this particular state, and he invited me for one of the workshops, or the first workshop that he conducted in endoscopy in Orissa. And I remember at the medical college, Dr. P.C. Mahapatra was there himself, Dr. D.K. Patnaik was there, Dr. S.K. Mahapatra, Dr. Hara Patnaik, Tushar Kar, and there were several very, very eminent people who have now risen to a lot of eminence, who were there as resident, as people, faculty who was supervising the various workshops and the cases being carried on in the workshops. And they also were extremely helpful and very friendly, and that is how I got to know all of them very closely.
So in your journey in Foxy, did you believe in having, or did you have any mentors who kind of were your, encouraged you to follow the line that you wanted to follow?
Yeah, for example, now we have eminent people like Dr. M.N. Parikh, Dr. R.D. Pandit, Dr. Patwardhan, Dr. S.N. Daftari, who are there to guide me through the entire process of learning how to take care of the Foxy activities, and I'm indeed indebted to them all, because with their help I managed to reach the role of the position of the president of the organization.
So after you completed the presidency, sir, no regrets?
Pardon me?
After you completed presidency, how was it? What was the feeling once you finished it? The next step?
Well, when I was the president of Foxy, as I mentioned earlier, we had a theme of Foxy which was optimizing labor for safe motherhood. And that was a theme that we pursued throughout the country. And this particular theme was very gratifying. We had a company which took care of 66 workshops all across the country. And these workshops were aimed at giving practical knowledge to the participants in the workshop as to how to conduct the delivery, how to monitor the delivery. Most importantly, you don't just leave her to her own, that she comes in labor and you keep seeing her every 4 hours or 5 hours. Make sure that she goes into active labor. Make sure that she's not dehydrated. Make sure that you chart a bartogram. So all these things are very, very important in day-to-day obstetrics, and we were stressing on that, and that is what we accomplished in these workshops. At the end of my presidency, I was extremely happy with the theme that I had chosen, because that went to one and all obstetricians across the country.
So we leave FOXI for some time. Let's go to international associations. You know, everybody makes it first into the local, and then you go on to the national, and you start dreaming of international. So how did you make a dent there? I mean, you know, CEFOG, AFOG, you know, all those associations. Yeah. You've been the chairman, you've been the president, you are the sitting president of CEFOG.
So I, being the Secretary General of FOXI, I was given the opportunity of being an office bearer of the South Asia Federation. It all started from there. And it was amazing how interacting with international people, international organizations, and international faculty, one is able to widen one's horizon. And as being the Secretary General of, then subsequently I became the Secretary General of CEFOG. I was holding that post for 7 years. And I got to know the various people from Pakistan and Nepal and Bangladesh, Sri Lanka very closely. And that is how I went into the international scene. When I went to the AOFOG, I went there as a representative of FOXI to the AOFOG. And at that time, there's a lot of, groupism in these international organizations. And some of the people from the north of the area, that is Japan, South Korea, etc., they try to propagate their own people, or rather make sure that they have a lot of their own countrymen in the organization. And then there was a post for the chairman of the Maternal and Perinatal Health Committee. Now this Maternal and Perinatal Health Committee is a committee which is very important because it has a lot of things that one can do as a chairperson. And they said that, well, we have this person from Japan over here. He's been the chairperson for the last 4 years, and we want to give him 2 years more. So you cannot, get that post. And then I said that, well, Japan, what is the maternal mortality and what is the perinatal mortality over there? It's very low as compared to South Asia. They said, I am the Secretary General of South Asia and I would like to take this particular post. And they all unanimously said that, well, that is where the person for the chairperson for the maternal health should be. And that is how I got elected to that post. So that was something where I had to fight an election at the international level and putting up a very plausible argument. They said that, well, naturally you have to, have someone who's a local person over there, and especially one who's in the CEFOG, and that is how we can, do the good job in the AOFOG as well. So I continued in the AOFOG for 4 years, and subsequently AOFOG also widened my horizons. So from 5 countries in South Asia, I had 23 countries open to me for various, projects and various meetings. And so that is how I went to places like Fiji, and I went to places like Ulaanbaatar in Mongolia, and we went to Jeddah because that is where AOFOG has its reach. And that is how my horizon widened even further.
So sir, do you think, talking about advances in laparoscopy with the robotic surgery, with all the immunofluorescence techniques and all, is it a boon or a bane? I mean, what do you think? Because we are now going to wind up in about a minute's time, and we'll have some rapid fire questions. So this would be
I think as we evolve in medicine, all these various improvements or modalities like laparoscopy, like robotic surgery, like IVF, like various advances in IVF are important because we are evolving and making it even better for our patients too.
So after becoming so good in laparoscopy, so why did you suddenly, we heard that Dr. Desai started doing infertility practice. So why?
Because many of our patients who come for endoscopic surgery are keen on conceiving. So endometriosis, fibroids, etc. And that is how you tend to get patients who are deep to conceive.
30 minutes, 30 seconds more, and we just have 5-6 questions for you. Number one, was your life a bed of roses?
Life?
A bed of roses?
No, certainly
No,
not.
it's never a bed.
It's never a bed of roses for doctors.
So was Gaurav more accomplished or Radhika? Son and daughter.
I have 2 children. One
Yes.
is Gaurav,
No,
who's
you have to say which one.
so one took up medicine and he wanted to become a surgeon like me, and Radhika preferred to be a dentist. So she's has reached her own mark in the field of dentistry as well. And she's in the UK, and she's the deputy dean of the
So both have done very well.
Queen Mary
So both have
University.
done well. So are you a foodie?
To some extent, yes.
Unhealthy habits that you would have loved to leave? None? So you're a great personality.
Except that I feel that with my busy schedule, sometimes exercising is not available.
But you do exercise?
I do occasionally.
Very good. So he exercises also. So that brings us to the end of this podcast, wherein you met a charismatic personality who was a brilliant academician, who exercises, who loves food, who's got lovely children, who's got a lovely wife and a lovely profession. What more? Thank you so much, sir.
Thank you.
Thank you so much. Can we have a standing ovation for both of them? And with that, can I request Dr. P.C. Mahapatra sir to please join us on the stage and felicitate both of them for giving us your valuable time and for being here. Dr. Bhagya, can I request Dr. Bhagya Mishra ma'am to please. Dr. P.C. sir, can I take the opportunity to have Dr. Bhaskar Pal also felicitated because he has a flight to catch after his talk. So we'll save time and we'll have his... पहले करते हैं sir? Because तब तक वो मेरा setup हो रहा है. अरे sir लेके भाग जाओ sir. Can I request P.C. sir to also felicitate Dr. Bhaskar Pal sir on the stage please? Thank you so much. With that, can I have the chairpersons for the next session to please join us on the stage? We have Dr. Indra Palo, Dr. Shivnanda Nayak, Dr. Prithviraj Shetty, Dr. Madhumita Mohanty. Can I also request our first speaker, Dr. Bhaskar Pal sir, to also join us? The total time allotted is 18 minutes. Can we have Dr. Bhaskar Pal's presentation on the screen, please?
Good afternoon all. Everybody might be here knowing the history of a story of Abhimanyu. Abhimanyu learned how to go inside the Chakravyuh inside her mother's home, but his mother slept and he could not know how to come back safely. Let us learn. We all are here, the laparoscopy surgeons are there. They are very good surgeons, but here we listen from none other than Dr. Bhaskar Pal, who will be controlling our 40,000 functions, mind and body, heart of the functions, in the next year, and we'll listen how we'll come back safely after a good laparoscopy surgery. Over to you, sir.
Thank you, Indira, but the word is not controlling, it is nurturing. Not controlling. Okay, I think PC sir, I was telling him that this is the way, I always tell him that we are like Ecalapa to him. We were not his direct students, but we look at him from far and we say, this is the way we want to talk, this is the way we want to operate. And we are Ecalapas. Arjuns are sitting here. And I told sir, this is the way we should have conferences, single hall, 1.5 day focus, come and on a day I want endoscopy, infertility, today I go back. And only he can think of this topic. When I told him what I want to speak on, Sujit called me up and sir said, name the topic as how to deliver. And even somebody seasoned like Indira got very confused that what are you talking in endoscopy session? Then I told her I am speaking on how to deliver at laparoscopy. So tissue retrieval in laparoscopy, I'll start from very basic, simple ones to advanced ones. And for those of us who are also doing robotic surgery, at the present moment we do have a problem that sometimes after robotics we have to move on to traditional laparoscopy just for tissue retrieval. Ectopic pregnancy, adnexal mass, fibroid and myomectomy, and uterus and TLH. These are our 4 main issues. What we can do, the easiest thing to do when we are dealing with ectopic or small cyst, something that I am not going to show, that you can railroad it into the 10 mm port, or you can put a 5 mm scope and take it out from the 10 mm port. But sometimes you might need to fashion the adnexal mass into a longitudinal strip. For all large masses, what we do is an in-bag removal, different kinds of in-bag removal. So let me just see if I can fast forward this. Why can I not fast forward this? So the simplest thing to do, so this is I think this is a torsion of an ovarian cyst. So after we do cystectomy, what we do is to, if we see that if it's an ectopic, it is anywhere on a tube, it's a longitudinal structure, it's very easy either to railroad into the port or take it out through the 10 mm port after putting a 5 mm camera from one of the side ports. Or this is what you do. If it's an ovarian cyst, something like that, what you do is you will cut it off into, make it a longitudinal strip and then take it through the 10 mm. That is what it comes easily. This is what we are doing. Instead of putting in a bag or so pulling and etc. So we just make it into a longitudinal strip which can come through approximately with a width of around 1 centimeter or 1.5 centimeter, and then you can just put it out through the 10 mm. Now there are, in different situations you have to go for different things. Now this is something, large ovarian cyst, we are worried about spillage. This is, you can see that that's a normal ovarian, this is from where a torsion had happened. And large ovarian cyst, if we are not worried about malignancy, but we are worried about spillage, then we take them out through a simple bag. Like this is a simple bag, you can take a bag of the classic drape or any one of the other things that comes which is sterile, and you take that bag and you put the tissue into that bag, especially true for dermoids. And then what you do is you take it out through one of the side ports, you take out the edges of the bag through one of the side ports, and then put your instruments in there and then gradually take that specimen out. That is what you do. So these are the 2 simple things that we can essentially do, especially when we are dealing with benign pathologies in the adnexum. Now sometimes you have to think out of the bag. This is a lady who's a postmenopausal lady, came out with this huge ovarian mass. And although it seemed to be benign, we did not want any spillage to occur, because being postmenopausal there's always a chance. So we were wondering what to do, and then we thought this is the morcellate bag which I'll show you later. This is in which we do our in-bag morcellations. So we put the morcellate bag through the vagina because we're doing a hysterectomy as well. And then we put the mass into the morcellate bag. And then just we do like a reverse of a laparoscopic way. So we take this rim out through the vagina. And once we take this rim out through the vagina, then we can do whatever we want vaginally. The only precaution that we take is that this is the The other camera end, we just keep it closed so that microspillage doesn't occur from there. So once from the vaginal end, we would have taken out, which turned out to be a twisted and degenerated dermoid. Once we taken it out, then we can take out the bachelor vagina. So you can see absolutely no spillage. Even if it comes malignant, we haven't done anything, and we proceed with the wall. Uterus at a total laparoscopic hysterectomy. At one point of time, people would show us that taking big uteri out with a morcellation. Now, from the time that we stopped doing naked morcellation, and I know it is a debatable matter, there will be a lot of people who will stand up and say that it is not cost effective to do an impact morcellation everywhere in this country. But I think we should generally avoid naked morcellation because of two reasons. The less important reason is for fear of malignancy, because that's very rare. But the more important reason is that there is microspillage of tissue, and especially when you are doing a morcellating a fibroid, many of us have gone back later and seen that there is studied leiomyomatosis all over the peritoneal surfaces. So we are now a country which is very good at vaginal surgery, and I'm standing somewhere from where the Society of Vaginal Surgeons started, and I think with laparoscopy all of us have become better vaginal surgeons. So uterus at laparoscopy should always be removed, almost always be removed vaginally. And size is not a concern. You can bisect it, you can morcellate it, and my friend Abhinivesh is sitting here, and this is a video, it's given to me by him, and this is what many of us call the pineapple technique. And if you go to the pineapple, the roadside pineapple seller, and if you see how he takes out the skin of the pineapple, that he goes in a conical manner, taking a strip out, and this is the whole principle. So what you need is this claw forceps, and what you do is you hold with the claw forceps, and then you cut at one angle, twist, then twist it, and you cut it again, gradually you keep going up. So the whole uterus would come out as a longitudinal strip. It's brilliantly done by Abhinivesh and Polly, and once it comes up, once the video comes out, you will see. Looks a little complicated. Once you've done it, it is pretty simple. So cut it, and as far as you can see, then you stop, and then you reapply the claw forceps, reapply it higher, and then twist the uterus. Keep on twisting the uterus in any one direction, and that is where you are dragging this strip and gradually going up. So even quite large uteri can be taken in this way. So when you are doing a hysterectomy, you have the natural orifice from where we should be taking the uterus out. So we've spoken of adnexal masses. We have spoken of uterus, and now we will talk about how to take out myoma, and that is what I will essentially end with. It's nearly done. This is how the uterus looks. So we call it the pineapple cut technique. These are the two instruments you need. You need a claw forceps, maybe two of them would be very useful, and you need a long knife with a heavy handle so that you can go deeper inside. What about myoma? I think it's a little risky doing a naked morcellation these days, and as I said, that the risk of leiomyosarcoma is not much. Leiomyosarcoma, the risk is around 1 in 500 to 1 in 1500 in different studies. Malignant degeneration of fibroid is extremely uncommon. Leiomyosarcomas are essentially new tumors and not a fibroid which has been there for years. That is not the major reason to avoid morcellation. The major reason to avoid morcellation is on redo laparoscopy. We can see myoma studied on the anterior peritoneal surfaces, over the omentum, even sometimes on the bowel. So there are three ways we can remove it. In most of the times, what we do is we do an end-back morcellation. For smaller fibroids up to around 4-5 centimeters, you can take it out through by colpotomy from the pouch of Douglas. And if the patient already had a large submucous fibroid, the os will be dilated, And if you open the cavity, what you can do is you can remove the smaller fibroids through the endometrial cavity. So this is our video of in-bag morcellations. We use the Morcell bag. We've been using Morcell bags since the year 2017. And the bag goes through one of your side ports. You can take it through a 10 mm port. You can put it in the lower port. Then the advantage is that the cosmesis is better. But because the 10 mm port you close in 2 layers, the pain would be more. And if you take it on the upper port, then the pain would be less, but cosmesis would be worse. So then you do is, what you do is you put the bag in, you put the fibroid in the bag, and then you pull the rim out through your lateral port. Then you take this sleeve, this is the bag is shaped like the stomach. And the esophagus of the bag, this is what it is. You railroad it into your camera port. And then you take it out through your camera port. And then what happens is, through that your camera goes with your insufflation, and from your inside the bag, from your lateral port goes your morcellator. So right now you have an environment which is covered by, walled up by the bag, in which the gas is causing, giving you the, I won't say pneumoperitoneum, the pneumo bag, whatever, and you keep on morcellating that, and you are safe because no particles will fly out anywhere. You are not at a risk of injury provided you can see where you are going, because you are not going to, the bag protects your morcellator from your other structures. So that is how essentially you go. The better you get at morcellating, you will get longer tissue strips, but that's not necessarily a challenge. And finally what you do is, the esophageal end of the bag, please tie a knot there so that there's no spillage, and you pull the bag out from the left side from where you've been morcellating. I think this is more or less another video of this similar thing, and I would for rather skip that out of 5 minutes. This is the Morcell bag, and this is how it looks like. So you put it flat on that, and then you can see that that is on your right, that is the sleeve through which the camera will go, and this is on your this side from where you on the right. What you have is from where your morcellator will go, and then you fold the. Make sure that the biggest challenge is so that the bag doesn't get twisted inside. So you can see that one side is blue, one side is black, and if you align your colors together, then either you are in the same plane or you are completely 180-degree twisted. And that's a challenge. That takes time straightening the bag. So you fold the bag and you put it into that inserter that comes in, and then you put that inserter through the 10 mm port. Usually we do it from the left side, and from there we put that. And then we pull the bag inside, including the rim. The rim would need a little bit of pushing in. And then what we do is, as we showed, that is what we do. Now, I think this is a very good way of removing fibroids. This is a little dark. And up to around 5 centimeter fibroids, we can remove it through colpotomy. I think many of us who are a little old, we have done LFEHS, and we are very familiar with this. Just put a simple sponge holder in the pouch of Douglas, just between the insertion of the 2 uterosacral ligaments. Use your monopolar hook with a cutting current to open that, and take your fibroids through that. If the fibroid is degenerated, even larger fibroids you can take out through posterior colpotomy. If they is non-degenerated, then essentially I would think around 5 centimeters you can take it. Some people leave that open. We prefer to suture it, and it is just put some interrupted sutures. It is only for apposition, for no other reason. So I think, being gynecology, smaller fibroid, if you want to cut cost, rather than arguing that I will do naked morcellation, it is a better way of taking it out is through the pouch of Douglas. Now this is not something which you come across every day, but this is a lady who had around 20 fibroids, including submucous fibroids. And we knew that she had submucous fibroids, so we had to open the cavity also. And then what we decided is, let's see, one of our teachers had taught us that if there is something inside the uterine cavity, the os will always be open. And that is exactly what happens. So you can actually try and push the smaller fibroids through that. Yes, obviously you will have to morcellate, but your morcellation time will decrease if you can remove some of these fibroids through the pouch of Douglas. Through the endometrial cavity. And in fact, after removing from the endometrial cavity, depending on the remaining size, you can decide whether you want to take them through the pouch of Douglas. You can see that small fibroids, we are putting it in From there, we are getting a little ambitious. We're taking a very, very hard calcified fibroid, trying to push it in. If it goes easily, we'll let it go. If it doesn't, then we'll leave it out to morcellate it or to take it through the pouchoproctus. So these are very rare situations, but usually we take it out through either the pouchoproctus or with the in-bank morcellation. I would say that let us aim to say that we should avoid doing naked morcellations. Thank you very much.
He had to rush for the flight, and I would like to thank him for completing it before time as well. Our next speaker is Dr. Alka Pandey, and of course we would like her to join us on the dais. If you have any questions, you can definitely meet Dr. Bhaskar Pal over a cup of tea, I believe. Finish 2 minutes before time.
So, those 2 minutes
No.
So, good evening everyone, and I thank Dr. P.C. Mahapatra, Dr. Bhagyalakshmi Nayak, and the organizing team from the core of my heart. So, before I start my presentation, I have few things to say. I have requested Bhagyalakshmi to give me some topic in obstetrics, but Sir wanted me to talk on future of laparoscopy. So I said, Sir, I don't do much of laparoscopy. So next day what I found, Sir had sent me his presentation. So now I said कि अब तो बाबा मुझको किसी भी तरह से इस टॉपिक को करना ही है. So I took few of his slides and few of my slides are there. So as Sir begins with, I bring greetings to you from the land of Lord Jagannath. So this first slide is from Sir, and Future of Laparoscopy by Dr. P.C. Mahapatra, and this is from Dr. Alka Pandey's place, that is Patna. This is Durga's temple, Patan Devi, and this is myself, and now I begin my presentation. So in the ever-evolving landscape of medical science, laparoscopic surgery has emerged as a groundbreaking technique. So in the past, people used to cut and see. In the present, they see and cut, and in the future one will see and the another will cut. So George Kelly is credited with performing the first laparoscopic procedure in dogs in 1901, and Jacobius is recognized for performing the first laparoscopic operation in humans in 1910, and Dr. Udwania is widely recognized as the father of laparoscopic surgery in India. In 1970, after becoming the chairman of OBGYN of the University of Kiev, Kurt Sam and his co-workers, they demanded that Sam should undergo a brain scan, because they said only person with brain damage would perform laparoscopic surgery. Now, history of chronological milestones. In 1901, first inspection of abdominal cavity by von OTT in 1901 using a speculum and candlelight called cilioscopy. First laparoscopic appendicectomy in 1983 by Sam, cholecystectomy by Eric
Muhe in 1985. First laparoscopic hernia by girl in 1987 and first laparoscopic hysterectomy in 1989 by Reach. First robotic laparoscopic surgery done and in 1993 and first colorectal by Gaze. Notes in 2001 and sales in 2005. Now what are the advantages of laparoscopic surgery? Everyone knows: faster recovery, minimal scarring, precision and control. But there are challenges and limitations. Steep learning curve, cost considerations and limited accessibility. Procedures that can be done are hysterectomy, myomectomy, adhesiolysis, adhesion preventing agents, endometriosis, radical surgery, simplifying techniques, minimizing complications and maximizing results. Now what are the future trends and innovations? As technology continues to evolve, so too does the potential for more sophisticated, precise and safer laparoscopic procedures. High-definition 3D visualization provides depth perception and spatial orientation far superior to traditional 2D systems. This advancement could significantly improve the precision of laparoscopic procedures, reducing operative times and enhancing patient outcomes. Now, robotic systems like the Da Vinci surgical system have already made the mark in laparoscopic surgery, offering surgeons unparalleled control, dexterity and vision. Next generation of robotic systems promises even greater capabilities, including more intuitive controls, reduced physical strain on surgeons, and the ability to perform complex maneuvers that are challenging with conventional laparoscopic instruments. This now single incision laparoscopic surgery. This technique involves performing surgeries through a single incision, typically in the navel, further minimizing post-operative pain, scarring and recovery time. Now AI and machine learning. Integration of artificial intelligence and machine learning into laparoscopic surgery holds tremendous potentials. AI algorithms can assist surgeons in real time during procedures, providing insights derived from vast data sets of surgical outcomes and imaging. This technology could help in identifying anatomical structures, assessing tissue viability, and even predicting patient outcomes, thereby enhancing surgical precision and safety. Augmented reality and virtual reality have the potential to transform laparoscopic surgery training and execution. By overlaying computer-generated images onto real-world surgical views, augmented reality can provide the surgeons with vital information during procedures, such as precise location of blood vessels or the delineation of tumor margins. Virtual reality, on the other hand, offers a revolutionary way to train laparoscopic surgeons, allowing them to practice complex procedures in a risk-free virtual environment. Now, telemedicine and remote surgery. Expansion of telemedicine into the realm of laparoscopic surgery could break down geographical barriers to expert surgical care. With high-speed internet connections and remote-operated robotic systems, experienced laparoscopic surgeons could potentially perform surgeries on patients in remote areas, providing access to high-quality surgical care to underserved populations. Nanotechnology holds the promise of revolutionizing various aspects of laparoscopic surgery from diagnosis to treatment. Nanoparticles could be used for targeted drug delivery, minimizing side effects, or for enhancing imaging techniques. Additionally, nanorobots could potentially perform precise surgical tasks at the cellular level, offering new treatment possibilities for conditions currently deemed inoperable. Now, the future of laparoscopic surgery also points towards more personalized surgical approaches, and with advances in genomics and precision medicine, laparoscopic procedures can be tailored to the individual patient's genetic makeup, optimizing outcomes and reducing the risk of complications. This personalized approach ensures that the surgical strategy is as effective and minimally invasive as possible for each patient. The development of new instruments and equipment is crucial for expanding the capabilities of laparoscopic surgery. This includes creating more flexible, multifunctional tools that can adapt to different surgical tasks, reducing the need for multiple instruments and incisions. Additionally, advancements in material science could lead to the creation of smarter, more durable instruments that are better suited to the unique challenges of minimally invasive surgery. As laparoscopic techniques become more advanced, need for comprehensive training and education becomes more critical. So, the integration of regenerative medicine and tissue engineering with laparoscopic surgery could open new avenues for creating conditions that currently require more invasive interventions. Delivery of stem cells or bioengineered tissues through laparoscopic techniques could be used to repair or regenerate damaged organs and tissues, offering new hope for patients with chronic diseases or injuries. So, what is the future of minimally invasive surgery? So, minimal invasive surgery has all the content to flourish in 21st century. Day is not far when MIS shall be performed by machine with artificial intelligence, which may even have the faculty of digitalized clinical judgment. However, surgeons' conscience and intuition can never be digitalized. That shall be the only difference in human and robot surgeons. So, what does the patient of today expect? He arrives in the office or from home. He thinks that infinite amount of time will be given to him. There will be instant diagnosis, immediate treatment, no complications, pleasurable surgery, and he should leave with 200% cure. So, physician is the superhero and miracle healer. And it ought to be remembered that there is nothing more difficult than to take the lead in the introduction of a new order of things, because the innovator has more enemies, all those who have done well under the old conditions. And this is the ending slide. I fear, this is Albert Einstein. He says, I fear the day that technology will surpass our human interaction. The world will have a generation of idiots. Thank you very much. And I request you all to vote for me. I am contesting for the post of Foxy representative to AO4, and humbly request all of you to support and vote for me. Thank you very much. One thing I would like to mention about Sir, Dr. Rishikesh Pai has said in the morning that Sir's oration is at the second level. But I want to add a few things. I am seeing him from so many days, and the day Janjay Mahapatra was elected as chairperson of Clinical Research Committee, he went to Patna. Sir was accompanying him. And I've always found, sir, for Hara Patnaik, for Sasmita Square doctor, for Bhagyalakshmi, just as a bird, he extends his wings and puts all people from Bhubaneswar and Cuttack under his wings. And this is something we all must learn from him. Leaders should protect and promote their juniors. And this is a very, very important trait of his that I admire and respect. Thank you so much.
Thank you, madam, for your wonderful presentation and nice words.
Our next speaker is Dr. Vaishali Chauhan, joining all the way from Pune, where I am also from. And even our next speaker is going to be Dr. Senish Gupta, because he is also there. Thank you so much. Over to Dr. Vaishali Chauhan.
Good afternoon, everyone. Respected PC sir, a heartfelt gratitude. It's been wonderful to be here today. Jai Jagannath, Odisha asi bahut khushi achi. Thank you very much. So my talk is overcoming challenges, gynec laparoscopy. Basically, it's going to deal with intraoperative complications at laparoscopy. And I also seek your blessings as I contest for the post of Vice President Foxy West Zone. I bring to you greetings from Pune. And as I started my laparoscopic journey in 2010, and the learning curve exists, it is definitely there. And I have learned watching doyens like PC sir, like Shailesh sir, who's from Pune, and we indeed are fortunate at Pune. And I think the entire Foxy is fortunate to have learned from Shailesh sir. So, first of all, let me say that all complications are the fault of the surgeon. There are no complications which are not preventable. And it's also true that most of the complications happen accidentally. Nobody goes out there to create a complication. And this is going to happen. If you are going to do a laparoscopic surgery, you are going to injure the bladder, you are going to injure the ball. And let me also tell you that all the videos, all the complications are not created by me. And when I went back to look for the videos, I found out that it's been a very long time since I've created complications. So most of the videos, some of mine from my friends from the net. So that also made me realize that yes, our students do complications. We have become senior, we don't do complications because the learning curve is there. And there are going to be complications like these. So what to do? It's important to keep a cool mind, prepare the surroundings, plan the procedure. Previous evening, previous night, have a deep briefing with your team. Entire team should be on the same page and identify the complication, diagnose it on table. Nothing like creating a complication, identifying it, managing it there and then on the table, and this is going to save the patient. Instead of a complication, not detecting, not managing a complication is criminal, can be termed as negligence. Creating a complication is not negligence, but not managing it is definitely negligence. And the entire team really needs to be on the same page, because what you see on the monitor, the entire OT is going to see that. And many a times what happens is, there could be failure of instruments. As a laparoscopist, you are there, you put your port, you have done everything. Suddenly light source is not working, the bipolar is not working, the harmonic is not working. At the end of a large myomectomy, you realize that the morcellator is not working. So you need to have backup instruments. You need to have a backup plan. Because as laparoscopists, you are truly dependent on all these things surrounding you. Patient's position, ergonomics, especially as a woman laparoscopic surgeon, this especially is important for the ladies here. Most of the men are tall, the monitor is high up, but when we operate, especially in corporate OTs where the monitor is at a height, there are problems with ergonomics. The monitor should be below your eye level. So, creating your comfort zone, your comfort space is very important. Triangulation between the ports and the height of operating table. As for every surgery. Knowledge of anatomy, tissue identification is important. In laparoscopy, we have this relative disadvantage of relative lack of depth. But over a period of time, when you operate, you can differentiate what tissue is what, you can differentiate bladder planes and so on. And the most important point, please call for help. Have a very low threshold for calling for help. So when you talk of complications, could be the type of surgery, the steps of the surgery, it could be anesthetic complications, and as obstetricians, you know, we are the biggest predators who can damage a ureter, bladder, small intestine, large intestine, and so on. Now talking about entry techniques, major complications occur at entry, and every laparoscopist should be well versed in more than one technique. Now this is an injury by Veress needle. Yes, the way Veress needle has gone in, and sometimes this may not even be picked up. So this injury, simple thing is identifying, knowing, and how do you identify? By doing the basic steps to understand that whether you are inside. Once you diagnose that yes, you have injured, you need to suture it there and then, and that is going to take a long way in the safety for the patient. So simple safety checklist that we have: the aspiration test, the hanging drop test, hissing sound test, the manometer test, and never wiggle your Veress needle side to side. That small injury may cause a big rent and can cause more complication. So nowadays the cesarean section incidence is rising, and many a time when we do TLH, most of the time we get a scarred abdomen, previous one Caesar, previous two Caesar. So which is the safest point of entry? The safest point of entry is the Palmer's point, which is basically the left upper quadrant, that is 3 centimeter below the subcostal line. It's a mid-clavicular point, and many a time, however scarred the abdomen is, if you go through Palmer's point, you are unlikely to injure the organs. This is another interesting, you can see the primary port has gone through the bowel. Again, this kind of injury is very difficult to diagnose unless you put a port from the 5 mm, a side port, and then pick up this major injury. The practical tip of whether your primary trocar has gone through the bowel is rotate the trocar 360 degree, because the only structure anterior to the anterior abdominal wall is a falciparum ligament, and if you rotate it 360 degree and if there is an obstruction, you know you have entered the bowel. So despite advances, serious entry injuries remains a common avoidable complication. This is the safe entry which I prefer, that is the Palmer's technique, and that is under vision. You take a small neck and then you enter into the abdomen. This technique, evidence has shown, creates lesser complications. And why is that? Because this is a technique that we use for complicated cases where you are more careful and the pickup rate of complication is better, and that is the reason usually I use this technique. The open Hassan's technique is what I usually use. But you should also be proficient in other techniques. The second technique I use is under vision, visiport, or optical entry. And this is the safest entry actually, because when you enter, it is under direct vision that you are entering through all the layers of the abdomen till you enter into the peritoneal cavity. Does this mean that optical entry is safer than other entries? No, it does not mean that. It simply means that under vision, if you have entered the ball, you're going to pick it up immediately because you are entering under vision. So what is highly recommended is the optical or the visiport entry, and this is the technique which I commonly use. So yes, if there is a complication, video captures, seeing where you have gone wrong, error analysis of your error, and there's been a study on the human behavior of laparoscopists, and they have shown that going back and analyzing the error brings down the complication rate in the subsequent surgeries. Another common thing we see is overshooting of the trocar. Sometimes the trocar is just put in with force, lot of force. What should be done is controlled
in a controlled way, at a constant speed, it should be put. And overshooting of trocar can damage anything inside, any organ, or can cause bleeding like this. So controlled and constant pressure is what is required. So safe techniques could be open technique or optical trocars. Now coming to the secondary trocars. Secondary trocars, the commonest vessel which we injure, I think all of you are aware, which is the commonest vessel which we injure? Yes, inferior epigastric. So the way, how do you identify it? Many a times the architecture may be lost, you may not be able to find that, and the best way is go to the round ligament, trace it laterally, go to the inguinal canal, and just medial to that is the inferior epigastric artery. And the way when you injure an inferior epigastric artery and the way it bleeds and it pours, and if it is undetected, unmanaged, patient can bleed torrentially and go into shock as well. So it's very important to identify this and manage it there and then. Either you can use you can cauterize the bleeder, and if the bleeder is too big, then you can suture it. Practical point, when you are suturing it, you should suture at both the ends of the inferior epigastric artery. Sometimes you can also put in a Foley's and inflate the bulb and pull it up. So with traction, the bleeding stops, and then you can attend it at the end also. So coming to the injury to the internal organs, the bladder. Now bladder injury, as you can look at this video, I think all of you can identify that what is going wrong here and what is the next step and what is going to happen. So anybody, what is going to happen here? I think it is labeled also. So operating like this, with this technique, definitely there is going to be a bladder injury. So whatever could go wrong in this technique has gone wrong. And here you can see is the bladder injury. The plus point is bladder is a very forgiving organ, and as gynecologists we can also suture the bladder very easily, and there's no need to involve a urologist, but that does not apply when you do a bowel injury. It's better to involve a general surgeon, and for the bowel injury, not only because they are more expert at it, but for the medical legal purpose also. So the wrong technique is what is going to cause the bladder injury. Giving adequate traction, finding the correct space, correct dissection, all of this is going to prevent an injury like this. But like I said, bladder is a forgiving organ, and once you find a bladder injury, it's better to suture it there and then. And usually I suture with 2-0 white krill in 1 or 2 layers. Methylene blue test is also essential. Why? To look for, if you have sutured this bladder tear, maybe there is another small bladder tear which is not visible. So methylene blue should be, test should be done to look for any other bladder tear or bladder injury which you may miss. So the technique is going from the virgin area to the center. Mostly the bladder is adherent at the center, where we take the lower uterine segment incision and cesarean. So creating a lateral window and going centrally is the correct way of doing. And the way to detect if there's a pneumosac, swollen CO2 is entrapped into the urobag, or presence of hematuria or post-traumaluria. So bladder trauma can be prevented by the correct technique of bladder dissection. And when you dissect the bladder at TLH, see that you dissect it adequately, at least 3 centimeters beyond the point of vagina, where you incise the vaginal vault. Coming to the ureteric injuries, in pelvic endometriosis, large uterus, pelvic adhesions, there is a risk of ureteric injury. And like in open surgery, the technique remains the same, that you should dissect posterior peritoneum. When you dissect the posterior peritoneum, the ureters fall apart. Also, like in open hysterectomy, the same applies for TLH. Once you take uterine, you should stay medial to the uterine. The minute you go lateral to the uterine and you start dissecting lateral to the uterine, then there's a risk of injury to the ureter. And sometimes you may not pick up the ureteric injury. If it's a thermal injury, then the patient is going to come back to you after 15 days or 3 weeks with leaking, with passage of urine. So thermal injuries, cautiously using the energy sources is very important. Coming to rectal node injury, an injury like this is a nightmare for a gynecologist, and here you need to involve expert surgeon, not only for the safety of the patient but for your safety as well, and for the medical legal safety as well. Small bowel injuries are also seen in gynec surgeries, and an injury like this, which was picked up right on the OT table, is a good injury to have, because you can immediately involve the surgeon and you can immediately suture it, and this patient did very well because it was detected and managed immediately. Thermal injuries, the way you're using monopolar especially, is very important. The lateral spread of monopolar is as high as 4 to 10 millimeter, whereas bipolar is just 2 to 3 millimeter, and the least is ligation, which is 1 to 2 millimeter. So uncontrolled bleeding is another nightmare. It obscures the surgical field, and in such cases you need to be calm. You should not panic. All the blood obscuring the surgical field can be a scary situation. So in such cases, it's better to identify the bleeder, either suture it or apply a clip and stop the bleeding. So immediate tamponade, identifying whether it's a venous bleeder or whether there is an arterial spurter. Arterial spurter needs to be coagulated, needs to be ligated. Use suction irrigation or apply pressure. If it's a venous bleed, you can use gauze or swab, to apply pressure. Lower the pneumoperitoneum, reduce the intra-abdominal pressure, visualize clearly, energy, use the bipolar if you look at the bleeder. Topical hemostatic agents like Surgicel may also have a role, pack and wait. And if at all the bleeding is uncontrolled, then what do? If the bleeding is uncontrolled, if hemorrhage is more than 500 to 800 ml, the bleeding source is unclear, and patient is not hemodynamically stable, then yes, there is no harm in converting this laparoscopy to open. There could be other complications like DVT, pulmonary embolism, and that is why the prophylaxis is so important, stockings, prophylactic heparin, and so on. So in conclusion, I would like to say that complications can occur, and the more experienced a surgeon is, less are the complications. It is very important to understand the anatomy, understand the suturing technique. If you're going in doing a major laparoscopy surgery, there is no excuse for not knowing endosuturing. You should be well trained in endosuturing and understanding the principle of energy. So Hippocrates said, primum non nocere, first do no harm. And I would like to quote everybody's favorite cricketer, Sachin Tendulkar. I just keep it simple, watch the ball and play it on merit. And I think each case is different, and a plan for each case should be tailor-made and individualized. With this, I thank you all again, and I seek your blessings as I stand for the post of Vice President. Thank you.
Thank you, Dr. Vaishali, for this very informative lecture. And I think the message should be that injuries will occur, but we need to detect it there and then and repair it. Thank you very much.
Thank you, madam.
Thank you so much. Can I request the chairpersons and the speakers to now please join us on the stage on the left hand side for a memento. Can I request Dr. Hara Patnaik sir to please do the honors and also present the memento to our chairpersons, as the chairperson presented. Can I request Dr. Janmeja Mahapatra sir to also please do the honors? In the meanwhile, we would like to move to our oration. Can I request Dr. S.K. Mahapatra sir to join us as the chairperson, along with Dr. Bharti Mishra, Dr. Manas Ranjan Sahu sir, and Dr. Ajit Mohan. We have our orator, Dr. Sailij Puttambekar sir. I would just request him to please check his laptop. His presentations are known to be high quality, with sound effects that can wake anybody up as well. So we're just going to check if the audio is working on his laptop. एक बार audio check करते हैं.
Good afternoon. Welcome all of you on behalf of my co-chairpersons and Education Foundation for this prestigious occasion. Welcome Dr. Sailesh and the delegates present over here for this position. We are all expert in removing the uterus, but we will now hear from Dr. Sailesh for the transplant of the uterus. So I will request my co-chairperson, Mr. Bharati Mishra, to introduce Dr. Sailesh.
Really, I am obliged to Dr. Puna and the team PRACHEECON for making me chairperson in that auspicious speaker, Dr. Sailesh Putabakar. By now, India is known throughout the world by the name of Dr. Sailesh Putabakar because he is the one who has innovated first time the laparoscopy retrieval as well as implantation of a uterus, transplant the uterus. So without taking much time, let him speak about what is the innovation he has done and how he has proceeded for the uterus transplant. Over to you, sir.
Yes. Good afternoon, everybody. At the outset, let me thank my guru, my close colleague, my promoter, Dr. P.C. Mahapatra, for inviting me here. I remember I came first time to Cuttack in 2003, and since then he has been my biggest admirer, biggest promoter. Thank you, sir. It's always a pleasure to come and show you. And in the next 30 minutes or so, I will take you through this fascinating journey of how I achieved from radical hysterectomy to uterine transplant. Hello, everybody. Great explorers are charted and changed the world as we live in today. And as surgeons, we should be always explorers. This is what we were there when we are doing open to understand the anatomy. Now we are understanding the anatomy just through laparoscopy. So these are my personal life milestones. I did my first laparoscopic radical hysterectomy in 2002, first live workshop in Cuttack in 2004. Received the first Golden Telescopic Award 2006, first live transmission to AHL, and then of course publication of pelvic anatomy in JMIC. But for me, the eureka moment came when I did the first laparoscopic transplant in 2017, and in 2018 we had the first live birth, which became the 12th baby in the world. And in 2022, we did 2 transplants in a record-breaking time of 9 hours, thanks to Dr. Vidit Mishra, who made it possible in a civil hospital. And then I did a live uterine transplant for the world, which has never happened so far, so before. What happened before 2002? Where the first radical hysterectomy took place in 1992, ladies and gentlemen. And for 10 years, we were lagging and radical hysterectomy never got popularized. Look at the publication. 50 radical hysterectomies in 8 years. Understand the volumes per year. There was no standardization of the procedure. Not possible to duplicate. Some people said 7 ports, some people said 6 ports, because this was not the disease of the European or Americans. And as, can we have the audio?
History has proven that those who dare to imagine the impossible are the ones who break all the human limitations.
And that's when we decided to break all the limitations. In 2002, the world, and especially our own country, was dyslexic to cancer surgery laparoscopically. We were doing laparoscopy, all benign surgeries, but not understanding that cancer can also be done. And that's where I entered in laparoscopic era, exactly 13 years after I was working in BJ Medical College as associate professor and not having any incidents. And in 2002, India's first Agni missile was set up, and that was the time I did my first radical hysterectomy also. This was in 2002. Believe you have to believe in yourself. You feel that world will immediately love you, but they hate you when you go against the tide. And this is what happened. So these are the initial days of my laparoscopy, not having any kind of harmonic, not having any kind of advanced energy sources, and all we had was just the bipolar and the scissors, and we did this with the bipolar and scissors, and this is how we did just with bipolar and scissors. But this was the reason we started doing this, because we didn't have any kind of thing. And then we also had this very crude kind of energy sources like this 10 mm. I don't know how many of you remember a 10 mm harmonic, and this is what we started using. These were the harmonic forceps that we used initially in 2002 and then 2003. And then of course different methods. We started doing radical hysterectomy by putting a colonoscope exactly from the vagina, and we started doing and published OSs. This is how we did. The colonoscope came from the vagina, and we did a single port radical hysterectomy. So this is how the colonoscope used. We used the colonoscopic camera to do the radical hysterectomy. You can see just 1-2 ports near the umbilicus, and this we called it as OSIS, Orifice Assisted Single Incision Surgery, and this we also published with Jon Anderson from Harvard Medical College. But we faced a lot of hurdles, less patient acceptance, and later on the patients started accepting, but we had the biggest hurdle was less acceptance from the colleagues. We developed our own skills, adapted to the newer techniques, but we needed a huge change in the mindset which was not happening. All the cancer institutes in India hated me for doing laparoscopy with cancer. And this was our radical hysterectomy, which was classical. All of you have witnessed this. This is just a glimpse of what I did, and this is how we still do it, so I'm not going to gaze. But was it all nice and good for me? No. We had our own sense of complication. We had a ureteric fistula, we had a bladder injury, and we also had a lot of bowel injuries because of lack of good instrumentation, lack of energy sources. So we had ureteric fistulas, and this all happened, I can confess, in the first 20 radical hysterectomies that I ever did in my life. We also had our shares of vascular injury, we had external iliac vein injury, we also had an IVC bleed because we were venturing into para-aortic dissection. When you have so many complications, a common man would always go back. First of all, you are doing something against the type, and then there are complications because you have not standardized the procedure. But we thought that this is the way forward, and we continued. And this is the complications that we faced, but we started repairing them. We realized that they can be repaired, and we repaired the vesicovaginal fistulas, we repaired the ureteric fistulas, and we also repaired everything laparoscopically. Though it was not a great thing to do, but at least we learned to take care of the complications also laparoscopically, and this is what we did, and we learned, we did this, we did the first ureteroneocystostomy, and that is how we did all the complications. So what was the lesson that we learned? We had to understand the ergonomics of laparoscopy, and most important thing, you needed to be positive when there was so much of negativity that we were creating complications, less acceptability, and we realized that standardization is a must. Till this time we realized that if any surgery has to be popularized, like McDonald's burgers worldwide, it has to be a standardized procedure. So we started standardizing the position of the patient. This was the Lloyd-Lewis position that we started. The port positions were standardized, and then we also standardized the technique. This was a classical technique of laparoscopic radical hysterectomy, which all of you have seen. We standardized it with 6 steps. The posterior U-cut, the dissection of the rectovaginal space, dissection of the pararectal space, and then we realized that knowledge of conventional surgery, knowledge of anatomy, strict adherence to the anatomical plane, but the last thing was equally important. We needed colleagues who were absolutely dedicated to do this laparoscopic work, and it was not an individual work, and of course it was a team work. So this was the first step. We started using the myoma screw. We were the first to use a myoma screw. We never used the manipulator because going through the disease process process we thought was always a mistake, and this is the posterior U-cut. If you read Dr. Arnold Watier's textbook, he says the greatest contribution of Shailesh comes from the posterior U-cut, because in the first 10 seconds, the two organs which need to be preserved, the ureter and the rectum, are seen immediately and they are preserved till the end. And this posterior U-cut was popularized worldwide. So you go from one sacral promontory to the other, exposing the ureter and exposing the posterior area. And then of course the dissection of the rectovaginal space, and that's where the dictum came, fat belongs to the rectum. That's when Dr. Ramesh came and told me, I always thought that fat, you should remain above the fat, but you gave words to the anatomy. And now this is the most popular word quoted worldwide, fat belongs to the rectum, fat belongs to the bladder. And then of course the dissection of the pararectal space remained parallel to the tubular structure, never go perpendicular, and if you remain parallel and lateral to the ureter, the first structure which you will see is the uterine artery, and you can clamp the uterine artery. I have now trained more than 1,000 people and they are able to duplicate the procedure. The key was, it was not only me doing this procedure now, there were a lot of people understanding and duplicating the procedure, and of course the anterior U-cut, here again the popular word, fat belongs to the bladder, so when you dissect the bladder, remain below the fat, when you dissect the rectum, remain above the fat. And that is what we realized, and we did this. And of course the cervicovesical fascia, remember good old days when you pushed the bladder in bled, because you went between the cervicovesical fascia and the veins, and we said that if there is a venous bleeding, don't go after the veins, just coagulate the fascia, because when you coagulate the fascia, the veins will automatically stop bleeding. So this is what was very important anatomical landmark. You can see, instead of going to the veins, just coagulate the fascia, and this is what we realized. And of course the dissection of the ureteric tunnel, that is what we realized that it should be done, and put the clips, because when we started doing this, and then the lymph node dissection remained parallel, because God has created the vessels for you. No arteries, no tributaries on the arteries and the vein, just remain parallel and push. So it became parallel and push, parallel and push, and almost everybody who came to Galaxy, not only from India but abroad, could duplicate the technique, which was the biggest strength which we developed this technique completely. So points to remember was using this technique and making it feasible and duplicable to everybody. And when our first women president came in 2007, that's when we published this technique of laparoscopic radical hysterectomy. When I published this technique, the editor said this is a unique technique, and Dr. Puntamekar, you can name this technique as Puntamekar technique. Shirodkar and Purandare already have a technique from India. Why are you not naming this Puntamekar? Temptation was heavy. My name would have become immortal, but that would be the biggest mistake for the people who helped me when I was nobody, for the patients who believed in me, and for the city in which I was born and brought up. And therefore I decided it should not be a selfish interest, it should be a tribute to my colleagues who helped me when I was developing this technique, and the patients who believed in me. And so I named this as Pune technique. This is where we thought this was very, very important. And when we published this technique, we showed it to the world, but the world didn't believe it. Because we published this technique and everybody wrote that Dr. Puntamekar is bluffing, 60 to 90 minutes is just too less to do any radical hysterectomy. The complete discussion went on and on and on for 6 consecutive issues till the president of AHL decided that Shailesh will do live transmission of radical hysterectomy. They gave us 60 minutes and they said that even if you finish 3/4 of the surgery, we will be okay. I finished the surgery in 58 minutes, 2 minutes ka munafa according to this, and that is what audio.
Thank you very much. You've been vindicated finally, because as our members know, there's been some discussions in the NGO JMIC journal where people disputed your results time-wise, and you've proven to us that you work like a robot. I guess you don't need a robot there.
So this is what the comment was. So I was vindicated out of this. So this was my story of like Mera Naam Joker. I became more popular in US than in India. Like Mera Naam Joker, which became more popular popular in Russia, and then the acceptability came us to India. So lessons we learned was understanding the anatomy, understanding the parametrium, and understanding the duplication of the steps. So a lot of people come to my hospital in 2010 and 2008 from those areas, and when they come in 2025, they say, sir, you have not changed, the steps remain the same, 1, 2, 3, 4, 1, 2, 3, 4, but that's how you should have this is Pavlov's reflex, so gade ko bhi ghoda bana sakte hain, race ka ghoda bahut kam hoega, so that is the most important thing. Then we realized that we were doing too much to do this radical hysterectomy. We were fighting with the open surgeons that we are doing more and more radicality, and in this process our ladies were not passing urine, our ladies had a lot of problems with constipation. That's when we realized that preserving the nerve is more important, and we started doing nerve sparing radical hysterectomy again, and this is where we started doing the nerve sparing radical hysterectomy. All of you have seen this. But what was our contribution? Every Tom, Dick and Harry surgeon over here cannot perform and see the nerve. So we gave an anatomical landmark. Take the uterine vein medial to the ureter and the nerve will automatically get salvaged. So this was an anatomical landmark. The vein comes from below the ureter, artery goes above the ureter. If you want to preserve the nerve, the vein you can see, that's the vein. Just identify the vein. Don't go after the nerves. Just cut the vein medial to the ureter, and that was the technique that we published, a simple technique which again became important for the people to understand. So all that we tried to do was do this as a duplicable step. And in 2006, when Amitabh Bachchan received the National Film Award, I received my first Golden Telescopic Award for laparoscopic ureteroneoscystoscopy with Zoasic, and this became the world's first ureteric reimplantation following a ureteric fistula. We didn't stop at that. We are Indians. Whatever we say is not believed. So we always publish what we said, because when we publish, people believe. And this is in the JMIC journal, the first laparoscopic ureteroneoscystoscopy of the world. And then when Bindra won the first individual gold medal in 2008, we published our technique of nerve sparing, how to take the vein medially and preserve the nerve. And then again in 2009, this was a consecutive second Golden Telescopic Award, not a single Asian had won, for laparoscopic posterior exentration in 2009. So preservation of autonomic nerves, technique duplication of this by gynecological fellows. Then we started testing all the fellows, and we realized that it takes only 15 cases consecutively, and they could do this technique from one step to the other, indicating that this is a completely duplicable step. You have to understand that when my boss said only I can do the surgery, I always wondered what will happen when he dies. I didn't want to have this opinion. Everybody should be able to do this. This is a technique which is duplicable, taught not only in India but worldwide. We understood the paracervical clearance, we understood the neuroanatomy, and it also helped us to understand the neuroanatomy. So this is how we showed the splanchnic nerves, and the nerve-sparing radical hysterectomy has now become more of a norm, so much so that the qualified Curle-Moreau classification, Dennis Curle from Paris, invited me to Paris to perform the same surgery. He is the guy who changed the Peever's classification of radical hysterectomy to Curle-Moreau, and this was an acceptability for an Asian surgeon performing in Europe the same kind of surgery. So preservation was very, very important. And then in 2011, when our India won the first World Cup, we published the first posterior exentration of the world. And then this was a posterior exentration. People thought that radical hysterectomy is the ultimate we can achieve. We started understanding that there was a plateau. Can we do advanced laparoscopic surgery? We started doing posterior exentration, and of course a lot of robotic also surgery. And this was the dissection that we did. So using the same anatomy, then from 2010 we started doing robotic surgery when India's Mars orbiter started. So 2009 we were the first in our country to start robotic radical hysterectomy, duplicating it the same way that is laparoscopy. This was the robotic radical hysterectomy we did in 2009 with Da Vinci Robo, and this is a Da Vinci Robo which we purchased in 2009 because I thought that this is also the technique should be used by gynecologists, and we published our 125 cases of robotic radical hysterectomy using the same technique that you can see. This was the robot that we had, and this is the robotic technique that we started doing from 2009 to up almost 2025. And then we published hybrid technique because we thought we are not using the energy sources of laparoscopy like ligashore and harmonic. So we asked the assistant to use the ligashore. The robotic surgeon would show where to cut with this, and we published this instead of using just the monopolar and bipolar. Use the entire thing as the hybrid robotic technique which became popularized worldwide till the robotic people got the same kind of biclamp, and people who were assisting me, so you can see this is what was the initial deal with the robotic area, and then when it was being cut, the assistant would use the ligashore or harmonic, and this is what we call as the robotic hybrid technique, and this what got popularized because now we were using the best thing to be done, using the technique and using the best energy sources in the world, and so a lot of people started doing this. So this is the robotic hybrid technique that we use. And then in 2018 we got the CMR robot. This is the English robot, and this is a robot which was first clinical application in the world was done in Galaxy. They were not able to progress from 2015 to 18, so they installed the robo free of cost in 2018 at our place. And then I decided to do the first robotic surgery with CMR on 15th August 2018. Ladies and gentlemen, do you know why? Because the relationship between a surgeon and robot is master and slave. Now when I was using an English robot, the master was Indian and the slave was British. And that is the thing, I gave it back to them after 1947. So we did this on 15th of August, and this is the robotic radical hysterectomy. So first clinical installation with the CMR robo, which we continue to have, and we have now done more than 1,000 cases with the robotic area. This is the CMR robotic system that we still continue to have. And these are all the surgeries that we have done. We have not stopped at radical hysterectomy. We have done robotic total pelvic excentrations. We have done robotic debulking surgery. And you can see the hybrid technique on the other side. The assistant using the ligashore, and then you are using the monopolar and bipolar energy sources. So everything was done with this. Then laparoscopic and of course we had done all the excentrations. All of you have seen this. So these were the various excentrations that we published, and everything was published. So this is the duplication with everything less, that is single incision surgery, OASIS, orifice assisted single incision surgery, and robotic, again published by us. And then of course, you know, before that we said that Narendra Modi came into the area, the nurse pairing was made easy during this surgery, and then we published the largest series of radical hysterectomy ever by any center in the world, 910 radical hysterectomies which were done as a single center experience. So in 2018, which was a year of Indian sports, this was a year when all our women started working. We also started working for 2018, and we published the first surgical pelvic anatomy where we challenged Gray, where we challenged Frank Nater, and this was accepted in the FIGO's Journal of International Journal of Obstetrics and Gynecology with lot of resistance, because naturally they didn't have a scope, we had the scope, we understood the anatomy better. We realized that all the veins, the statement that was very popularized, all the veins lie below the fascia, fascias lack fibroblasts. If you do interfacial dissection, then there is no adhesion. And this was the most important thing, and you can see 119 citations in 2018, and then recently the article by Dennis Curlo says that what Dr. Kurtambek has said, there are two approaches to laparoscopic pararectal space. The medial approach should be called endometriotic approach. The lateral should be called as oncological approach. Fat belongs to the rectum, though a bad English, it is put in apostrophe, still conveys the best meaning. fat belongs to the bladder, and all this has been now accepted. We wrote multiple books, Laparoscopic Pelvic Anatomy in Females. This is a book now translated in 12 languages, almost in Spanish and also German, and you can go anywhere and go. So paradigm change was there. Fat belongs to the rectum, remain parallel, hypogastric nerve lies medial to the ureter. But the most important thing that we said was there are no anatomical variations in anatomy. After 1000 radical hysterectomy, I have yet to see a uterine artery arising from external iliac. So when a surgeon comes and tells me that I had a very distorted anatomy, I always tell him your mind is distorted, anatomy is constant. You just have to do the anatomy correctly. So what we achieved was understanding the anatomy completely, and this is what was completely dissected from Da Vinci, from everyone, and we have come a very, very long way understanding the anatomy from open surgery to laparoscopic surgeries and opening our vision to each and everything through the keyhole surgery and not relying only on open surgery. So you see the world of laparoscopy that we have achieved. And then suddenly, in 2018, all the work that we did was put in dustbin. The LAC trial. The LACC trial said stop to all radical hysterectomies in the world. They said the mortality and morbidity of laparoscopy is more than open surgery. I just could not believe it. The world was stunned. This was in October 2018. What would a common man do? You would start shouting that we have done so much of good surgery. But my principle in life is your work should speak, not your words. So we didn't oppose it. But then we started analyzing it. What were the reasons for lactile failure? They were not clearing the infraureteral parametrium. When you do open surgery with your thumb, you push the ureter and you take the clamp laterally. When you want to do the same thing in laparoscopy, you have to take an effort to open the ureteric tunnel. Better understanding of the parametrium and changing the anatomy and understanding the neural anatomy. So this, the most important thing, all the people in LAC trial use uterine manipulator. Who told you to use uterine manipulator? Going against the principle, lacking and giving vaginal and pelvic recurrences. In 2010, we have published this, a novel technique of uterine manipulation with a uterine hitch. And of course, they were doing a colpotomy without securing the colpus. So there was a shedding of the tumor cell. We have always used the Schautas technique laparoscopically. We have used the staplers. We have done a complete figure of 8 or a bursting suture before we do the colpotomy. And the most important that this avoided the spillage, and this is the anterior parametrium that we described. This is what we realized, that failure to clear the anterior parametrium was necessary. This is the anterior parametrium, what I call it as infraureteral parametrium, which is characterized by the presence of inferior vesical vein. You can see the Yabuki space, and this is what we describe. And we published the anterior anatomical description of anterior parametrium for the first time in the world, a probable answer to pelvic recurrences following radical hysterectomy. This was an article against the LAC trial, but I still won my 5th Golden Telescopic Award for the same LAC trial, and this is where we are understanding the Golden Telescopic Award. So the Americans were open to this entire thing in 2020. So what next? In advanced stages, as I said, we have all done the exentration. All of you know that Alexander Brunswick from Chicago sent the message of exentrations from Chicago to the world. We had the proud privilege of bringing the laparoscopic version to the world from India to all over the world. And this was the most important thing. So you can see this. I'm not going to show you all this. And our experience of exentration, 185 patients published, still remains the largest series of anterior exentrations in the world. And this is all the thing that we have done. This is a recent article which says that Uttamaker et al. Has the largest series, and whatever he has done, from 20% survival in stage 4 cervical cancers, post-chemo, post-radiation, our survival has gone to 65%. And this is very, very important. So this is the laparoscopic total pelvic exentration. Important points, so it can be done in less than 2 centimeter trial. The shape trial has come, and we can do it for late stages of this. So from this Our natural evolution was to do the uterine transplant that we did, and when we did this, we evolved from being a TLH to radical hysterectomy to doing a uterine transplant. Make in India was a dream of our absolute Prime Minister, and that's what we realized, that Atmanirbhar Bharat, and we realized that it is important to do it all by ourselves. Dr. Max Brainstorm, who did the first radical uterine transplant, had promised to come and help me, and at the last moment demanded $1 lakh, which I could not pay, and I therefore continued to do this. And then this was the thing which was a game changer. Instead of using the internal iliac vein, we started using the ovarian vein, again making this procedure completely duplicable. And this came from this, and today the right approach was, when we wanted to do this, we again went to the cadaveric resection, learned the anatomy, and then we went to this. So it was not an overnight decision to do a transplant. From 2014 to 2017, I worked on 12 cadavers, going and understanding the anatomy before we embarked on this, and that was what the first laparoscopic donor retrieval of the world took place. The question was, why should a mother who's donating the uterus have an incision from zippisternal to pubic symphysis? We did world's first laparoscopic retrieval of this, and this was recorded. This was a team of surgeons, and I'm so grateful for them, because all these surgeons did not charge a single rupee doing this 9 transplants so far. So we were the first, ladies and gentlemen, to do the first center laparoscopic anatomy retrieval, and now in October we will be the first to do putting the uterus again in the female in the recipient laparoscopically. I have been trained to do the vascular anastomosis. So the objection that the lady who is going to receive the uterus is going to get 3 operations. 1 open operation to put the uterus, 1 to deliver, and again to take out the uterus. Only there will be a cesarean section, because everything will be done. And on the stroke of midnight of 18th October, we made the history that we had the first baby of Asia Pacific and the 12th in the world. We call it as Radha because she came from Gujarat. And this was a team that we did, and this was published or perished, because everything that we did, we published it. This was the laparoscopic assisted uterine retrieval, and of course the utero anatomy, and we made it in India. So we made this another thing which was possible by understanding radical hysterectomy through methylene blue. We realized that using the ovarian vein is much better, because there is no surgery in gynecology where you have to take out the internal iliac vein. The surgeons all around the Europe were taking out internal iliac vein, leading to a lot of problems. And now Brazil, Spain, Croatia, and also Kenya and Nigeria are using the same technique of using the ovarian vein. So our anatomical innovation, ovarian veins can be used, and just using 2 uterine artery and 2 ovarian veins, our evolution was from almost 14 hours from donor retrieval, it came to just about 4 hours of retrieval. And also our patients, India stands proud that all our 11 transplant, there has not been a single rejection of any of the transplant. Uterine artery and its branches was very, very well maintained. Most important, that the uterus can survive with 1 artery and 1 ovarian vein. That is what we published, and this is the laparoscopic retrieval from the donor organ we published. And this novel anastomotic technique for uterine transplant using utero-ovarian anastomosis was published exactly in 8 days after we submitted the article. The editor of the Journal of Minimal Invasive Surgery from America wrote to us that this is a life-changing anatomical understanding, and we need to publish this. So that's when I realized, if all of you have read this article of Thomas Friedman, world is flat. We are all worried that we are born in Cuttack, we are born in Puri, and born in Pune, our opportunities are less. No, ladies and gentlemen, you can be born anywhere, but dream big, and that is what was important. So again in 2022, we did 2 transplants in 1 day at Vineet Mishra's place. You can see this. This was the Pune surgeons who conduct this. We made the history with our group of people. We did a live transplant in 1stnInternational, and we are accepting the newer modalities. We went for sentinel node, which is what is very, very important nowadays, and we also use stapler application rather than using the entire figure of 8. We started using the stapler for the vagina and then cutting it below this. So newer techniques, newer adaptability, putting the bags in the endo bag, taking out everything in the endo bag, and of course the ICG technique for para-aortic dissection. All these new techniques started coming. So role of omentectomy also we described, because omentectomy was not a part and feature of adenocarcinoma of the rectum, biomarkers. So ladies and gentlemen, what is the future? AI is the future, following Gurukul. But even when you have AI as the future, I still believe that Gurukul is the parampara, because this is the best way, exactly 30 seconds. So parampara, and this is what we started doing. This is what we have trained people for, and for this, in 2024, I received the John Stick Mentorship Award for training maximum international surgeons from the AAGL, and this is what we got. But heroes are nothing without their team, as you can see from the area, and that is very, very important. Heroes are nothing with their team. So our vision, anatomy remains constant. What has changed is perception of the anatomy, and that is very important. So traveling all over the world and doing this, ladies and gentlemen, I leave you with this thought. Sound please. Traveling all around the world and teaching the people. This is what we have done. We have achieved India's role in the entire area. I don't know why the sound is not there, but that's the area. Now I have a license to operate in 50 countries, Indian degree, no international degree, and this is what is the most important thing. So traveling to every part of the world and doing these kind of surgeries, helping people, helping patients, helping surgeons to develop the technique. So that's it. Thank you, ladies and gentlemen. Thank you very much. Thank you so much.
Thank you, Silas, for that mind-boggling presentation. In fact, I think this oration must have enthused a lot many youngsters and juniors, gynecologists sitting here, that how surgeons, as a surgeon, as much as Silas is acceptable in the surgical fraternity, so much so also is acceptable in the gynecological fraternity, and you must be, and I am only invited, as I am the only surgeon in the audience and you are the secretary. We are the only two surgeons, rest all are gynecologists here. When I was hearing you, I just was seeing your journey from Meranam Joker to Saruk Khan. I mean, this journey is wonderful. I think Professor Alfred Toddler sometime had told that in 21st century, illiterates are those who do not want to unlearn, learn and relearn. And when you have a wish, you have a desire to perform, I think sky is the limit. And we can never stop waves coming in the sea, we just have to learn how to swim. And Silas, you are wonderful, your presentation was mind-boggling. It must have enthused a huge wave of encouragement amongst the attendees here. And I must thank
Can I request Dr. Sujit Bera sir to also please join us as we would like to present the memento. With that, we would like to move to our panel discussion, and we are just 2 minutes delayed. And with that, can I request our moderators, Dr. Biswa Das, Dr. Subhash Malya sir as the moderators. I would like to take this time and take the opportunity to call our panelists, Dr. Abhipsa Mishra, Dr. Sujata Kumari, Dr. Nikmanda Mishra, Dr. Alok Kumar De, Dr. Tapan Patnaik, Dr. Vinodar Pandey, Dr. Harpreet Kaur, Dr. Sangamitra Das as well. Can I also request our experts, Dr. Neena Mishra, Dr. P.L. Tripathi, and Dr. Chaitanya Machi to please join us as the experts.
Good evening, everyone. I think there is always a saying called as a calm before a storm, but here there is a calmness after the storm. So after this, it's very difficult to come down to normalcy. Now, all of you have been so euphoric and so happy about the great talk given by my teacher, Dr. Prathamika sir. And I think it's very difficult to step up to his level. But of course, me and Dash sir, we will try our level best to make it more interesting.
So I think I request everyone to settle down from the storm of uterine transplant and so thank you the organizers, Dr. P.C. Mahapatra, Shojit sir, giving us this opportunity. So without wasting time, what we are going to go through is what are the troubleshooting in laparoscopy and how to overcome these situations and avoid complications to have a safer outcome in terms of surgical outcome, the patient outcome.
Right. So I think if, we just settle down, there is some minor complications here which we are rectifying. So which we will talk. Again, warm greetings from Calicut, Kerala. It's been a pleasure to be here in Odisha. Nice to see Harada and all the seniors here. Lakshmi madam, all lots and lots of seniors over here. Now, why laparoscopy is something which we always say. There is nothing, I think after Dr. Prathamika's talk, there is nothing like, क्यों laparoscopy क्यों करना है? Why should we do laparoscopy? I think it goes without saying that we are all accepting that laparoscopy is the best. I would say the best, it is next to best. We have early recovery, we have less pain, we have scarless, nowadays with all those people that have more cosmetic thing, scarless, less blood flow, shorter stay, and of course, more cost effective. So settle down, sir. So respected experts and panelists, we'll just move around and start the Alokta, ready? All done? Sure, fine. Sir.
So, coming to laparoscopy, we say it is cost effectiveness. Sir, can you tell us whether laparoscopy is going to be more expensive or it is cost effective in terms of patient outcome, coming back to their work and faster recovery? What would you say?
Yeah. As compared to the early recovery and the number of days in terms of number of days the patient saved, as in open surgeries he has to take a lot of days on leave, and in laparoscopy it's early recovery, less pain. And the early recovery means the patient can go to the office, go to the work early. And if you compare the cost with the number of days he saved, I think it is less expensive.
I think laparoscopy is cheaper if you compare everything the patient spends and coming back to normalcy.
It's now regarded as daycare surgery. Actually, that's the best part of it.
Yeah.
So the same day patient can be discharged.
So even we say laparoscopy is the best compared to open surgery, there are certain limitations.
Of course, now there are limitations. What are the limitations that you feel in laparoscopy? You're all here saying good about laparoscopy. Dr. Prathamika sir said so much good about laparoscopy. What are the limitations that you feel? No, पैसा मत बोलना please. बिना पैसे का कुछ और चलेगा लेकिन पैसे की बात मत. Yes, ma'am.
Important for this. Teamwork is very important.
Teamwork. But yeah, what does teamwork means, ma'am?
Everything.
I call team, I call team as TEAM. together everyone achieves more. Sabka haath, sabka vikas. That's all.
And waste as the machinery is advancing day and night. So from single chip we have improved to robotic now. So definitely it is expensive, and to afford robotic is because we are talking now robotic, and to afford a robotic setup is really price is involved. So this much is I think, and next is yes, of course training is very important, and attending these type of conferences, workshops and training, and this will define everyone day by day. So these three things I think is important for laparoscopy thing.
Yeah, so there is a lack of tactile sensation, that is the first limitation. But if you are well trained over time, you will recognize by giving laparoscopic instruments the consistency of the tissues, how to handle these issues.
In my view, I think the biggest only limitation is the skill.
Is it?
It's the skill. If you have the skill, if you don't have any limitation.
I totally disagree with you, sir.
Okay.
Why? Sir, not everybody are born surgeons like him, sir. We are all acquired surgeons, sir. We learn and learn and learn.
I'm saying what parameter you want to do the laparoscopy.
Yes, sir, you are correct.
You have everything. You just need skill. You do the surgery. You do the surgery with your spinal anesthesia, local anesthesia nowadays. In spinal anesthesia, people doing TLH in 15 and 20 minutes time. So it's not big issue. So if you have skill, you can work.
Yeah, so what sir wants to convey that you need a very good training program, structured training program to learn advanced laparoscopy. You are correct. And what he said is also correct, that is how we acquired, with training and efforts. Yes, sir.
Another biggest disadvantage is the arterial complication. In open surgery, in no way you can hit the external iliac, in no way you can hit the vessels. But even if occurs rarely, coming to the carbon dioxide and embolism, gas embolism, in no way it can happen in the open surgery. So only, even if it is there.
सर ये तो अपना रोड एक्सीडेंट और एयरपोर्ट जैसे हो गया सर ऐसा थोड़ी होता है सर फिर भी सर रोड में भी जाते हैं तो भी होता है एरोप्लेन में भी जाते होते हैं फिर भी जाना तो पड़ता है ना सर right anyway while going in an aeroplane we don't talk about air crashes so we should go to eco items now along with this sir now what are the trouble areas and common complications are what we're going to discuss now please understand these ships in harbors are safe but that is not ships are built for we have to move forward sir जो आपने कहा सर देखिए ना सर ships are very safe in harbor but that is not how it is we have to go forward we have to operate तो मैंने आपका मन पढ़ लिया था पहले से सर so now you can see accidents can happen to the best of roads you can have the best of roads you can have the best of vehicles but still accidents can happen now these will pull down your confidence but फिर भी operate तो करना है सर पापी पेट का सवाल है सर now this is the complication rates are about 3 to 6 per 1,000 cases we do accept it just like the road accidents also we do have but sir there is no clear safety advantage with any specific entry. What is your safety technique? Sangeeta ji, what is your safe entry technique? What do you feel, sir? Next, Mishra madam.
Sir, regarding the safety when we are entering inside, our preparation should be well. Like patient should be properly anesthetized and properly anesthetized and properly relaxed abdomen. Patient should be in.
आपके पति anesthetiस्ट हैं?
Yes, sir. General anesthetic.
नहीं, because when she said now patient should be well relaxed, तब मुझे समझ में आया पति anesthetiस्ट है. जी मैम.
Yes, sir. Sir, in general anesthesia, fully relaxed abdomen and empty stomach, empty bladder and bowel preparation should be well. And with proper technique, we have to properly insufflate the.
Madam, you said about bowel preparation technique.
Yes.
So, Mr. Madam, what is your bowel preparation technique?
Usually we keep the patient NPO just 6 hours prior and we give only 2 tablets of Dulcolax prior night. We don't restrict any food, but definitely if it is any.
But Patnaik sir is saying that he doesn't like Dulcolax, he gives enema. What is your take on that?
We avoid enema because if you give enema, the bowel will be more distended. So better to give and then we keep the patient NPO usually after 12 the morning institute is there. And if it is a case of deeply infiltrating endometriosis, then definitely clear.
Thank you. We would like to hear from Dr. Harpreet and Dr. Sanghamitra that which cases you give more importance to bowel preparation and those situations what all you give to prepare the bowel.
Mainly like Dr. Vipsa said, especially in deep infiltrating endometriosis.
endometriosis or being previously operated cases. In those cases, for bowel preparation, we prefer to give Exelite or Pegleg for a complete bowel, so that in case we are expecting any kind of bowel injuries or bowel involvement, so it would be easier. But again, also adding that the gastrosurgeons say that it's not required, even if we are given a Dalcolax, it's enough, but still I am giving.
Yeah, Dr. Subhas, you can throw some light there. Now surgeons.
I always use Conclave preparation, be it endometriosis or simple TLH or radical. I always prefer. But liquid, but here liquid I stop just 4 hours before surgery. But I always prefer. Though gastrosurgeons they will tell no need of any preparation. What is bowel preparation? This is bullshit. But I always prefer the bowel preparation.
Sir, your take, sir.
When you are expecting some bowel complications like adhesions are there, because surgeries are there, endometriosis is there. So in that case, you must prepare. Because you should be ready for that also.
I think sir is very, very experienced. You know, I keep saying, good surgical decisions come with experience, and experience comes with complications. Of yours and others also. So this is what I keep saying. The experience is nothing but others, somebody else's complications. So we need to learn about this. Now, as sir rightly said, you have to identify the risk or factors for complications, learn how to recognize the complications, how to prevent the complications, and discuss the management part of it. Now, risk factors, I would for positive time, you will just understand all these are risk factors, we all agree with this. Now, as Madam said, position related. Can somebody throw light on position related? Anybody? Sir, can you please, sir?
I mean, why positioning is so important in laparoscopic surgery?
Yeah, the conventional position is the Lloyd-Davis position or modified Lloyd-Davis position. If the patient is putting, for a prolonged period of time in, tender part, and the anesthesia always object, and as far as the position of the leg is concerned, for a prolonged period of time, if the legs are abducted, the perineal neuropathy and the malformation of the sciatic nerve, and also the arms which are kept in the extended position for a long period time, there are possibility of brachial nerve palsy. That is why the position, proper position is very, very important.
So the positioning is for a better exposure of the pelvis. We give head low position, we keep the arms by the side of the patient for the better positioning of the surgeon. But at the same time, we have to ensure there is no damage to the joints, nerves, and since we have flexed the legs, working in the pelvis, we have to avoid the deep vein thrombosis also.
And also from the vaginal side, the vaginal manipulation is very, very important. That is why the position is that much important. But one thing I have learned from Sailesh Puntamakar sir, that is put a sandbag below the anterior superior iliac spine. That separate the small bowel, the small, make you the head down. The small bowel automatically goes towards
so
the
this is a very, very good point which sir has made. When you put a bolster under the
below the anterior superior iliac spine,
what happens is the pelvis breaks into two, the sacrum comes up, which means the line of recently from the left to right goes back, and the small bowel just comes down. इसका मतलब है even if you don't like your anesthetist, with little bit of head low, the small bowel will come back. That's a good advantage. It's a good point.
And always in TLS, we in Kurla practice this.
Sir, we are also Dr. Puntamakar students. Sir, the पूरी दुनिया ही उनका उनके student है sir.
This is the best thing. We can have a Allen stirrup or anything stirrup.
Allen stirrup is the best used for positioning of the legs and pelvis. And I think ideally, except diagnostic laparoscopic cases, we should put even pneumatic pumps for all patients for prolonged surgeries to prevent even.
That's a very good point. Now, access related injuries. Now, I wouldn't say injuries. The experts, sir, if you have anything to add, if you are going wrong somewhere, please correct us. If you are going wrong somewhere, please correct us.
Few words. Because first you told that what are the limitations. I will say, except a cesarean section, there is no limitations for laparoscopic surgery. Till now, I don't know how to level in future. Second thing, the skill. As I was telling, the skill is the limitation for skill. Whatever you learn from day one, you are skilled in that way. So if you start teaching your students from today about laparoscopy, that is the best skill they are giving. Because previously we were doing vaginal surgery from day one. So they were the skill. Now the vaginal surgery is fading away. But the new generation, they are lacking the skill of vaginal surgeon. So laparoscopy doesn't need extra skill, what I mean to say. Safety wise, everywhere safety is required. May it be general surgery, may it be open surgery. You have to be a bit cautious, you have to be a bit alert what to do for which patient. About the bowel preparation, there is a lot of discussions. Yes, there can be inadvertent injuries to the bowels. So you must be ready for that preparation. So bowel preparations before 21, not 4 hours. 4 hours preparation is only for the anesthesia, not for the operating surgeon. A operating surgeon needs at least 24-hour bowel preparation because the congestion of ethans in the bowels, if something happens, there can be a bone weaving. So bowel preparation, you have to be very, very careful. 24 hours in liquid should be advocated for all and every patient because you do not know which patients you are going to have a bowel injury. That's my message.
Yeah, thank you, sir, for your inputs. And it is true that bowel preparation, see, I would say safety precautions is sometimes individualized. You know how you operate, what are the precautions you are going to take, but there are some universal precautions we take to avoid general complications. So, like initially discussed, patient should be anesthetized, relaxed abdomen, empty stomach, empty bladder, prepared bowel, experienced team, and excellent equipment. They have all equal contribution. Now coming to assess injuries, when you enter inside, Dr. Harpreet, what is your preferred method of entering into the abdomen? You create pneumoperitoneum first before the primary trocar, or like brave surgeons who put the primary trocar first?
Take a pneumoperitoneum with a varus.
So you create pneumoperitoneum with varus needle. And what are the entry-related complications you expect in before putting varus needle or trocar?
Basically, while putting varus is that we need to have first set pressure also at a little higher, 20 mm. And then while putting the varus, it should go perpendicular. It should not be ideally the abdomen should not be lifted too much because we need to go through up to the peritoneum, and it should be given at the umbilicus where we expect all the layers to be there. But if there are any previous surgery patients has undergone, then the Palmer's point is preferable because that is a place where, and on top of that, we should be sure that the right stool has been given, so that the stomach is deflated, there is no splenomegaly, and then we can go for the Palmer's point in previous surgeries. But adding to this, there was a case, just mentioning one case, there was a patient who had some history of some bowel surgery and she was having an upper midline incision. So there was a mistake which I did was take the Palmer's point and I went through the transverse column. So that is one.
Keshav sir, would you like to vary anything like Madam said that the initial pressure should be 20 to 25, before putting the primary trocar. Would you agree with that?
Yeah, literature write that before going for the trocar, the pressure should be a bit higher. But as far as in our center, our practice, we only fix to the 12 millimeter of mercury before going for trocar.
Please remember that this is something which I have learned all my days, is that even if you have a phalangeal incision, when you start your surgery, you will find most of the times the adhesions are in the umbilical. This is something which is very common. So what we normally do is, all of you have told your preference. I personally go for the Levox point for all my cases. I may be right, I may be wrong, but what I'm trying to do is each one of us are very good at each method. We can go ahead and do whatever we like. But if you go by statistics, do you feel any of this method is superior? Whether it's an open technique, Huss's technique, or closed technique, or a Viris, which one do you feel is better?
None. Those would comfort of the surgeon.
Absolutely. It's always the skill of the surgeon and your comfort.
It is the training of the surgeon that is important.
Very good.
Very is also good. Direct trocar entry is also good with safety device.
But as Dr. Vishwadhar told, the basic things, if you're going for any method, putting a rice tube in the stomach, deflating the stomach, what our seniors have taught it from a DNC to a major surgery. Catheterize or empty the bladder, do a PV before you start, palpate the abdomen, and then you start. We can do a laparoscopic uterine transplantation also, but do not forget the basics. Our basics are most important. Anatomy is very, very important.
On the other day, I think recently I did a surgery. That lady had a umbilical hernia repair with a big mess. And mess is messy always. And what do? If you go through the Palmer's point, you definitely going to face some momentum or something. So that you have to. That's why you have to tailor-made. So if you have the option of OptiPort or VC port,
very much.
Yeah, so we actually opted for 5mm VC port. But that would be very nice and small trim one. So we blessed that and went through once, and actually can see it can be momentum adhered with the parietes and or it's free inside. So we couldn't see anything other than the momentum. We just pierced it.
Did you do a colonoscopy then?
Colonoscopy?
After going inside?
Yeah. So, yes, but again, the optiport or VC port, you must have some experience with that also.
Now, what is experience?
Because the color changes, you must know how the color changes with when you are actually screwing the twig inside.
Sir, just one question to you.
On a lighter note, sir, you should know the color change also, and secondly, you must have pocket money like Alokda, because VC port is not very easy. Paisa nahi hai, sir.
You cannot, we shouldn't forget about our beloved Jain's point also. Jain's point also.
Sir, one question to you. Would you like to give some input to the public, to the audience, that is there a role of rate of insufflation or gas flow rate while starting the insufflation?
Quadrant manometer is a must. Flow definitely. The book says you start with 1 liter per minute, but actually we stated at 2 to 3 liters, and then as the surgery advances, you put it in the highest mode. Now we have methods where you can infuse in 50 liters per minute CO2. So these are the things, but initially we put it in the bracket of 2 to 3 liters per minute, and there's a flow rate.
Yeah. Thank you, sir. Just to add on, people who use direct rocker entry, there I think flow rate has more importance than very still. Because very still anyways is not going to allow more flow of gas. But if you are putting direct rocker and if you have started 10 liters per minute, I think a certain expansion. I think all of us, we have experienced certain bradycardia and so it is.
One thing, sir, in this point, because in the last case, you have set the rate of flow to 20 liter per minute. And you are going to the second case, and the cart wheel attendant is not able to think you have put a direct rocker. Suddenly, the patient will be insufflated at the rate of 20 liter per minute.
Yes.
And the maximum number of cardiac complications that occurs during the initial 2-3 minutes of insufflation only. That one should remember.
That is very important message. Thank you, sir. You have to be very careful. Suddenly, anesthesia will say, please reduce the pressure, please take out the rocker. You have to be very careful because after all, everything comes to you only. So,
but the newer devices that are available is actually if you start the device, initially it will only say the varies. So afterwards, then only you can have to switch over to other modality. So newer devices, even if you are using Ascola, you cannot just get, even if your previous surgery was 50 liters, but once you put this on, it is only on 3 liter per minute. So that's a very good thing when you start using your device. Whenever there is discussion about management of complications, we discuss a lot about the entry because I believe safe entry is half surgery done. So please don't feel bad. We are speaking about this again and again and again because this is one. ये हो गया तो बाकी का काम आधा हो गया. So that's why we are actually doing this. We have enough of other complications, but एक बार अंदर घुस गया तो खस. It's like our parents like joining MBBS is very difficult. एक बार घुस गया तो life बन गया. We all know it is not so, but still. Sir, about this sport we have done this. This is what Dr. Vishuddha is showing us safe entry. But
yes, sir. So, Dr. Avipsa, can you just throw some light about, we decided that you went through umbilicus as it is the thinnest part. Previous surgeries, you went through commerce point and chain point. And, do you think it is always safe without scars? You are safe, entry is safe? Or you expect some situations where adhesion is still there without previous surgeries?
Yes, even without surgery, if there is a case of endometriosis, pelvic inflammatory disease or tuberculosis, definitely we expect some kind of adhesion. So, always in those cases, combat point is definitely a better option.
What about obese patients?
Yes, in obese patients also, definitely the position is, we have to keep our hand little vertical and 90 degree. And then very
you would still like to, for 110 kg patient, you would still like to go through umbilicus or you want to go higher?
To be honest, I am not giving primary coated umbilicus. I don't know, we are giving supra-umbilical. Since 10 years, I am doing supra-umbilical.
2 hands, not just 1 and 2 hands.
Sorry, see, just for last 5 years, what we have changed is even for bigger structures, we try with a little difficulty. If we can put it through umbilicus, I think cosmesis is for everyone. Sorry, even we have started doing morcellation through umbilical cord.
Sir ने भी cosmetic बोला है तो we have to agree.
Sorry.
We are always going for supraumbilical. Only not only the obese patients, very thin patients are also very difficult intubable.
Right. But recently we have changed even the morcellation cord through umbilicus, just to avoid extra. I think I agree with you.
One of the points which sir was trying to raise about whether you like to go for every case. We have Tripathi here, Professor Tripathi sir here. One of the biggest proponents of tuberculosis which we have seen from textbook is from Tripathi sir. So always in case when you have tuberculosis, be very careful when you are going for these sports. These sports in tuberculosis I have done. 2 tuberculosis generally, we get very less tuberculosis in Kerala. But 2 cases which we got, both have done colonoscopy. Transverse colonoscopy for those cases. So that's why I'm very, very scared about it. Whenever I put the ports BB. You know what is BB? Not BB Dash. You know what is BB? Not BB, B and B. Bhagwan Bharose. So we put the port in Bhagwan Bharose in such cases. Thinking it will go all right. Now coming down to this again, his next part is, now in spite of doing all your port positions very well, very nicely, you learned everything, this is what happens. What is this? And is this dangerous or is it okay?
Yes, okay. Can it be dangerous sometimes?
Mishra madam, you said okay, I'll come back to you madam. Please.
Just to adjust the primary port or the secondary port, we have to adjust.
Why this happened madam? I am a very nice surgeon. I am a very great surgeon. Why this happened to me madam? The reason again I said, before you add your CO2, make sure your inside the abdomen. It looks very, very simple. इसमें क्या बड़ी बात है? But make sure you're inside the abdomen. See the yellow color. Only then you start insufflation. Looks simple, but and the reason why Dash sir asked is why is it important is because when you have a lot of pneumoperitoneum that has gone through the chest, when you extubate, you have a lot of problem because patient cannot breathe. We've had a patient who had to be ventilated for almost 12 hours and then we actually took it out.
Yes.
So don't take things lightly.
Setting should be very important in landing phase also. The scope should be ready before putting any ports.
Yes.
Primary port, at least the scope should be ready.
I think an excellent point. I will tell you there are certain situations where teamwork is not there. You put the primary port, the telescope camera, they are not ready.
No.
And so that is not acceptable. No. When you are the surgeon, you have to train your team.
Absolutely, sir. There is senior or junior, this has to be followed. You have to get everything ready because in open surgery, you have a bleeder, you go and put your hand inside. Laparoscopy, nothing happens. Even check your bipolar, check your suction, and only then I start. I never start a case, whether in a conference or in my own place, I do not start a case without all these are ready. It may look very arrogant, but no, safety first. There is no doubt about it. Primary report, I think we have finished with this automatic and everywhere. We have got to the scenarios. Now, this is something which happens very rarely.
So, this is a patient who had no previous surgeries. The primary port was placed, secondary port was placed. Then we realized that the primary port went through the adhesion. So, what is your take, sir? What do you do in these cases?
No, don't tell me BB, sir.
So, this patient, no previous surgery, you never expected this kind of adhesion. So, the primary port went through this.
So you have to give another. You have to give secondary port 5 mm.
Yes.
Then go for the other surgery.
Yeah. Would you like to take out the primary port?
No.
No. Okay, so that the message is, if the primary port has gone through adhesion bands or through intestine, do not take it out. Rather, you put the primary, 5 mm telescope through the other ports, do complete adhesiolysis to see whether you have injured anything or not. That is, I think, the best idea.
Even if there is no adhesion seen in the primary port, during the exit there is no harm after completing the surgery. To a primary port, you must, before taking out the 10 mm primary port, one must check that it has not gone.
Sir, what is being done here, is it correct or wrong, sir? I always say, use your left hand and the things which your teachers have taught us, traction and counter traction. Always do it under traction, please. Left hand is very important, keep it in traction and only then you cut it.
Yeah.
And I use this dictum, white belongs to the patient, pink, white belongs to me, pink belongs to the patient.
Plane should be also close to that plane is a long one, yeah.
Yes, very good.
Chance of bowel injury will be here.
Yes,
because some part is hidden behind that
Yes.
mental band might be there.
Sometimes there are videos also like that. So,
This is my own complication. Can you please tell me where have I gone wrong? Don't tell me, sir, overconfidence, sir.
Like, sir said you should take out everything under vision.
Yeah. वो मुझे भारती मैडम I thought I know everything. वही गलती हुआ मैडम. So basically, when you take a 10 mm or more than 10 mm port, please close it. One is please close it under vision, and secondly, when you detach or remove, always take out the port first and then the telescope. So you can see what is, or else it gets stuck because हमारा क्या है, case हो गया, सब हो गया, कचाक. Please don't do that. All I say, my hair is not so white, but my complications are also not so much. But whatever mistakes I have done, these are all wrong things. So that's why we don't want to have this.
I had similar one momental herniation through the incident. The next 3 days after that, the patient had a cough and the momentum came out through the umbilical cord. So after that, we also follow the same
even in 5 mm port, you can have a defect. If you have macerated 5 mm port injury, then it also can herniate. So it is better to have a look at it.
Again, sir, the same principle holds good in our morcellation port. Please don't leave the morcellator. Always close. In spite of closing the morcellator port, I had one bubble having that. So after that, I put 2 stitches. Kabhi डर लगता है. As and when you grow old, you become more.
Because now we are morcellating 15 mm morcellators. That is a very big one.
Very much.
So it is at least two stitches.
But again, yes, ma'am. Mike.
From Japan, that conference, and he has told how under vision you have to take out the 10 mm port. This thing I have learned and I have taught all my students.
Thank you.
So always, and the abdominal to be lifted.
Yes.
Because negative pressure, the intestine will go and
yes.
So immediately I got it for.
One more thing.
One thing I want to add on that. If I do the umbilical port and entering it straight into the abdomen, if I take the supraumbilical port, that is an indirect tract. Actually, it helps you out in preventing these herniations.
Sir, these things are not to be told, sir. Because then people tend to put port डालना नहीं आता है. So that is the truth. The point of entry is different from point of exit. So it doesn't
have it. So that means supraumbilical is much better than the.
That is why supraumbilical patients have much of hernia compared to umbilical.
And your anesthetists also, can be responsible in this way also.
Irresponsible or responsible?
No. Responsible for complication also.
Sangeeta is saying irresponsible.
Make sure you actually closed all the pores there. He or she should take out the tube. Otherwise, the patient will jerk, cough and everything. And if you have a bigger opening down there, the blood and momentum can come on side, isn't it?
Yeah, so what he's saying is correct. It's very small setups. Sometimes the anesthesia is the lead before the surgeries. And one more last point to add is
that
I had a rare complication of face emphysema just 7 days back.
Yeah.
One just information.
Yeah, last time I have seen, face emphysema.
I have not seen them. Lucky.
I want to add up one good point about emphysema. If someone is adding that CO2 insufflation entry into the accessory port, and actually that doesn't know that fiddles out, that comes out in between, and that is a high chance again that can cause emphysema. So every time you NCO, if you have taken that port that is in the side port and the secondary port, and someone your assistant is not that sure about the surgery, see actually you have to give it.
Sir, this is what is called as the
alpha. One just information, not exactly information, on a technique. Those who are doing a direct trocar entry, we in our sector, we have adopted a different procedure because we all have the experience that when you are doing with a 10 mm trocar, a lot of resistance. Many times we just struggle on, keep on pushing. So what we have adopted is that just enter with a 5 mm trocar. It becomes very easy. Just put a 4 mm telescope and see if you are inside it. do the neoplatinum, then enter the tenon. It becomes very, very easy. So always we have adopted this principle.
Okay, sir.
Just do a neoplatinum with the high cement.
But sir, one point to it. If you want to really do a tenon, those people who struggle actually give a very small incision.
सर ये कोर्ट है जज ने बोला है तो हो गया सर जज ने बोला है
just last point, there are anesthesists who give immediately head low position once you create new partner or once the patient is anesthetized. You have to ensure that before putting the primary trachea, the head should not be lowered.
देखिए, I call this the alpha maneuver. The moment you put in your port, Greek letter alpha, 360 degree view. Always see 360 degree and only then you proceed. Because you never know if you have gone through the transverse colon, so you will not realize. So it's always go 360 degree. Now, vessel injury is not so common or so common. What do you say, sir? What does the house say?
Anyone who has encountered, madam?
नहीं आप ऐसे पूछेंगे तो कोई नहीं बताएंगे सर.
Inferior epigastrium, I think, is the most common one, which usually everybody encounters. So to prevent that, definitely the secondary port insertion should be under region.
Which vessels can I injure the answer? All vessels?
Yes,
all vessels. No, we'll hope not. We'll hope not. Vishudha.
Yeah, the main reason for inferior epigastric injury is tunneling. You know what happens? So the ideal is entry and exit point should be the same. You should be perpendicular to the abdominal wall. You can see how it is.
एकदम बढ़िया.
So what is your management, sir? Dr. Rahul, you can tell after that.
If it is small artery, you can cauterize. Otherwise,
No, I'm cauterizing, madam. As you said, we are cauterizing, madam.
It's not controllable.
Not
Then
You can suture with rifle straight to.
yeah, port closure needle.
Whatever madam said, we follow. See, we are good students, See, madam said, rifle डालो, हमने डाल दिया.
Straight needle can be used very nicely. Straight needle can be used and put a stitch.
Sir, now this is, sir, we are doing a sacrocorpopexis, upropexis, sir. So now we have taken this suture, we are taking a ethibond here. Now there is a small bleeder here. How do we proceed from the middle sacrum?
Yes, sir.
Arterial or venous, sir?
You can see how it is.
Yeah. But I think this is the medial sacral vessel. It's not a big vessel. You just cauterize with a flat surfaced bipolar. It will stop. But you make sure you have dissected the vessel well, not to went to the left side, because if you going to the left side, you have the pain. So then you are in a bigger trouble.
But sir, but fearing going to left, I will go to right. Is it okay, sir?
No, I'm saying not. Because the anatomy of the vessels.
The joke about here is what sir is trying to convey is if you go to medial to this, we have the lateral, the middle sacrum and lateral sacrum. If you go to lateral to that, please understand that is where the autonomic nerve plexus will come down. And hence, if you coil into that area, you're going to have a chronic pelvic pain for a very long time. Okay, not the ureter. We thought we were going to ureter. No, it's basically the nerve plexus. Hence, you cannot go to lateral, you don't go to medial, expose it and do it across. So even if it's a small venous bleeder, putting a very good gauze piece for some time is also good.
Gauze tamponade will help also.
Just one, this is something what went wrong, can somebody tell in this case?
Right lower, please. Right lower.
What went wrong, if you just in a few seconds?
The video one?
Yes, sir. So the internal iliac, what went wrong? And how to handle this?
देखा मैडम वो टेंशन आ गया.
No, but the first is why need to actually coagulate internal iliac artery at the first place.
Yes.
Why need to go for that?
The mistake was, this is such a big vessel that we did not realize that it cannot be taken with a vessel sealer. If you see, we have not proceeded the blade to cut it, but it was stuck to the claw and avulsed. It was actually a dangerous situation, but we could handle. How you are going to handle this?
Yeah, this is why you have to have the clave, no?
Yes.
This is,
So these are the vessels not to be taken by, vessel sealers or, coagulation.
Always have a vascular clip. It will cost not more than about 8,000 rupees.
at least 2 clips you need, at least 2 laparoscopic clip, vascular clip you need. Just put on the either side, then you decide what to do next. Whether you are happy to go for, if you go for suturing, that's fantastic.
I think clips are sufficient. They will block the blood supply.
So that's one thing. Always keep your left hand free in such cases. Go and catch hold of the vessel first. Then you can call for help, but at least catch hold because this is coming from the volume, and the patient will suddenly go for it. Now, always take care of your instruments, please. Please take care of your instruments. It's very, very important because you can see if there is an insulation defect. Can you see that? Can you see here what is happening here now?
Yeah, that's electrical, current actually leaking through different. It's the monopolar.
So you have to be very careful taking care of the monopolars if you are using monopolar energy sources in laparoscopy.
So does translumination help you to avoid these vessel injuries?
This is a superficial way, nothing to do much. You have to see, if you have to see, you have to see the inferior epigastric artery. So not to worry about this.
Normally, only in very thin patients it can be seen in translumination, otherwise normally it is not seen in translumination.
So this is about, bladder injury now. Again, how common do you find bladder injury in your
How many have injured bladder?
Yeah, I have done at least couple.
Bus? You are all very good surgeons, sir. You are all very, very good surgeons. But I feel I have experienced surgeons because experience comes with complications.
You did more volume, that's why the ratio is right. I did less volume, that's my complication. Number is less. This way it happens, sir.
No, sir. Sometimes if you are very good in anatomy and sometimes few surgeons their sense is much better than others. That is true.
First is definitely the identifying anatomy is the best part. But sometimes the pathology can be so dangerous, then treacherous. In fact, in some cases, it can be so elusive. It feels like it cannot be the bladder, but you ended up cutting the bladder. So that's why. So it can be sometimes very elusive.
What are the situations where you expect bladder injury more?
Yeah, this is the other day I didn't injure, but did some muscle cut. It was a case of cesarean scar pregnancy. If you have a diagnosis of cesarean scar pregnancy, and if she is a lean, thin lady and had 1 or 2 cesarean section, you expecting a ventrofixed uterus. And ventrofixed uterus with cesarean scar pregnancy, the bladder is like, it's a solid thing.
It's
like
infiltrated. It's always a problem. So basically, yes, sir.
Before going for the bladder complication, the anticipation of problem by clinical examination is very, very important. Yes. If you are putting a speculum to the vagina, if the cervix is in a case of previous year's uterus, if the cervix is pulled upwards, then you prepare yourself that you are going to have a very good bladder on that day. And specifically in case of previous years or previous section bladder, the lateral approach is the best approach. And even with the lateral approach, if you go in the proper plane with the seizure, Uttamekars are doing, but with the cesarean it is good. Using harmonic is the best tool, but overconfidence on the harmonic also is dangerous.
I somehow have this habit of people reading your mind, sir. So I will just show you what happened here. You see on this side now, as you rightly taught me, I am doing this. Harmonic, badhiya I'm using the harmonic very well. But please understand the basics of surgery which our parents or teachers have taught us. It is again traction and counter traction. You just see my left hand, there is no traction. You just see the uterus, there is no traction. And I'm confidently doing this surgery. And harmonic I'm using so well, so very nicely. And I'm opening the bladder so nicely. You see that? So this is where I say you have to know your limitation. But what is more important is doing a complication is not important. You learn immediately. You just see what I did after that. See now, I did a mistake. I have given good traction. See my left hand now. You learn. When you fall now, it's okay. You get up, but don't fall again. Now you see, very good traction with the left hand. Very well I'm pushing the bladder. Very well I'm getting the plates. Now this is important. you do a mistake, it's okay, but you learn from the mistake, the same case. So initially you saw my overconfidence, now you see my underconfidence also. So that is very, very important. So understand this.
I would just like to interrupt. We have Dr. Subhash Mal is overconfident to catch his flight. So he has a flight at 7 o'clock. Dr.
Happy journey. Happy journey.
With this, we're just going to give him a medal and continue with the panel discussion.
Yes, so what are suppose you are suspecting bladder injury, which is not clearly seen. Maybe you have, the wall is split, and how you are going to detect, how you are going to suspect bladder injury?
Paste is methylene blue, I think. Because when suspected something, always distend the bladder and check the leak. That is the best thing. And I have never done a Follies. During surgery, I have never put a Follies. So many people during conference, they ask me why you are not, from the beginning of the surgery, you are not putting a Follies. But during surgery, if my bladder is full, I am happy that at least I have not injured the ureter and bladder. That's why I have never put.
You are always different. That way, no sense in mistakes. Thank you. That is, there are surgeons who prefer to distend the bladder so that they know the limit of the bladder and they can dissect it better.
Without Follies, I have never done surgery. With Follies, I have.
Okay.
And if you give a Follies, thing is that you can see the air inside the ureter.
Yes. So that is something we saw in the previous slide, that this is a pneumo bag. The uro bag gets distended with air, and there where you suspect that there is some injury in the bladder.
And one can see the reddish color of urine also, I think.
Yes, that's also.
Sir, suppose you injured, yes, blood, if the opening is good enough to allow the blood, sometimes you see the blood stain urine. Sir, would you like to repair on your own? Do you take help from the urologist?
Site of the injury of the bladder, size of the bladder.
Okay.
Site is.
Dr. Machi, sir, ask your input about this.
Now it has gone to laparoscopy also. In laparoscopy also, when you are putting a cutter, there is a chance of infecting the blood. Because sometimes you get maximum blood is they have an incomplete evacuation of the blood. Incomplete evacuation. You put after anesthesia, you put the catheter, you will get almost 2 to 300 of urine, particularly in certain cases. So sometimes there is without any primary surgery also, you will get the bladder adherent to the anterior abdominal wall. Anterior abdominal wall. Sometimes people that dissected, it is the peritoneal way to dissect it, but ultimately they cut the bladder within a bone. Or whenever we are doing laparoscopy, we are more cautious that there is a structure which are about to be injured. That must be the mind.
Yeah.
Otherwise, whatever surgery, whatever carefully you will do.
So complications are bound to happen sometimes.
Always, and you must anticipate and immediately you must diagnose and manage it then and there. Otherwise, you never say, even if there is no surgical anything else, if you are going, even putting the berries, you can go through the intestine, even if you are putting the proton.
Yes, you can injure the. Sir, how?
Yes.
So how you are going to manage to injure the bladder? You look at it.
That is the detection and early management and transport management is very important. Never hesitate to call me when I am after a huge university, I'm telling my own story. That I did a surgery around 10 p.m. at night. So huge address and I got the pelvic ligament above the abdominal wall, and there the ureter is intact.
So sir, very correctly said, if you take the help of urologist.
Yes. In our place, sir, there is one urologist, and even in no point of time, he is free enough to come and help. And as far as the surgeons are concerned, I feel we can do better suturing as far as the laparoscopic repair of the bladder is concerned. And we always prefer to repair by yourself.
I think all the guys will do that, but if you are in a multi-specialty hospital, make an urologist stand by your side just for medical legal reasons. All the bladder injuries heal. In case it doesn't, then.
One day what happened? I did the delays, I asked my assistant to deliver the.
Yes, very important. Sir, what
deliver the product.
Very true. You never
In that case, take the help of the uterus definitely. So it depends upon the site of the injury and size of the injury and medical care.
But very important is never tell your assistant or inexperienced people to do visual management.
This is also space.
And then when you are a surgeon, you confirm twice that this is a cervix. Sometimes some of the sisters staff they hold the vaginal wall and pull it.
And one another difficulty, sir. If you call a urologist, and most of the urologists they are not
Important is
conversant with
site of injury of bladder injury to look for the ureteric orifices before stitching it.
Yes.
And cystoscopy should be there inside the wound so that we can do a cystoscopy is very easy. Look for the
And we
ureteric.
can do cystoscopy with hysteroscopy.
Yeah, definitely. Can be done.
Dr. Harpreet, have you ever injured the ureter? Sorry. What are the risk factors?
I am not directly injured, but later on thermal injury, yes.
Okay.
So that was two cases, both were endometriosis. First one was the initial part of when I started laparoscopy, it was a stenting done, and I learned from that stenting should not be done. Because it had kept the ureter so stiff that dissection was being done, but I still could not know that I had dissected it. And the other case which I later retrospectively realized was a very simple case, few additions. But the manipulator end, who was sitting, she had completely deviated the uterus to one side. So then the ureter was pulled out. So these were cases, but anticipated ureter injury in case of endometriosis is the most
Very. And I think general manipulation is very, very crucial in doing a better surgery and avoiding complications. Would you like anyone who is using now ICG dye or infrared stains, do you find any benefit?
Yeah, in fact, in some case I had to, because this lady had a long-standing endometrioma, grade 4 endometriosis, now had deep ovarian abscess. That means abscess in endometrium. So she been through all the antibiotics like meropenem for long. The CRP is not coming down, so we ultimately decided to operate on her. And she's a fat lady. She had PTS two-season section, and I'm quite expecting that visualizing and ureterolysis is a big challenge for that lady, because she already had inflammation, already had previous surgeries, and big fat lady. So that's why we actually called for the other system, that because ICG system was not there. So we actually called for ICG system. We infiltrated ICG. Even after infiltration with ICG, we used to take for every ureter to identify at least 10 minutes to 15 minutes to identify at the pelvic brain. So that was that.
I think ICG and
I had 1688, that striker one.
Yeah, 1688 is actually compatible with ICG.
Yeah, compatible.
People have
That
come
patient has hydronephrosis with endometriosis on the right side. For that case, I think I have used, but very important is to remember that because the flow will be very thin and the ureteric tissue will be very thick around that flow. So that must also.
I think it saves a lot of time in identifying, and sometimes unnecessarily you dazzle the ureter that is the advantage. So we are almost at the end, and what is conversion to open surgery should not be considered a defeat. Whenever you feel like laparoscopy has limitations, you can convert to open surgery. So open once, then open many times. Once you land up in complications, you land up in once colostomy is then subsequent closure. And technology, however, has advantages, but they have limitations also. So we have to. The surgeon is the man behind the machine, and I think. What is more important is do surgeries only when it is indicated. We land up in more complications when it is you do unindicated surgeries, and proper training is mandatory for people if you are doing advanced surgery. Knowledge of anatomy is more important than to be previously I said you have to master of open surgery before starting laparoscopy. I think now you have to be a master of anatomy before you become a good laparoscopic surgeon. And it's always a teamwork, and explain all possible complications to your patients. In the initial days probably I was explaining less. Now I explain everything to them. Everything can happen even if without surgeries, without expected complications. Then they will take their decisions. And thank you very much for your patience here.
Sir, I want to say a few words. Laparoscopic surgery needs skill and we all have faced complications, but we must not be scary, and interdepartmental cooperation is highly necessary to manage all the complications. And I think our panelists are experts, and we experts have learned a lot from our panelists. Thank you.
Of course. Just one message to all the gynecologists who are doing the laparoscopic surgeries. Before doing laparoscopic surgery, gynecological laparoscopic surgery, we must be well versed with the surgery. Because unless you have the talent and techniques of doing the surgery, you will be depending on the urologist, the gastroenterologist, and the general surgeon for repairing the bowels and the bladders. So just making the injury to the bowel, you should not be in a hasty. You can repair yourself. Bladder injury is too easy to repair. Even the ureteric injuries. If there is an incomplete ureteric injury, just learn how to put a stent. It is very, very easy. If you have this operative stethoscope, you can put a stent in the ureter.
Yes, I think
don't
that
be
is
panic. Don't be panic.
Yes.
Yes.
And see, we have to master our basic surgeries because there are new diseases coming like isthmocele, like scarectomy, with all these advanced, all cesarean deliveries. I think probably 10 years, 20 years from now, there will be no normal pregnancy, no normal delivery. You can expect the complications more. Thank you very much for your
With that, since this is the last one, we're going to felicitate our panelists and the moderators. Can I request Dr. Lucy Das to please join us along with Dr. Sajid sir to felicitate our...
So I'm very much grateful to PC sir.
Check.
And Sujit, they really have to put a great effort to actually organize this PRACHEECON. I'm really grateful. Thank you, sir.
Also, just letting everybody know, in the next 30 minutes, we're going to be getting started with the cultural program. And if you do not believe me, Dr. Harpreet Kaur is already on the stage. She might start dancing right away. 6:30 is what we would like everybody to be here. The first person to come here is going to get a special gift, a big hug from Dr. P.C. Mahabatra. And at the same time, we're also going to be starting the dinner early. So please do not leave. We would like all of you to please stay back. And even if you are not hungry, make sure that the person next to you eats well. Thank you so much. Can I request Dr. P.C. Mahapatra sir also to join in for a photograph along with Dr. Bhagyalakshmi Nayak ma'am. Photographs are important and everybody likes to take a picture with sir.